conference. We have an array of speakers with us today. In the main arena itself, we are having 7 talks, 7 scientific deliberations. So I urge you people to please see and take the most advantage of all the talks. Please see to it whichever topics is according to you. We are running in the parallel halls as well. We are having 5 places where the talks are running. One is the main arena, and there are 4 gallery halls in the opposite building in the COPS. So please look at the program schedule. Whatever is as per your knowledge domain or interest, you please see where you belong to and go and participate in that particular talk. So in this main arena, we are going to have 7 sessions, 6 in the morning and 1 in the afternoon, followed by valedictory. So I request everybody who is standing back to be seated. Please take your seats. Let's maintain a scientific decorum over here. All the participants, please take your seats a little faster. Okay, so to begin the first session of the second day of this conference, we have among us Dr. S.J. Nalini, who is the Professor and Principal, Faculty of Nursing, Shri Ramchandra Institute of Higher Education and Research, Chennai. So I welcome ma'am, and this session will be chaired by Dr. Jacinta R. Mariappa, who is a Principal, New Royal College of Nursing, East Point Group of Institutions, Bengaluru. Welcome you ma'am, and I request you to please come and take your chair on the dais. So this is Dr. Jacinta R. Mariappa who will be chairing the session. Welcome you ma'am to the conference, and I request you to please introduce the speaker of this session.
Hello. A very good morning to one and all gathered here, the luminaries. I'm honored today to be the chairperson for this session, which is dealt by Dr. Nalini. Dr. S.J. Nalini is a renowned figure in the field of nursing sciences. Madam brings over 30 years of extensive experience spanning the clinical nursing, education, research, and leadership points. She has presented more than 194 papers, published about 71 research articles, and authored 2 books in nursing. Her collaborative research on the terminal suffering among hospitalized South Asians, earned 3 bursary traveler grant awards from the Palliative Care Congress in the UK. She is on the editorial boards of the Journal of the Advanced Nursing and the Journal of Clinical Nursing, UK. She was nominated by the Governor of Tamil Nadu to the Executive Committee of St. John's Ambulance Association and as Chief Expert for preparing a common transcript for undergraduate nursing programs in the state. In 2024, she was honored with the SRIHER Mentoring the Excellence Award, highlighting her contributions to the nursing mentorship and curriculum reform. It's a honor and pride for us today to have such an eminent personality amongst us. Welcome you, madam, and we are very delighted to learn from you about the advanced nursing practices which make use of simulation and other equipments in the field of nursing sciences.
Thank you, Dr. Desenza. A warm good morning to one and all. I bring the warm greetings from Shri Ramchandra Institute of Higher Education and Research to one and all, and my deep appreciation to the organizers of this great international conference, ICTHS 2025, which is nice to, it's nice to know about 1,400 delegates who have gathered here to learn about the transformation and translation and use of technology in the healthcare professionals. So it's very important as teachers of today, we have to be so different in taking care of the younger generation. So I can't be a teacher like how my teacher was and how he taught to me. So I have to be different because education is not just learning about facts, but training the mind to think. So these are the words which has been proposed by Albert Einstein, and we have to change to meet the needs and demands of the Gen Z who we face every day, who are more sensitive, they are interactive, they are tech savvy. So a teacher of today has to meet this challenge to create innovative aspects or methodologies in education. And this is what we call it as a curriculum revolution that is happening. We have moved from traditional to a revolutionized curriculum where we have introduced lots of newer pedagogies so that there is what you call it as preparing a nurse who is able to think like a nurse. So you are a professional and you need to have something called as critical thinking capabilities, and the pedagogies that we offer to them should infuse the concept of lifelong learning in a student so that you are able to prepare a better professional who is ready to meet the demands of the future. So with this concept, I move to today's discussion on advancing nursing practice through simulation and technology, which is in fact empowering educators to transform learning. So these are the objectives for the day. So what is this simulation? It is nothing but a series of events or activities that is either potential or actual that is happening in everyday practice, either in education or in the clinical practice settings in our field. Now these activities gradually helps a student to develop the knowledge, skills and attitude. Not only development, it helps them to analyze, and they are able to respond to the realistic situations that is happening in that simulated environment, or what you call it as created environment. So what is more important, as I told you before, we as educators are supposed to create opportunities for the learners. Now how do we create those opportunities? It's more important that we try to keep our students engaged so that in the learning methodologies, they are not just participants, they should be participants but not observers. The next thing is, whatever we offer should be motivating them, and you should give them opportunity to have a situational flow through which they are able to get a feedback what they are doing is correct or not. And then we should be able to create situation that helps them to meet the learning competencies or the set learning outcomes. And then, most important, every student should feel empowered in the way we give methodologies, because it should not make him think we're just doing something, but it should be something real learning that happens with every aspect or event that we provide in the curriculum system in our colleges. So this is what Edgar Cone of experience has actually taught us. Now Edgar tells that whatever methods and media that we use, it varies. The impact what it gives varies. So certain things which helps us to only read and write actually gives only 10 to 20% of learning experiences or activities that it is proposed to meet. Whereas certain activities like simulation will help you to achieve 90% of the students' expectations, and their learning needs and requirements is met with whatever you offer through activities like simulation. So, simulation and technology, how does it help nursing education? The first thing, a student is able to practice number of times in this risk-free environment. He is able to come across in the future real world, and he can make so many errors. There's no problem at all. Now you make errors, tomorrow you should not make errors. That is what is very important with this practice of simulation. There's learner engagement that is taking place. The learner becomes so interactive. He becomes immersed with whatever is happening with the situation. And we provide a lot of safety. We are able to incorporate the evidence-based practices, and patient safety is taken care for the future. And the student is able to develop skills, competence, and you are able to prepare ready people for tomorrow. And most important, with this methodology, we are able to even contact those students who are in the remote arena and make them better practitioners for tomorrow. Now, there are different simulation modalities. It starts from the simple task trainers that we give, like an IV arm that we have, or a simple airway, or a centerline board that we always keep for the students, or a CPR mannequin or a torso which we keep for the students. And then we have human patient simulators, like a full body mannequins that we give them. It can be either an adult or a baby or a newborn. And then we also have extended reality, where we have incorporated virtual reality and augmented reality in the system. So we have highly emphasized technology that is incorporated in the system. And apart from that, we also have the standardized patients who act or role play the scenarios for us as taking up a particular character that has been given to them. And then we also have screen-based simulation, where especially you can see in anatomy and physiology classes, we are now having softwares to deliver the problem-based learning methodologies. And then we also have the hybrid, where we try to incorporate, say, for example, a standardized patient along with a task trainer. So multiple aspects or modalities are possible, but the levels of fidelity do vary. So what is this fidelity? It is actually the degree of reality that we have in our simulator. So our simulators, what we use, can be a low-tech simulator, or it can be a high-fidelity simulator. Now today the concept of fidelity is getting changed to either being low-tech or high-tech. So low-tech tries to give you more knowledge. You can practice as many number of times if you want. Like for example, the simple one what we use is a CPR torso, the human torso what we give for the students to practice, or an IV arm which we give for the students to practice to insert an IV line. A mid-fidelity simulator in fact is little more realistic compared to the low-tech ones, where you have a full body mannequin which really imitates the breathing sounds, or the little bit the up and down movement of the chest is seen. And the high fidelity ones are in fact more authorized, more computerized in nature, and can depict a scenario in a more realistic manner. So Miller's pyramid, Miller is a very famous psychologist who was actually dealing with cognitive psychologists, and he told us actually how we transform our knowledge. From the classroom teaching what we have, we gain knowledge, and then you go one step higher to understand what knowledge you had. You go in for developing your competence, and then when you get into the performance-based activities that you do, you go to the next level of showing things, and then in the real world, you are able to enact or create these activities, and that is what is very important, where we are supposed to provide our students with those increased level of simulation fidelities so that they are able to come up to that level of action when they become the true professionals for tomorrow. So here you can see that the skill acquisition goes across the period of years. So if we have a course across 4 years, we give lots of low fidelity in the initial learning, where we try to make them learn the basic or the generic learning skills, and then as they go on, we go in for higher learning methods or use high fidelity techniques, where a student is able to really think what she's supposed to do. For example, you have a postpartum hemorrhage that is happening, and how I am supposed to react as a nurse in a situation is something that we have to use high fidelity techniques, and this has to be taught with the higher levels of education as the student come across. It is not that we have to stick only to low or high in different levels, but whatever has been given to the student has to be perfectly utilized to achieve the set objectives. Now there are different types of fidelity that is there, which we are supposed to discuss a little bit here. Now there's what you call it as equipment fidelity, where the student should feel that he's using something which is more realistic, like the skin of the patient. How real it is, what you provide makes a lot of difference. And then comes the environment's fidelity. Even if you're going to have a high-tech simulator and you're just going to keep it in the corner of the classroom, it will not give that environment fidelity. It doesn't look like a ward or an ICU setting. So it is important to give that environment fidelity, where the student tries to put inside his mind and tries to create or keep his mind accept that I am inside a ward or I am inside a theater or an OT theater. The next important thing is psychological fidelity. Our students actually don't come forward and they are really frightened when they are supposed to do activities like simulation. So you have to keep them understand or make them understand that you are performing in a safe environment, and whatever you do will not go out of this room, and you can make errors. This is meant for making errors and learning, and that confidence has to be given to the learner. And most important, the scenarios what we prepare has to be so convincing, and it should be related to life activities that is happening in real world experiences. So that will make that concept for a student to understand what he is learning through simulation is something very, very important, which he carries along in his real world for the future. So these are some of the pictures. Actually, we had an opportunity to go in for a faculty exchange program last year in 2024, when we had an opportunity to be in the University of Hull. So there we got an experience of how Hull University in UK offers a lot of simulation-based modalities for the students, starting from a simple CPR simulation to the advanced one. What you can see here, a complete, operation theater setup that is there, ward setups. It can be a neonatal ward or an adult ICU ward. So every setup is provided, and we were, so happy to learn this simulation environment is not available only in the university or the college. It is also available in the same manner in the hospitals. So what has been taught as simulation modalities is even carried, and it is being reinforced again and again for all the clinical professionals over there, so that it goes on. There is what you call it as learning that occurs continuously, and this is what is the experience we got in University of Hull. So it's more important to understand that this simulation helps us to bridge the theory and practice, and we are able to get the foundational knowledge, where we move on into the simulation-based practice in the laboratory settings, and then we gain the clinical competence, so that we are able to really make decisions in the clinical settings. Now there are a few key elements that we are supposed to have in a simulation-based education. The first and foremost, we need to have teachers. The academic people are very, very important, and they should be people who train us in this simulation. And it's very nice and good to have actually people who are certified in this simulation technology and techniques, and it's better to have faculty trained in or certificate courses that are available. They can get trained in this use of this simulation. And then what is required is complete planning. You need to have the program scheduled. You should have planned how it has to go on, then implement and evaluate what is being given. And the last one is you need to have resources. The resources, you need to have the simulators, you need to have all the equipment, tools are required. So if all these are there, then effective learning is possible. So there are few best practices that is really happening in simulation that facilitates effective learning. First and foremost is the preparation that we give to the students. So we make the students to understand the clear objectives, and we make them understand what is the scenario, where it is taking place. A good pre-briefing is given which prepares the student to go in for this technique. And then we also create or emphasize on psychological safety, where we have a non-judgmental environment, and it is not a place to point out to the student what you do is utterly wrong. It's not like that we try to emphasize. We make it more convenient to have two-way communication, and that psychological safety definitely ensures a student to make it possible, and he has that confidence. Even if I make errors, it's not a big issue. Then followed by the enactment of the scenario, there's what you call it as debriefing that happens, where the students reflects on what has he done during the session, how he has actually performed during the scenario, and you get a constructive feedback. And most important, there's also self-assessment that is possible. What is that I have done, why I have done, and why I should not do is something that he realizes, and this goes on to support the entire learning systems of the future. Now, what are those problems that we face when we are trying to incorporate this simulation-based learning? Most important is time factor, and we find our syllabus is too much loaded, and we have to really do need analysis, which are those areas which requires a simulation, and definitely we need resources. And we should always think that whatever simulation, what we give is in fact a supplement, and it is never going to replace the clinical learning what the students get. So there should be a balance between what you offer in the clinical area and what you give in the simulated learning environment in your laboratories. And then whether we have always this confusion, should I go for the high fidelity or the low fidelity? That problem always occurs. And sometimes we find lack of consultation. Even if I want to ask somebody, I don't find an apt consultant person who can clear all my queries. And sometimes we have lots of problems in selecting the best of the simulation model, and though we give or offer simulation, how much we are trying to use them for feedback is a big question. So it's important that we try to get or gather a lot of feedback from all our stakeholders, which includes our students, faculty, and the staff. So we need to dispel certain myths which normally exist among academicians related to simulation. The first and foremost, we always think all the simulators are high-tech, and there is a lot of money that has to be pumped in order to buy the simulators. It is not so. There are lots of small low-tech simulators that are available, which you can give great amount of learning can be given. So it is in fact scalable. It moves from high to low, and you can use or improvise. Even the small low-tech simulators can be improvised in order to give the high-tech opportunities for your student. And then, as I said, it is more, the simulation is supplementing your learning. It is not a compensation for the clinical atmosphere or the clinical learning what we are going to provide for the students. And as much as possible, they should be what you call it as realistic scenarios that is being given for the student, and the student should feel the benefit when he's doing the simulation. It is something he has to feel that inclusivity in there, and it's important we have to use user-friendly technology. If these are being used, your simulation is going to be the best opportunity given to the students to learn. And there are lots of high fidelity. High fidelities are in fact something which mimics the real world scenarios, and they also give immersive experience for the students, where the students thinks that he is in a ward rather than in a classroom where he is standing, and it enables them to critically think and also gain technical knowledge with the skills, and he is able to take better decision making in a controlled setting. Now there are lots of ample opportunities that is growing today to integrate technology inside the simulation. So we can incorporate the learning management systems we have in our universities to in fact structure the courses or use the simulation and also go in for a progressive tracking. And we can use this upcoming virtual simulations that actually provide better learning opportunities for the students, and the skill, the number of times he can perform the same skill is better, and it is actually, he gets the feel of learning in a ward. And we can also use the electronic health records, which helps in maximum amount of correct documentation that is done by the student. And we can also use the telehealth modules by which the students are able to remotely connect with academicians and also enact the scenarios. And a lot of mobile learning apps are also available, which helps the student to learn anytime, anywhere. So this sort of education is possible today, and remote mentoring is possible. So I remember when we had an opportunity to get trained in one of the state simulation activity that we had in Tamil Nadu. Apollo Simulation Center was one of the area which we're trying to train our faculty and all the teachers across Tamil Nadu. So there they continued this follow-up by means of remote mentoring through this platform of remote mentoring, and we had a lot of sessions where what was happening in Ramchandra was visualized in Apollo Simulation Center, and they were able to give us feedback. So it's going to be the future. The virtual and the remote simulation is going to build the bridges, and it is going to provide clinical experience. I still remember in the medical colleges we used to have cadaver, where students used to practice on a dead body. Today this concept has gone. So we don't know how it is going to be tomorrow. We have lots of students coming inside, and it's time we have to go in for virtual modalities of using this remote and virtual simulation to train our students. So with the immersive learning, we are moving in from the traditional learning model where students can replicate or practice number of times. You get what you call it as immersive practice, and it is safe practice setting, so the skill learning is much better, and you are able to make your students to think critically in rare scenarios, and you are able to produce nurses who are becoming ready in order to face the real life world of tomorrow and become competent also. So these are some of the immersive learning where VR is being used, where they have avatars being created, and it tries to move within the control setting in order to give you opportunity to practice. Now this is something which we did during the time of COVID, and that's the time we got connected to this virtual simulation, where we tried to connect with Ladril India, and they were able to support with lot of virtual simulation opportunities for our students and our nurses and our faculty. So this was one of the scenario that we used, where we taught them on how to do a CPR for a COVID patient using this virtual simulation technique. And you can, using this AI which is coming up and going big boom that is happening with the AI today, we can transform nursing with the use of it. AI will help us to take better decisions in the clinical area. It is going to help us with documentation, and it is also going to give us a predictive identification through its analytics by identifying which are those areas where the student is actually making a error or a risk, or which are those areas which we are supposed to improve, and we are able to adapt it for the student's need. And as each of our student is different, we can utilize AI which can take care of each of the students' needs. So every student is considered to be unique. So AI makes this possible to teach every student in a different manner, and simulation and virtual patients incorporated with AI is going to be the future, and we can do a lot of assessment and feedback. A real-time feedback is also possible with this system. So the Indian Nursing Council, in fact, has brought in a good simulation center. I think many of our faculties have undergone training in this National Reference Simulation Center that is situated in near to New Delhi in a university called as SGT University. So they have trained, and it's important what training our faculty have got from these areas has to get transformed to all the other faculty members who are there in our colleges. And the latest thing that is picking up is interprofessional simulation education. Now we are all working in a scenario where it is always teamwork. So we don't work in silos as a nurse or a doctor or a physiotherapist. So we all have to work in a coordinating manner. For this aspect today, the interprofessional simulation is gaining its ground in our country. So it's time we have to incorporate this concept of interprofessional simulation, where you have students from different specialities enacting the scenario and they play their role. So instead of a nurse playing a doctor role, physiotherapist, it will become a nurse doing a nurse's role and a doctor doing a doctor's role. So that definitely helps each other to understand and also respect each other's boundaries of doing the professional activity. Now what does literature tell us, what does research tell us is something that we have to understand also. So use of simulation in nursing education, they did a cross-sectional inter-university study which gave us information that though clinical simulation is something that is incorporated in the syllabus, you can see that there are variations across universities where the number of hours that is given for simulation varies. There are some universities, they just give about 24 hours, and there are universities that they can go up to even 516 hours. So there are variations. So this tells that whatever experiences given to the students are not the same across the various learning centers. But there is a lot of impact on the simulation training because the patient safety risks are reduced. The accidents or the incidents that are created related to the patient safety definitely reduces with the use of simulation. The learning satisfaction is very, very high with simulation, and skill acquisition also has improved to 85% post-simulation activities in a study that was done. Now, what is the effect of high fidelity? Now, high fidelity, they say, is something which really improves the students' ability to clinically judge a situation, and it also helps them to really recreate that real world scenario. So this is what the study has shown, that clinical judgment is much better and it is significantly high after using simulation with high fidelity mannequins. So what is the impact of the simulation based learning? So they have found out through this quasi-experimental study that was conducted among 177 students, and they found that students' competencies, skill competencies improved, the confidence levels were very high with the students, and they were able to perform better, and the satisfaction of the students also improved with this use of this methodology. So if we are supposed to have effective simulation integration in our curriculum, what is required? The first and foremost, we need to have a needs assessment that is being done. We need to train our faculty, which is very, very important. If we don't train our faculty, then it's no use having a big lab in our university or the college. And then we have to deliver all the simulation sessions. And in fact, I should be pointing out here, our Tamil Nadu Nurses and Midwives Council has now taken the next step, where they have also given the simulation training, and now we are in the process of preparing simulation scenarios that becomes commonly used for almost every college. So we are in the process of preparing this simulation scenarios, ready reckoners which can be utilized by faculty members. A lot of resources are required, and every college management should think about allocating the perfect resources, and we have to design curriculum in such a way ample amount of adequate hours has to be given for simulation training. And what's more important is getting the feedback, evaluating the use of the technique, which is definitely having a improvement and bringing out the competencies or not. So simulation is something which definitely helps us to rehearse as a team, especially the interprofessional simulation, and it helps to bring about the collaborative practice, and it builds the trust if you are going with your simulation. So how you can integrate the feedback. You can use standardized rubrics or a rating scale to judge the performance of the students when they are in a simulation experience. And you can also have a reflective journal where the student writes what he has actually experienced. Reflective journaling is very good, which helps them to critically analyze and think on what they have done. There are a lot of competency checklists also which you can use to identify whatever perfection they have achieved with the competency. And finally, you can customize to identify how much of the effect or the impact the learning experience the students were able to experience with your simulation. And then you can also, you can create individualized learning plans and progress with the feedbacks which you have obtained from your students. Now, there are few key barriers that we are supposed to address. One is a lot of constraints that will happen with the softwares. Faculty resistance is something that we face. Technical issues, and sometimes you have good simulators that is not being used because of the technical issues. Time constraints is something that is largely limiting us from using this technique to a greatest extent in our learning field. And maintaining learner engagement for a teacher is challenging with this system, and we need to have a lot of support from the administration, and we need to have ongoing faculty development programs. It is not that once I train my faculty, that's it, and you have to learn everything. It has to be ongoing, and we need to have a lot of pilot programs, and you need to create partnerships with people who have good institutions which have simulation arenas, and you can also send your students to those places to learn, and we have to have continuous evaluation and feedback. So these are certain simulation activities that we took up in Shri. In fact, we brought in a simulation workshop which we organized at a national level conference along with the Lateral Medical India in 2020, where we trained all our faculties. And one of the papers which we produced from this, it went on not only for, it went on to get published in BNJ Simulation and Technology. And this workshop created us to take up simulation activities in our college even before the incorporation of the syllabus by Indian Nursing Council. And this is the latest one. These are the pictures of the latest workshop that we conducted in collaboration with ASPE, an international organization, Association of Simulated Practice in Healthcare. So there was a workshop that we had for titled In Situ Simulation. So simulation, it's not meant that you need to have a lab or a separate space. You can even do it in your hospital. This is the concept we try to bring through this in situ simulation. And the other initiative, we had a big conference where we had more than 400 members joining us in this simulation activity with Association of Simulated Practice, along with the Tamil Nadu Nurses and Midwives Council, who partnered us to conduct this international healthcare simulation workshop just about few months back in our place in August 2025. And these are some of the pictures you see. And you can see one of my student, a scholar, PhD scholar, who's trying to do a virtual simulation using an innovative infection prevention control. So this is a virtual avatar that has been created, very useful both for the students and the staff nurses who are working in our hospitals to use this to make the environment more infection free. In fact, when I used it, I felt I was becoming like a small child playing the game. And if you are interested, you can scan this QR code and contact her for further, access to you as well as to your students and your nurses in the hospital. So these are some of the pictures that I have posted here, how we try to train. Being an obstetrician and gynecology nursing specialist, we do a lot of activities related to suturing. So I have my teacher who is sitting there, Dr. Urmila, who is going to become Dr. Urmila, now currently Miss Urmila. So she is training our students, even using the chicken breast to train the suturing. So this is how we used as much as possible the real concepts in our labs to train our students. So this is another initiative that Shri has taken up, where we have introduced virtual reality, partnering with an agency called as Medicine. So our students are sensitized with virtual reality, and so many scenarios which is not possible in an everyday aspect in the hospital is now being offered through this virtual simulation. So as teachers, It's important that we become exceptional teachers who are able to inspire, and enthusiasm is something, the father of excellence, and I hope we will be utilizing this concept of simulation to the best of its nature to help our students to become ready for the future. Thanks for the opportunity once again. Thank you.
Thank you very much, Madam, for elaborating on the advanced nursing and simulation and throwing light on the simulation techniques. I just wanted to ask you, how far this simulation technique can be accredited, and what is the role of our apex bodies?
Yeah, accreditation of simulation centers are now possible. Very recently with this workshop, what we had, the ASPE workshop, we understood that in India there are now 3 centers which are accredited. One is, I know very clearly, is Apollo Simulation Center, and then there was also D.Y. Patel which had its accreditation. So all of them, they made me understand that for getting this accreditation from an international agency like ASPE, it is not required that you should have an exotic high-tech facility lab. It is not required. What is required is you have to follow the standards, what has been said by them. So if you follow the standards, and you can use your low-tech and medium-tech simulators in order to get this accreditation. So it is not only ASPE. I know that there is something called as INACSL, that is International Accrediting Agency with US, which tries to give clinical simulation. I know Sultan Qaboos has got this simulation accreditation. And there is also in US something called a Society of Simulation. So whichever you want, you can write to them and you can get some support and help in order to accredit your labs. So that is one. And I learned from my scholar also yesterday that even individuals, even me, I can undergo the training and get certification from these agencies that I am a certified simulator who can train others, and I get an accreditation. So personal accreditation, person-based accreditation is also possible in simulation.
Madam, thank you so much. I would like to, highlight, request you to highlight for the present day generation, our students, as they have seen a transformation in every aspect of the health sciences. What would be the take-home message for this younger generation, specifically in handling the simulation techniques at the lab scenarios?
Yeah, I should really tell the students how important to get that practice in the simulated labs. Please understand and respect the time that your teachers have spent in creating scenarios for you, not only creating the hard work your management, the entire team of faculty are taking in order to make you learn through different methodologies. So respect the time and value their input that they have given. And most important, India needs nurses and good healthcare professionals. So it is not possible to give every practice opportunity in the hospital, and we are growing. The number of students who are coming to us are now expanding, and we have to understand that scenario, that we have to utilize those opportunities that are given in this simulation labs and use them to the best of ability. And most important, this labs, I feel, is something that should not be restricted to the time zones. It should be open for students to practice any time they want. So if we open up for them, I think they will definitely reciprocate, because students are always, we learn a lot from the students. So if we give them opportunities, they will definitely take up in a better manner.
Thank you, madam. Thank you so much for highlighting. And you have been a real eye-opener. You have culminated both the virtual reality with simulation, the real scenarios in a day-to-day life, what a student could experience in the clinical setting. And at the outside, I thank the organizers, the Dayananda Sagar University, for giving us the opportunity, for me, the opportunity to chair this session, And thank you very much, Madam, for the elaborative session once again.
Thank you so much, ma'am. Nalini ma'am is asking any question from the audience if it is there. You can come up with it now, or if you want to meet her in person, I think she's available for some time. Okay. Okay. Thank you so much. Thank you, Jacinta ma'am, also for chairing the session. So, as a token of appreciation and thanks to both of you, I'd request our Dean, School of Health Sciences, Dr. Pushpa Sarkar, to kindly come up and present with a token of thanks to Dr. Nalini for her insightful talks on the simulation in nursing. Ma'am, center stage, please. Thank you, ma'am. We would also like to extend our thanks to Dr. Jacinta for chairing the session. I request Dean ma'am to give a token of appreciation to Dr. Jacinta as well. Thank you, everyone. So to continue our session of the morning, we will have the next session of the day, which is by Dr. Valentine C. The title of the talk is From Evidence to Action, an Introduction to JBI and Systematic Reviews in Healthcare. To chair the session, I would like to call upon Dr. P. Senthil-Selvam. He is a professor in HOD, School of Physiotherapy, Wells Institute of Science, Technology and Advanced Studies, Chennai. Dr. P. Senthil-Selvam, kindly come and take up the stage and your chair. Namaste, sir. A very good morning to you. I would request the chair to kindly introduce the speaker of the day.
Thank you so much, madam. So, before chairing this session, I would like to express my gratitude of appreciation to the organizers. So, thank you so much for conducting this mega, a resourceful conference, which could be beneficiary for many of the students aspiring to become a researcher. So this conference will help them to give more sufficient knowledge and insightful information to equip themselves to become clinicians or researchers. So thanks to Dr. Satya ma'am, the principal of Physiotherapy Department, and her team for being a part of this organizing the conference. So with this, I would like to start my session. So I welcome Dr. Valentine C. Jones. So sir is a recognized leader in physical therapy, serving as professor at University of Santo Thomas and director of JBI Philippines, the Center for Health Research and Movement Science, and clinical data analyst at St. Luke's Medical Center. He was named 2024 Outstanding Professional in Physical Therapy by the Professional Regulation Commission of the Philippines and has received the most DOSTPC HRD Best Mentor Award. He is a passionate advocate of evidence-based healthcare. He is a member of JBI, NRCP and PPTA and actively an advanced researcher, a clinical innovator and mentoring in many pain management and rehabilitation in the Philippines. So with this welcome note, I invite Dr. Valentine to give a very informative presentation. Sir, the stage is yours.
Good morning, everyone. Namaste, India. I hope everyone is okay. I admire the Indian culture. You always wear your gown with pride, and that's why I decided to wear the Filipino modern version of a barong. Thank you. I'm a physiotherapist. Every time there was an instant wherein a patient, a student came into the clinic and she has severe low back pain. She was a gymnast. I knew for that particular instance that I needed to manipulate her sacroiliac joint. I asked her to lie on her back. I pulled her leg, and then lo and behold, that student came out walking without pain. I was confident that spinal manipulation will work on her because there is a moderate evidence to support its use. Spinal manipulation can relieve pain in the short term. I'd like to share with you this journey, the journey of using evidence-based techniques, evidence-informed practice, evidence-informed assessment using the JBI lens. Please allow me to introduce what JBI is. Okay, I'm just getting the clicker, and I'm timed. That's the JBI Adelaide. The JBI Adelaide is found in South Australia. It's the biggest research center, so to speak, when it comes to evidence-based healthcare. It's situated in the heart of the Adelaide city wherein I remembered when I was there back then in 2010 to 2013, every time my neurons are fried with research work, I just go to the Rundle Mall, because I'm a Filipino. We have that culture of mall, the mall culture. So I go to the Rundle Mall and then give myself some headspace, and then after that, I go back to the office and work again. It's a lovely city, and the JBI is actually a research organization under the Adelaide University. Oops. What is the mission of JBI? We are supporting and promoting evidence-based healthcare. We want our patients to use or to receive the best evidence in order for them to receive the best care that will help them solve their pain problems or their functional dysfunctions. In that way, the society becomes healthy and productive. That is what JBI hopes for. We are a leading global evidence-based healthcare research organization. We harness research, we teach research, we actively disseminate what we found, and JBI also has a software known as the JBI Summary. Okay? that will help us synthesize voluminous evidence. And our organization cuts across not just 40 plus countries, but over 90 countries worldwide. It is a big organization wherein we partner with the different experts in the world. What is our purpose? To improve health outcomes. How are we going to improve health outcomes? By synthesizing evidence and making sure that the stakeholders who are our patients will use the evidence that we've synthesized. Okay. Let me just go through those in the latter slide. This is a picture of the JBI collaboration centers. That is where the Philippines is. Is there a pointer? I'll just go there. That's where the Philippines is. The file has not been updated yet, but there are 2 JBI collaboration centers in the Philippines. And our center in the Philippines was the first JBI Philippines Center for Health Research and Movement Science. We are at the University of Santo Tomas. I'm proud to say that not because of the accreditation, but because of our mission and vision to better the healthcare delivery in our country back home, in the Philippines. That is our main purpose. That's why we are proud in presenting that we are part of the JBI collaborating entities. This is the University of Santo Tomas. I was actually with a very good professor, and I think it was 2 days ago when I was passing by this road and I saw the edifices of your building. I was really awed. It was really nice. It's majestic, and I love your school grounds. You have multiple buildings which are majestically standing on your grounds. We have one UST main building, okay, which also looks like a European in its, when you take a look at it. The University of Santo Tomas is actually in Manila, Philippines. The JBI Collaboration Center or entities gather together yearly. After visiting you, I'll fly to Kochi, India, and I will be able to meet the 90 plus directors from the JBI collaboration entities. It's a yearly activity that we are engaged in to ensure that we are updated on what we are doing. What is the main thing that we're doing? We create evidence synthesis hub, which is usually given to universities, wherein the academic professors, academic researchers will synthesize the evidence. Whatever we've synthesized, we transfer to our partner hospital. That is where we are ensured that the synthesized evidence is used and will be used by the patients themselves. That is how we complete the loop. I'll show you in further detail how we practically do that. We've got different activities. We've got the JBI systematic and scoping reviews, which are updated likewise. We've got implementation projects and case reports. There's the rapid evidence synthesis. There is mentorship from the JBI Adelaide. There is a clinical partnership engagement, and so forth and so on. The JBI Philippines CHRMS has grown in hips because of JBI Adelaide. It's not just a partnership, but it is a family relationship wherein we ask them to train us and they give support to that training. By now, we are at that point, the JBI Philippine CHRMS is at that point wherein our university provides synthesized evidence to our hospital. That will never happen unless JBI has take its place in our scenario. Let's talk about evidence-based healthcare. Who are physiotherapists here? Can you raise your hands? All right, so physiotherapists, we're of the same kind. Who are pharmacists here? I know there are heaps of pharmacists in here. Nurses? Oh, a lot of nurses. I salute you. The nurses, they know about what I'm talking about. It's about evidence synthesis and evidence implementation, and they've been using that back home in my country time and again because they want to improve healthcare delivery in their place. I'll give you a scenario. One of my patients came in and she has myofascial pain syndrome. Painful neck. That's the patient. She came in. I know that dry needling works. That's the best available evidence over there. It actually works. There is a moderate certainty of evidence that dry needling can deactivate trigger points and decrease the pain of patients with myofascial pain syndrome. Best available evidence. I am a physiotherapist. I am trained to do dry needling, and I can deliver the treatment to that patient. That's professional judgment. The circle that you see there, down below. Now, are we allowed to do dry needling back home? Are you allowed to do dry needling here in Bangalore? Yes, you are allowed. That's context. That is context. We are allowed to do dry needling back home. That's context. Those are the three circles that are ticked in that true clinical scenario. However, this is the gist. This is the ultimate decision maker. My patient doesn't like dry needling. She'll faint. So I did not do the dry needling on her, even though 3 of the 4 circles have been ticked. The patient's preference is always important. It's of primordial importance. Those 4 circles tell us what evidence-based healthcare is all about. It is multifaceted, and it actually evolves over time. JBI has the FAME approach. What is that FAME approach? F is for feasibility, A is for appropriateness, M is for meaningfulness, and E is for effectiveness. Now, let me just explain each in practical terms. Feasibility. What is feasibility? Who are working on diagnostic tools in further improving the diagnosis of liver cancer or hepatocellular carcinoma? Or that would be a bit complicated. Who works with patients with hepatocellular carcinoma or liver cancer? Can I see raise of hands? Can I see hands? Patients with liver cancer. Back home, liver cancer is the second most common cause of mortality. That is why our government is doing its best to ensure early detection of patients with hepatocellular carcinoma. Because we believe that early detection will provide early treatment that the patient will have a better chance of living. Currently, what the doctors use, I'm a physiotherapist, the hepatologists use is, what they use are ultrasound, biannual ultrasound. They screen patients for 2 times in a year. But there is another instrument that, or diagnostic tool that came into the picture, and we call that the AFP, or the alpha-fetoprotein, which increases the success of detecting hepatocellular carcinoma. In practical terms, if I'm going to use biannual ultrasound plus AFP, or biannual ultrasound plus alpha-fetoprotein, I'll be able to detect early stage hepatocellular carcinoma. That's good for the society. They become more productive. Now, the question is, I know this is also your question, the question of by the government, can the government afford it? Can the government afford it? That is what you call feasibility. Even though it's effective, but the government or the hospital cannot afford it, then it is not feasible. You still cannot use it. All right? So that is what feasibility is about in the parlance of JBI. What is appropriateness? Blood transfusion is magical, right? For those who need it, but those whose religion is Jehovah's Witness doesn't allow blood transfusion. That is what you call appropriateness. What may be appropriate to you may not be acceptable to other patients. We take that into consideration. Not all effective treatments are used by the society because of the question on appropriateness, meaningfulness. Who is doing palliative care here? For physiotherapists, are you engaged in palliative care? Yes, I see them nodding. And I know that for the nurses, who are involved in palliative care? I know probably some of you are shy. I know that some of you may be involved in palliative care. It is effective. However, there are issues back home, or not just back home, but internationally, on why it is still not being used in the hospital. And we got those through a systematic review, unrivaled those issues on why palliative care isn't existing in our setting. It's because of the hierarchical level of how the doctors will ask the PTs to treat their patients. We have that hierarchical system. And in our systematic review, we found out that it's one of the causes why palliative care is not existing in the mainstream treatment back home. How did we unravel that? Through a systematic review on qualitative study that determines the meaningfulness of an intervention. You see now the multifaceted role of the researchers? Your future role in case you will be interested in doing research. Effectiveness. This is what we know about. We kept on talking about effectiveness, and I think globally, everybody knows about effectiveness. All right? We do randomized controlled trial, pseudo-RCTs, quasi-RCTs, observational studies to determine the effectiveness of an intervention. That's pretty clear. But that is only a portion of the FAME approach by JBI. This is a JBI model. At the center, you see the pebble of knowledge. The pebble of knowledge which has the fame, feasible, appropriate, meaningful, and effective. The inner wedges show global health, evidence generation. Whoops. Evidence generation, evidence synthesis, evidence transfer, and evidence implementation. Let me run through these wedges. And the primary purpose of showing this is for us to realize that your primary research is just the start of evidence-based healthcare. It's not an end-all. Once you publish your research on primary studies, that is not an end-all. Why? Because the stakeholders, your patients, have not used it. The global health, that's the fame. This is the global health. In global health, we check for sustainable impact. Worldwide, not just back home, resources are limited. We ensure that, the government ensures that, whatever they fund should be beneficial and effective to their constituents. Why? Because resources are limited, right? How are we going to make that sustainable? That's an issue when it comes to global health. How are we going to engage the hospital leaders in implementing the research? That's part of global health initiative. How are we going to link you, intelligent academic researchers, to your hospital champions? That is engagement. And that may not be really happening. The university may be separate from the hospital. And it has to come clear. Evidence generation. This is where you do your research, your primary study. This is where you ask your professors, is this effective or not effective? That's expertise. We've got people who we know and ask them for their suggestions. And we believe them. That's part of expertise, and that's also part of evidence generation. Or we do focus group discussion. Discuss about a certain topic and see what fits best, or what is best for the patient. And that's what you call discourse. You generate evidence. That is part of evidence generation. Undergraduate students doing their thesis is evidence generation, especially if you're doing a randomized controlled trial. Evidence synthesis. Did COVID-19 struck hard in India? I found my purpose during the COVID-19 pandemic, while everyone was actually giving out PPE, personal protective equipment, what I was doing that time was synthesizing evidence for the government. The government needs, or needed us to synthesize voluminous data for them that will anchor their recommendation. That is what evidence synthesis is all about. You write evidence, and it is a skill. It is a skill. You write systematic review, evidence summary, which is a shorter version of a systematic review, and of course, you've got different societies. You've written clinical practice guidelines for those different societies. That's also evidence synthesis. Evidence synthesis is not an end-all. Evidence generation is also not an end-all. It is a wheel. Once you have synthesized the evidence, You need to transfer that evidence to who? To the champions in the hospitals, to the stakeholders, to your patients. And how do you do that? How do you do that? For the youngsters here, I'm not young anymore. I hope that I was young like you. But do you know, of course, of TikTok? Who knows TikTok? Oh, only few people are young here. Who knows Instagram? Now, a lot of younger people. You could actually actively disseminate your research evidence using those portals, not just your good-looking faces, all right, or the parties that you're engaged in. Disseminate the evidence that you found through TikTok or through Instagram. And of course, what are teachers for? We educate patients. We educate healthcare workers such as you. After the Kochi, I'll go to the Galgoshes University and teach their academic staff on how to do a scoping review. That is part of educating people on how to utilize these different types of reviews. And of course, systems integration, wherein evidence is actually placed into electronic medical health record. And it becomes synchronous with the hospital operation. This is where the big picture is, evidence implementation. And this is where the battle begins. Why? You found the treatment useful, but the champions in the hospitals do not mind. They never used it. Why? Because they don't have time to use it. Or because they believe in one medicine over the other medicine. That is where the battle begins. How are you going to integrate evidence into the local health system? That is what evidence implementation is all about. It is about facilitating change through champions, not only in the hospitals, but also in the university setting. It is about contextualizing the evidence. Possibly they're not using your intervention because no one knows how to use it. That's context. They've got evidence, you showed them the evidence, but they do not have the expertise. That's context analysis as well. 7 minutes more to go. That's a JBI model of evidence synthesis. It's a framework. It's a complete one. It's not just a concept. We are practically doing it back home through the support of JBI Adelaide. The last segment, systematic reviews. What are systematic reviews? In systematic review, we are writing the evidence considering that we've critically appraised them. You actually know that not all things that you see on the net has to be believed. You need to critically appraise the evidence. That is what we do in a systematic review. Whenever policymakers ask us to synthesize evidence, okay, we do a systematic review. We never do a scoping review. We never do a literature review. Why? Because in a scoping review and in a literature review, you do not critically appraise the papers. That's the major difference. I think any organization will tell you that critical appraisal is of primordial importance when you want to influence policy. What are the aims of this systematic review? Say, for example, I'm just making this up. Spinal manipulation in study A is more effective than spinal mobilization. But in study B, it says otherwise. Spinal mobilization is more effective than spinal manipulation. And study C tells another scenario wherein spinal manipulation's effectiveness is the same as spinal mobilization. The question is, who are you going to believe? There is a way to answer that. You pull the evidence through a systematic review. A systematic review will uncover international evidence, will investigate conflicting results. And if there is a gap in the literature, it will tell you on your face that there is a gap in the literature. A systematic review will tell you certainty of evidence. What does that mean? It only means that I could say with confidence that this intervention works and this intervention does not work through systematic review. Through a systematic review. Not a scoping review, nor a literature review. What are the differences between a literature review and a systematic review? Let's check. In a literature review, the authors will actually put or select articles that they deem support their hypothesis. Most likely, they will jettison those articles that do not support their assumption. That happens in a literature review, right? The method is actually not rigorous in a literature review compared to a systematic review. More often, there is no methodology in a literature review. And because of this, there are systematic errors that happen in a literature review. Why the systematic error? Because most likely a literature review will lean towards the author's beliefs. Remember this, a literature review could be published with just one author, but that you cannot publish a systematic review with just one author. It should be two or more, or you will not be able to publish a systematic review. You do not comprehensively search the databases in a literature review. It is unreproducible and not transparent. Now, what are the aspects found in a systematic review? You need to publish your protocol in a systematic review. More and more journals are not accepting a full-text systematic review without a published protocol. We need to check, we need to validate whether the authors have been reporting to what they should report. It's a structured research process that decreases or reduces biases. It involves checking 3 or more databases. It involves checking gray literature. We check clinicaltrials.gov, we check our libraries, we check ProQuest, okay, which house gray literature. And of course, the methods are transparent. They are reported. It's a formal type of research on its own. Let me point out to you the JBI Manual for Evidence Synthesis. If you want to write a systematic review, the JBI Manual for Evidence Synthesis is a wealth of information. It is for free. And we've been using that in helping our students, undergraduate students, write systematic reviews. Okay? In addition, of course, to the training that we provide them. So we've got the JBI Manual for Evidence Synthesis. You could also opt for the Cochrane Handbook or the Prisma 2020. A high-quality systematic review would clearly articulate objectives and questions, will have an eligibility criteria reported in the protocol, will have had searched multiple databases, and present and synthesize these extracted findings. Everything is transparent when you talk about a systematic review. These are my summary points. JBI is an international research center that advances evidence-based healthcare. There is a JBI Evidence Center at Kochi. Okay. Global health, evidence generation, evidence synthesis, evidence transfer, and evidence implementation work concurrently in ensuring use of evidence in healthcare delivery. And systematic review follows a methodological process ensuring recommendations for policy change is underpinned by the strength of evidence. Thank you very much for listening.
Sir, thank you very much for a very extensive, exclusive talk about your presentation, especially about JBI and what it does, and about the evidence-based approaches, and about the evidence-based practice, especially and how to do a systematic review, and what is the difference between a systematic review and a literature review. It was much awful. So hope the audience would have got more information about your session. So each and every slide is more precise, clear, and easily understandable. So I don't have much question on your presentation, but a few couple of requests on this topic. The first one, in what way the meta-analysis will improve the statistical power? So it is the question that arises from my mind. So any answer for this?
Yes, Doctor. Thanks for the question. When we write systematic review, it always comes with a narrative synthesis. Okay? But there are systematic reviews wherein you can pull the data that you've extracted so long as the data are homogeneous. And then we pull them using Revman, and Revman will come up with a forest plot, and it will give you what we call a pooled intervention effect. Yeah. For example, there are 5 studies reporting different results. So the Revman will pool those results together using statistics, and it will come up with one pooled intervention effect, wherein you could see you could take a look at the mean and the 95% confidence interval and see if the intervention is really effective or not effective. So meta-analysis will put more clarity in it, but it is not an essential part of a systematic review.
Okay, fine, sir. So my next question may be helpful for the audience. So what will be your valuable research tips for the young researcher or the beginner?
Sorry, can you repeat that?
The research tips for the researcher, young researcher or a beginner.
All right. For the young researchers, for the young researchers, my request is that your research question should be coming from your patients. What is the most important question that your patient is asking? It's not what is important to you. Always start with your stakeholders. What is important to them? And then transform that into a research question. That will fuel you in completing whatever you're doing, because you are actually practically doing it for another person who needs your help and not for you alone.
Fine, sir. Thank you. So next, I would like to get the questions from the audience. Yes.
Hello, sir.
Hi.
Yes, sir. Thank you so much for the wonderful and the lucid presentation.
Thank you.
But, sir, I have used JBI manual checklist for many in my systematic reviews. One flaws which I am finding in that, there is no cutoff values for JBI checklist. Whereas when we compare the other checklists like Newcastle, Ottawa scale and all, we have a clear-cut cutoff. So distinguishing between systematic review and literature review, what makes it different means the base of risk of bias. But by using JBI, we are not able to produce a very clear-cut idea that which is having high risk bias, which is having low risk bias, because it is purely subjective and there is no cutoff score. Please elaborate or further action on the same, please, sir.
Yes, thank you for raising that. JBI, like the other organizations, will have a critical appraisal tool based on the study design. So a randomized controlled trial will have a JBI critical appraisal tool that matches it. A quasi-experimental will also have a JBI critical appraisal tool that matches it. Now, you are correct. Most of the research centers, okay, engage in this or which have come up with the critical appraisal tool will not directly tell you to score it as low, moderate, or high just by using their CAT. A JBI critical appraisal tool does not have that. It gives that obligation to the systematic review team, which comprises of academic researchers, content experts, statisticians, and patients. So they will decide if that paper is low, moderate, or high based on the risk of biases that are present and were detected using the critical appraisal tool. So it is actually given on the review team. Back then in 2024, if I'm not mistaken, the PDRO score, okay, will usually have a cutoff wherein they'll say if the score is 7 or less, you exclude that study. It has changed heaps. Now, when we see a study eligible to be included in the systematic review, and that particular study, okay, has a high risk of bias, we do not exclude it in the analysis. We take the evaluation into consideration using the grade pro approach. The grade pro will grade the papers based on the risk of bias, the inconsistency, right? The imprecision, the publication bias, among others. So there are a lot of layers in it, wherein that freedom to give your risk of bias assessment, I think, is still very much useful. Thank you.
Yes. Any questions? Okay, fine then. Okay, ma'am. Thank you, sir, for a wonderful session.
Thank you.
Thank you
Thank
so
you very
much.
much.
Thank you, Dr. Valentine, for your session. It was an enlightening session and a reaffirmation why the systematic review is important for all of us. So be here, both of you, please. I'll request Dr. Pushpa Sarkar to kindly come up on the dais and hand over a memento to our speaker. As a token of thanks and appreciation from School of Health Sciences, Dayananda Sagar University, we would like to present you a small memento and certificate to Dr. Valentine C. Thank you so much for coming. Thank you, sir. We would also like to extend our heartfelt thanks to Dr. P. Senthilselvam for chairing the session. Thank you so much, sir, for doing the honors. Thank you, all of you. Thanks a lot. To continue the session further, we have our next speaker of the day, Dr. Tanuj Kanchan. Dr. Tanuj would be speaking on art of scientific publication, and to chair the session, we have with us Dr. Naveen Kumar T. I would request Dr. Naveen Kumar T, Professor and Head of the Department Forensic Medicine and Toxicology, Kempegowda Institute of Medical Sciences, Bengaluru, to take his chair on the dais. We welcome you, sir. Kindly take your chair, and I would request you to introduce the speaker, Dr. Tanuj Kanchan, sir.
Thank you. I'm honored to be on the chair here to chair the session on the next speaker who is going to come is Dr. Tanuj Kanchan. He's a good friend of mine whom I know him from past 15 years. So we are of the same profession. And I would like to tell you that he is one of the best speaker for this session because he can, he's the one who is best, and he's been doing, he has been having a lot of publications in national and international journals. So a small introduction of Dr. Tanuj Kanchan.
Changes.
So he heads as professor and head HOD Forensic Medicine Dean Research since 2022 to 25. He's affiliated to AIMS Jodhpur, and he's member of Fellowship of MAMS, FAMS and FAMLE, and he has received numerous awards, includes a top 2% most cited scientist of the world from 2021 to 25, 2 times recipients of Good Teacher Award at KMC Mangalore, Eminent Scientist Award by Dr. Shurveer Singh Trust Udaipur, professional experience more than 20 years, area of expertise forensic pathology, anthropology, toxicology, suicide prevention, research and publication and ethics. Publication, he has got more than 500 papers, 5 books and 25 chapters in the books, including encyclopedias. So H index 82, citation 86,402. So I don't, he has got an, this biodata, it's too less to start up with, it's more, I can tell you that. So without wasting the time, I would like to hand over the floor to Dr. Tanuj Kanchan.
A very good morning to all of you. Am I audible? Okay, fine. So, my talk, first of all, thanks to the organizers for giving me this opportunity to address this wonderful. Now, my discussion, my topic has been placed between two very important topics. One on systematic review is just got over, and the next speaker is a fantastic person, and he'll be speaking on artificial intelligence and ethics of it. So, my talk is a basic one on art of scientific publication, and I would wish to open this slide with a quote, "Hard work is the key to success." This is something which we have been hearing from our childhood days, and believe me, you grow older, but the saying always finds its way. So you go to a senior and he always will give you a saying that hard work is the key to success. But is hard work the only key to success? The answer is obviously no. You have to be systematic in your approach. You have to have an idea and smart ways of doing certain things for it to happen. So today we are going to talk about art of publication, something which is very important for us to give shape or destination to the research which we have taken up. So I will be covering my topic into what is it, how to do it, who will do it, why to do it, when to do it, and where to publish. These are the things which I will be discussing in today's lecture. Obviously, all of us who conducts a research, who are men of science, and whoever believes in publishing, obviously should indulge in this science of publishing. So you need not be a trained expert. Actually, we don't get a training for writing. We do a research, and then gradually, over a period of time, we learn how to express it in a better way and how to publish it in a good quality journals for maximum people to read it. As early as possible, instead of waiting for tomorrow, today is the best time. And early as possible, when I say, I see a lot of students in the crowd, and this is the right time when you should start thinking about it. People think that they will do their thesis, they will do their PhD project, they will take up some project, and then subsequently their teachers will guide them, and then they will publish it. No. Whatever ideas are coming to your mind at any point of time, I am happy to see that people in different courses, at the time of their bachelor's degree only, they have started to write small articles. So that is how you learn and you grow. If you have conducted a research, if you have done a thesis, then the best part is that as soon as the thesis is over, as soon as the research is over, you should try to publish it. Once you leave it, it will never happen. That is why so many of theses and projects, they go waste every year in India. Now I will be taking up why to publish, how to publish, what to publish, and where to publish. So, talking about why to publish, we all know we have our own reasons for publishing it. Some of the other reasons we will be exploring now. That is, it is our responsibility obviously to publish. Responsibility because for every research, lot of human resources and funding go waste if you don't publish it. So documentation of research finding and putting it to scrutiny of others or reading of others for their scrutiny, comments, critical analysis is very vital in research. It is essential part of dissemination of knowledge because it connects you to other people in the field, other scientists who can work on your project. Important in advancement of science, it generates discussion. Results may be positive, results may be negative. Both the ways the thesis or the findings are going to be helpful for the future researchers. So very rightly said that science does not exist unless it is published. So in most of the lectures, in most of the places, we keep talking about how to conduct research, what to do, how to select topics, how to take it up in a certain way, what should be the method and all those things. But we rarely talk about publishing it. So today we are here to discuss the different avenues related to this. So it is said that a project that is not published remains incomplete. I'll justify why. Because science is not an individual experience. You have to share it. Only when you share it, then only the consequences of it can see the light of the day. So communicating our science is as important as creating it. A lot of us are creating it, but we are not communicating it to others. And the best way to communicate to others is through publication. Now, this is the inverted triangle of research. I'll tell you why this is known as inverted triangle. So, the research triangle starts with the research idea into research proposal. You have to plan a research well, you conduct a research. Now, most of us stop here. So, there is an idea, proposal, research, and we conduct a research. Most of us stop here. What is important afterwards is you publish it. Once you publish it, it is subjected to critical analysis. Any research finding can be subjected to critical analysis only when it is published. Otherwise, it is a closed door game. After that, it goes into scientific records, and some of these are utilized for policy making. So that is what ultimate aim of doing any research was. A good or more good to the society and the country, which will never happen if you conduct a research but don't publish it. Why it is inverted triangle? Because a lot of us have many ideas, but we don't change it or convert into proposal. Lot of proposals go, but research is not done. And after conduction of research, publications are not there, analysis obviously stand no chance, and never reaches, even good papers, they never reaches policy making stage. So publication, that is how is important despite of having good outcome in your research paper, research work. So why to publish? Dissemination of knowledge, it is our social responsibility. Accreditation and ranking of the institution depends on that. That is why most of the institutions are now focusing on more and more publications, more and more research outputs from their faculty members and students. Besides that, most important driving force is the personal satisfaction, often referred to as intellectual excitement. So unless that is there, there is no motivation. Obviously, you can't go far away. Besides that, at an individual level, now we saw at a social responsibility, national level, all those things. At an individual level, obviously it is helpful in getting you jobs, promotions. Sometimes some universities are starting now performance-based evaluations and incentives, and your published articles, research papers, all those have some points allotted to these papers, and this is the basis of maybe some incentives or hike in your salaries. Sometimes for securing funds and grants, when you go, they see your past profile, they see how many papers you have published, what is your research profile, and that helps you get more funds and grants for your research papers. Then it gives you national and international visibility, which can lead to collaborations. Citations, you write something, people read it, they cite it, they appreciate you, they recognize you, and you get future opportunities are there obviously accordingly. And that ultimately again would give you personal satisfaction, intellectual excitement that we talked about in the previous slide. Now how to go about it? So is it difficult? Is it difficult to publish? I think some of you who are in the beginning stage might be thinking so. Some of you who have left it because of their initial failures might be thinking so, but actually it is not very difficult if you continue to do it. The basic structure of writing a paper revolves around IMRAD, you all know it, introduction, material method, results and discussion, or analysis and discussion. And for case reports, these are two prominent types which we publish our work as either original research paper or a case report. The structure differs, very minor differences there. For a case report, introduction, case reports and discussion. In original research paper, you have introduction, material method, results and discussion, or analysis of the results and discussion, followed by a conclusion, and you have to summarize all your findings in abstract and mention some keywords by which your paper or your research area can be identified. Now, how to go about it? Introduction should be relevant, clear aims and objectives should be there, appropriate sample size should be there, standard method should be employed, appropriate analysis of results should be there, good presentation of results is required, good representation of your own work, a good discussion, literature search, valid conclusion including limitations and acknowledgement. Besides that, sometimes conflict of interest also needs to be mentioned. If you look at it, this is all ideal scenario, you keep on writing, you improve on that. Important is acknowledgements, so any funding source, your institution which supports you, any friends or colleagues who have supported you, all those people ideally should be acknowledged. And believe me, we pay less attention to acknowledgement section, but acknowledgement section gives a clue to the editor and the reviewer that there were many people involved and you are somebody who knows about publishing, and that is how you are acknowledging them in due course of your publication. So we'll take these important ones in the coming slides also. And lastly, you have references as per the journal style. Now, important in publishing is whenever you are choosing a journal, once you have chosen a journal, then you have to follow author instructions very seriously and follow the submission guidelines. Sometimes the papers are rejected just because they have not followed guidelines. Not following guidelines just shows the non-serious nature of the researcher when he is submitting a paper. Whenever in doubt, you can have pre-submission inquiries also with the journal editorial office. That also, good journals have that provision. Now, what are we publishing? We are publishing in 3 well-defined categories: original research, case reports, and review articles. Now, review articles can be narrative reviews, they can be systematic reviews. The previous topic was already on systematic reviews, which are categorized almost equally as any original research paper. So, that has been taken up. These 3 categories are the well-known ones. Besides these 3 categories, you should be aware that there are many other categories which youngsters at college level or even when you grow in experience, you can make use of these categories also when you are trying to publish your research or an idea. These include technical note, short report, case review, letter to the editor, correspondences, brief communications, rapid communication, etc. So you have to look for these possible opportunities in different journals. They vary from journal to journal, and even if you have a small bit of idea which cannot be converted to a big research idea or big research paper, then also you can write to them, and there are chances of it being appreciated and published. Other categories include, the list is unending. There are many of these: editorial, preliminary communications, clinical practice, leading articles, personal view, learning point, images, photo case, photo file. So even if you have any personal kind of view, you have some idea, hypothesis, you can publish those things also, and they gain wide appreciation in the international community. And if you don't have much time, obviously photo case, photo file or images, they are a good solution to writing a good paper. Now, where to publish is an important task. Things are not easy, but the basic is you have to publish in peer-reviewed journals and high-quality journals. We'll see how to establish quality of the journal. So we have to publish our research in high-impact journals with impact factor, which are peer-reviewed. Something which is not peer-reviewed is easy to get in, but that will be waste of your hard work. So good thing is that you should recognize some publishing agencies like Scopus, Medline, Index Medicus, PubMed, depending on the specialities, which specialty you belong to, and then accordingly you can choose the highly ranked journals. You can try there for publishing your research. If you are not into international journals, if you find it difficult, then you can start with the national and state journals. Preferably should be indexed in Scopus, should have some impact factor. Please be aware of predatory journals. I hope all of you are aware of what predatory journals are. Predatory journals and publishers are very common nowadays. They invite you the moment you write something, or they get hold of your email through your official universities, or they know that you are in different stages of publication. They will approach you, they will invite you, they will give you good offers. And please be aware of these journals. They are making money out of your work and nobody is going to read it. And even these kind of publications have no value. That is why UGCs and universities have focused on counting only those publications which are in Scopus journals. So journal with high impact factor should be a final destination for researchers. Make good choices, not the easy ones. Please be aware of predatory journals. You can use journal finder sites like Elsevier Journal Finder, Springer Journal Suggester, and nowadays it is very easy because ChatGPT and AI, in the moment you put, you ask them for any kind of help, these simple things can come to you as to which journal would suit your topic of research, and accordingly it will help you choose a journal. Now, most of us are publishing our work in specialty journals. So whatever specialty I belong to pharmaceutical sciences. I'll have accountable few journals in my specialty. I'll be trying there. Obviously, these journals are over-flooded. Articles will be rejected, and then I'll think that there is no place to go. Either I will go for a predatory journal, or I will go, I'll shelve my research and think that nothing is going to take place now. So the obvious answer to this issue is, please think beyond your specialty journals. Don't be restricted to a society or national journal. Choose journals based on their impact and subject. It increases not only your scope, also visibility. Why I am saying so is that we all are somehow related to healthcare practices, medicine, which is a vast science, and all the specialties, subspecialties are interrelated. Something which may be not novel or not interest to you or your specialty may be of some importance or interest to other specialty. So it is always better to think beyond your specialty journals. I'll give a few examples also later. Still appears to be difficult. If it still appears to be difficult, then you follow what many years back, many decades back, Sir Isaac Newton said, that collaboration is the key. If you can't do it alone, please collaborate. Now is the word of collaboration. You can't do everything alone. You have to collaborate with people who have similar interests, who are dedicated. Please collaborate with them, your colleagues in the different departments, different institutions, and as you grow, believe me, you will be collaborating shortly with your international counterparts also. So important is in collaboration, you have to keep in mind is work with the right people, because many people would wish to collaborate but will not wish to contribute. There is a difference between collaboration and contribution. So we have to we have to join hands with people who can contribute, not who are collaborating only for the name's sake. So researchers are individuals, but science is a collective effort. Being independent is the key. Now, this is a conflicting statement. On the previous slide, I say collaboration, and now I say independent. Being independent is the key. Being independent is the key is, if you know maximum about your research, how to write it, then only collaborations will work. If the chief of the family does not know everything, then the house is going to fall. The principle is very simple. So I'll give you a couple of examples. As a PG, suppose, or as a junior faculty, you want some statistical analysis to be done, and you have to approach a statistician. Now most of the colleges, they have one or two statisticians to support research work. Yes or no? Yes. So you will have to take an appointment with the statistician. You will go there, some work will be done. Either you will not find him at one go, or the things will not be done as per your satisfaction, or whatever is done, your guide or the reviewer will pose some questions on that. Again, you have to take an appointment with the statistician. After some time, you will feel like, to hell with the work, I will not publish it at all. So that is how we lose our work. Better is to have a know of the basic things what you are into. Simple things like, in earlier days, we used to go to a typist or a computer operator for typing things. That itself was a trouble, and many of us would lose our important work in between. So acquire the basic skills and work with the right people. Learn to write clearly and concisely. Till now, obviously, English is the language of science. Be persistent and tenacious, but be prepared to fail. Truthfulness and honesty, especially limitations. Whenever you are publishing in an international journal, then you should also focus on mentioning the limitations. And whatever is there, you should mention it with truthfulness and honesty. Ethics are to be maintained always. Now, what are the common reasons that we face when we are publishing? When we are trying to publish our article, most of us have faced harsh times that the paper gets rejected many times. So what are the common reasons? What they cite, the reviewers, what they cite is, research idea is not novel, case is not rare, methodology is not clear, inappropriate sample size is there, not following journal format, poor language or expression is there, too many tables and figures, ethics committee approval is not there, it's missing, there are issues of scientific misconduct. So if you have tried publishing in journals, or if you are going to try, believe me, one of these sentences is going to come when your manuscript is rejected. So now what is the outcome? Outcome is we get disappointed and dejected that our hard work is either it is not recognized or there is no way taking it forward. So handling of revisions or rejections is the art. It is a trick. Please remember, reviewers are not God. Reviewers, they know many times lesser than you. This is the truth. And reviewers are subjective. Reviewers are subjective means something which is rejected by a particular person will be accepted by another person. So you don't have to lose hope. If they have given you some comments, whether rejecting it or asking for revision, then you should take that feedback seriously. Instead of thinking that whatever you had done the best, and what does the reviewer know, what do other people know, all those kind of negative thoughts should not come to your mind. Rather, you should give a response which is point-wise to each comment, and even if it is rejected, take the comments as a positive feedback and submit it again to another journal. I told you reviewers are, this is a subjective assessment. They are not the ultimate experts. So something we have seen in our experience that something which is rejected by a particular journal gets sometimes accepted by a higher ranked journal. So we should not lose hope. So handling revision and rejection is very important. There should be a tolerance for criticism and failure. Please remember that criticism is not insult. Okay, criticism, many of us take it as in a very negative sense, and it seems to us that as if we have failed. It is not like that. You have to take it in a positive way. Look at the aspect, look at it from the reader's aspect. Whatever we are doing today or tomorrow is always the best to our abilities, to our thought process. But now it is being scrutinized by people who are reading it. The reviewers are one of these. So please start to think from their point of view. If you are there pointing something, then you should know that because they give you a different perspective to the same work. So that will help you. Now you have to judge the level of criticism, how much it is justified, and what you are going to gain from the criticism. Anyway, you are not going to lose anything. So these reviewers are actually helping you grow. Quickly extract lessons to be learned from failure and then forget it. Now rejection is a part of the process. If somebody says that he writes and it gets accepted, it is not possible. The person is either telling a lie or he has never tried itself. So rejection is a part of the process. Today you might have seen in my CV that I have number of publications, maybe 500 or so, but then if 500 publications are there, then I am very sure that at least 2,500 times I would have tried. And the rejection rate and failure rate has not improved. It is the same, believe me, because competition keeps on growing. So if I had to wait for a publication for 6 months in 10 years back, today also it has grown only, and now I have to wait for 2 years, because now more and more literate people, more and more people who have belief in publications are coming up. So a lot of new ideas are there, newer generations are fast, technically sound, so they are a tough competition. So rejection always will be there, whosoever is there. You try, it will be rejected, and that only gives you experience and you become expert. So that is essential part of success. Nobody is born expert. Everybody becomes expert by experience, and experience comes only through rejections. So learn to withstand criticism, be open to the comments from your colleagues, reviewers, editorial office. Self-motivation obviously is the key in these difficult times, and a positive approach will help you. Persistence is important. It keeps you improving. What you avoid is, avoid intellectual impatience, pessimism, author conflicts, misconduct. These two are very important. There should be no conflicts or no ethical issues in your work. If that is the case, then the authors are blacklisted, and then there will be no great future. Serious scientific misconduct will not be covered today in these classes, but you all know it is plagiarism, falsification, fabrication of data. These are the three major issues which we have to keep ourselves away from. And other than these issues, at our personal level, what we frequently cite as issues for not publishing or difficulty in publishing is, often we see people saying, we don't have enough material, we don't have enough time, we are overburdened, we don't have any good library facilities, and there is lack of quality labs, there is lack of quality work. All those issues always are before us. But these are, in my opinion, these are all excuses. You have to look for material. Material will not come to you automatically. You don't have a particular kind of patients. You collaborate with a hospital which has patients. They'll be willing to collaborate with you. Time is always a concern. Nobody has time. India is a country where it is very suited this line. We don't have time. I think Shashi Tharoor once commented that India is a country where nobody has time, but nobody reaches in time. So everybody is late. So don't bother about time. If you want to do something, you will get time. And we do so. We have doctors who after clinical practice are seen in pubs. After that, we have people who are roaming here and there. It's all on interest basis. You have to drive a balance between entertainment, duties, and what you derive pleasure from. So, lack of quality of work, I have put emoji there because we have to have belief in our work. No work can be small or large or of bigger magnitude. We may have international laboratories which can have better output, better experts than us, but that doesn't mean that we are not better than anybody else. If we are better than other people, then obviously we have some meaningful things coming up for us. So, if there is lack of quality of work, international people would not be collaborating with us. They will not be coming to India for research. Everybody has limitations. They too have limitations. You don't have material, they have no material at all. They are looking forward to you for material. Okay, so don't underestimate. Basically, the message is don't underestimate your work. If you don't value your own work, then you are not going forward anytime. Inadequate guidelines and training, facilities inadequate, finances are inadequate, workforce is inadequate. All are excuses. If you start working, these will not come into way. What more guidance and training you want? You have frequent workshops, trainings, and your university is conducting this event so that you learn about doing all these things. So everything is there in front of you. Only thing is we are not recognizing it. That is the problem. So real problem lies within us. It is lack of vision sometimes. More importantly, it is lack of belief in publication science. We don't believe in it. So lack of self-belief, belief in our work, and so we prefer to spend time complaining about the system. So I was meeting some intellectuals in Delhi in a award ceremony recently last month, and all of them were talking about what quality of work they are doing, and it has made impact in the country's economy and all those things. And I told them, but where is it going? They have not published it. Nobody knows about it. It is only in a closed door meeting that when they are showcasing that they have come out with some brilliant idea, but it is not known to other people. So that is what is lacking in us. So there is no time for complaining. You have to start doing, and all the complaints you will see that they go off on your own. On their own. There is nothing to complain. You have all the facilities, all the material, all the time around you only. Only thing is you have to start to see that it is there. Now we have a curious example of 3 publications. I have given it as a curious example of tuberculosis because now the first publication came in 2007 by 3 authors who wrote an article on sudden death due to tuberculosis. It was published in a Journal of Forensic and Legal Medicine. These 3 authors are, one of them is a pathologist who is senior to me, and 2 are my colleagues, or both seniors to me. That is why I know this case. So once this case was published, all the peer group criticized them badly, and whosoever was there around, they told, what is this publication? Tuberculosis is so common in our country, and so many deaths are occurring due to tuberculosis. And this international journal published from UK is publishing a case of sudden death due to tuberculosis. Either the editor and reviewers are blind, or the journal is rubbish. So that is how they discredited the paper. So obviously these authors would have been disappointed, but then okay, they carried on. Now you see, after 3 years, one author is common. They have published in the same journal a case series of tuberculosis related to sudden death. So after 3 years, again their paper is published in international journal, and other critics are criticizing. They are doing their work. They are criticizing the work, and this person has published a case report. And lastly, you see, after another 5 years, one of the author of the first paper, from the same institution, tuberculosis burden at post-mortem, Lancet Infectious Disease, 2015. So, what do you infer from this? We are nobody to judge or say what is important, what is not important. Something which is not important to us, which is very common to us, may be rare to them. Now think from a point of view of a physician in UK. When was it that they had seen gross findings in a lung of a tuberculosis patient? Not really. They have seen it in books, pathological picture they have seen in books. They have not seen those elaborate descriptions in today's time. So maybe that was the reason why it was published. And obviously it got published in Lancet, then you can't query on the intellect of the reviewer and editors. So some of the suggestions which I would have is to go for original prospective research, If you are going for original research, let it be prospective, and methodology is the most important aspect. Your methodology should be very strong. That is what actually is seen by the editor and reviewers. If you are going for a questionnaire study, then use standard questionnaires. If you are deriving a questionnaire, then let it be vetted by your colleagues and other groups. If you are going for retrospective studies, we often see the same studies are being done in this college, that college, retrospective study of accidents, suicides, and like that. They keep on doing on a small sample size. They should be novel and they should be done on a larger sample size. If you are doing a case series, then all the cases should be detailed. Basically, whatever you are doing, you do with some conviction, truthfulness, integrity, and confidence. That is what is the key. And if you do it with the conviction, then reviewers and editors, they are able to see that. I am sure about that. So, you have to analyze your observations. Before I think we are into concluding parts of the topic. So, there is a small, to keep it in a lighter vein, there was a practical session in a psychology class. The professor showed a large cage with a male rat in the middle of the cage. Some of you might have heard of this story. So, this is a professor is showing a research results to his students. He is trying to do some research. So, professor has kept a piece of cake on the side and kept a female rat on the other side. The male rat ran towards the cake and ate it. Then the professor changed the cake and kept some bread. The male rat ran towards the bread this time. The experiment went on with the professor changing the food every time. And every time the rat ran towards the food and never towards the female rat. Professor concluded, this experiment shows that food is the greatest strength of all attractions. Then one of the students from back rows said, back rows because backbenchers are usually very innovative in the initial stages. Sir, why don't you change the female rat? She may be his wife. No offenses to wives. I could have put anything else here also. She may be his wife. So, is it not a methodological error what we are thinking at? Yes, it is. So, critical thinking, right, intelligent interpretation of observations is very important. Because that is what reviewers and editors are doing to your paper when you publish it. Whatever we are doing, we feel very happy about it, we feel strong about it. But only when it is put to scrutiny of others, then it sees the real light of what is important. So, last word of caution, there is nothing like a magic wand or a shortcut to success. You have to keep working hard, and self-belief are the only ways to go ahead. So, you start, think, analyze, plan, try, do again, keep on doing, and then obviously success will be there. And that is not only for publication science, that is all throughout our life. We have to follow the same path, and then only there is success coming our way. So, anybody who is starting, I see a lot of students there is a lot of promise the country has in you, and you all have capabilities. We have a lot of resources now in terms of computers and technological advances. So, it is not very difficult if you have a belief in that. Only thing is you have to focus on that. And for those people who say that we have less time, we don't have much time, we devote a lot of time in typing long messages on WhatsApp or social media, all those things. I am very sure with that much of writing you can make out you can come up with a nice paper also. So, thank you very much for the patient hearing. Knowledge is a collection of facts, wisdom is knowing how to apply the knowledge. Thank you very much. Any questions? I am in time, I think. Yes.
The house is open for questions from the delegates.
No
Hello,
questions?
sir. Yeah. Very good talk. The reason being you have been positive throughout the talk and also given your own experience of how persistent you were in the 500 journal publication. So this gives a positive note to many of us here, the beginners and the students, that we have to be persistent. And I would like to understand, we are in such a rush that we keep publishing in all the journals which keeps offering. But then, do you say all journals which take money are predatory journals? We are still unable to recognize the predatory journals. They still say that we are indexed in this, indexed in that, and any note on that? how to identify?
See, firstly, nobody says, everybody says that they are the best, and predatory journals are masters in that. They calculate impact factor on their own, and they have some dubious websites. Their journal names are matching with some other, those things are there. But if you can go to, see, all of us will be knowing about our specialty journals at least. If you can go to PubMed to search for journals, check for the journals. If you can go to the Scopus, Scopus is the easiest one. If you can go to the Scopus and check the journal, then you can easily find out. And easier ways are like how old is the journal. For example, the journal is coming out first or second year, first or second issue. Obviously, it is not being well read. Now, the journal may have been started by a good publisher, that is true. But why do you want to waste your hard work into a newly claimed journal, newly started journal? So, small things that comes by experience. Predatory journals, actually, long time back, there was a Beale's list of predatory journals. I don't know, many of you might not have heard. There is a Beale's list of predatory journals where you could have clicked that and you could have got the list. And this person who was a librarian from US, he used to continuously update the list. But the predatory journal lobby is so strong that there were lawsuits against him, and that person himself has gone into hiding and the list has vanished. So there is no list to search for predatory journals. But what you can do is you can look for the publisher, you can look for how many years old the journal is. Usually these predatory journals are very young. They are into their first or second issue, and you can look at the articles which they are publishing. By the simple glimpse of it, you will come to know that they are not of standard quality. And I am looking forward to people publishing in high impact journals. That is very easy to find. So you have to go to Clarivate Science or Web of Science and look at the impact factor and start publishing there. My message is very clear that you have to start from the topmost journal. Whichsoever is the topmost journal. Whether you believe in your article or no, it doesn't matter. You have to start from the topmost journal, and they will reject it fast. It may happen, you go to the second one, third one, fourth one. I have tried myself, some of the papers which I thought are not of good quality, I submitted those papers in an ordinary journal. They rejected it. Then out of sheer hopelessness, I submitted it to a higher journal of the rank of BMJ or Lancet, and they accepted it. So there is no science, there is no logic. It is your luck also sometimes, the way of writing also may matter. So that is what I have a message about. Try something big. You are not going to lose anything. Only thing you said was you lose on time. So for that, the solution is that once you start doing it, you are in a cycle actually. Initial 2 years are tough because your articles are being rejected. But once that cycle is there, some are rejected, some are accepted. So you have to pass that lean phase, initial phase, and once you are across that is why collaboration helps. If you are doing it alone, see, I have faced the practical problems. If you are doing it alone, then dejection, disappointment comes in very fast. Because your hard work, sometimes Indian editors and reviewers are very harsh. So another advice is go for international papers, international reviewers. Sadly, our people will write comments like, this is a worthless paper, not worth publishing in any journal. They will put comments like that. That is very disappointing. If you go for an international journal, even if your paper is bad, they will very politely say that you could have included that, you could have added that, adding this would have created a value for the paper. So that motivates you, that teaches you. On the contrary, many of them, there is improvement in our people also. They would keep it for 7 months, and after 7 months they will say that this is a worthless piece of shit. So obviously you will never come up again. So better is that to go for right kind of journal which take lesser time in transit, and that cycle keeps on going. Your friends and colleagues who are interested in it will help you, because alone it is very difficult to take that challenge. Thank you.
Thank you, sir. Thank you.
Thank you, Dr. Tanuj Kanchan, for enlightening and being very precise and accurate methods and methodology in regarding the publication of a research. With the thank you note, I conclude this session. Over to the organizers.
Thank you.
We'll give you one moment. Thank you, Dr. Tanuj and Dr. Naveen, for carrying out this session so well. I would like to request our Dean, Dr. Pushpa Sarkar, to kindly come up and hand over a memento of appreciation and certificate to our speakers and the chairs. We would like to extend a very hearty thanks to Dr. Tanuj for coming here and giving us the talk on art of scientific publication. Thank you so much, sir. Please accept a memento and a certificate from our side as the token of appreciation. Thanks to Dr. Naveen T for coming and chairing the session. Thank you, sir, for being here with us today. Thank you, all the dignitaries. Up next, we have a session by Dr. Bikash Mehndi. Dr. Bikash Mehndi is a professor, Department of Pharmacology, PGI MER, Chandigarh. To chair the session, I would like to invite Dr. Hanuman Prasad. Sir, kindly come and take the chair on the dais. Dr. Hanuman Prasad is serving as a principal, Mandya Institute of Medical Sciences, and we are thankful to him for accepting to be the chair for one of our sessions. We welcome you, sir.
Thank you.
Kindly introduce the speakers.
It's an honor to be here. I first of all congratulate and thank Dr. Pushpa Sarkar for organizing such a wonderful international conference at Bengaluru. Because Meghe, I think most of our health sciences faculty would have heard about him. He is editor-in-chief of Indian Journal of Pharmacology and International Journal of Pharmaceutical Sciences. He is ex-additional medical superintendent, founder of Experimental Pharmacology and Neurobehavioral Laboratory, coordinator at PG, JIPMAR and Metro Vigilance Center, regional coordinator for North Zone, Ministry of Youth and Sports, Government of India. Ex-Secretary, Clinical Pharmacology of Indian Pharmacology Society. So, Dr. Bikash Mehta has lot of awards to him. He's been dedicated to 2% of scientists across the world, conducted by Elsevier and Stanford University for 5th consecutive year. Nominated as member executive committee of IPHR for global coverage in 2023 to 2026. Member of Codex Committee, USA, DSMB members for several multinational trials. He has published 10 books, 300 book chapters, and more than 700 research papers. I think we will definitely have an enlightening session on this. Please go ahead, sir.
Welcome. Can you hear me? Yeah. So, thank you for brief introduction. Since it is a mixed population, I put the title, How We Should Look for Innovation, and how you should think for further step. So if you take today, earlier professor, they used to say publish and perish. But today, time has come that you need to look for the innovation. So when you look at pharmacology, 60s, we are working on prostaglandin. 70s, endothelin, nitric oxide. So since last 15 years, we are looking for nanotechnology, stem cell. And last couple of years, we can imagine that all the people are going after artificial intelligence. So this is how we look at that, innovation, all this experimental study. If you look at the discovery of diphtheria antitoxin, insulin, more than 70% of discovery, we got the Nobel Prize. Now look at during that time of COVID. Though today we said that, we don't have an expertise on experimental pharmacology. Very few centers, they carried out experimental research. Even we can count it. If you ask today, how many sites we have facilities for bigger animal, monkeys? Only 4. So during the COVID, I was, looking after from ICMR. So people used to go to the jungle to get the monkey. Today, we are working on Zika virus. We need a monkey from Africa. So during this COVID time, you can see, imagine 61,389 animal they were used, and especially because we wanted immunomodulator. So this is how we look at that. So I'll go back, like Dr. Tonus has already said about the Newton. What is the discovery? If you happen to go to Cambridge, Cambridge is because of the river, Thames River, and he was a neglected child. But if you go to Clare College, in front of the Clare College, you can look at that apple tree and window, he was sitting there, and that's how discovery. So you little further standing shoulder to be giant. Then you take an example of Egypt. You know that all this person who diagnosed around 200 disease, and he also performed surgery, practiced dentistry. So if you look at, some of the plant, even my MD's time, I had taken from Egypt use of castor oil for osteoarthritis. So all vital organ, blood system, it was identified. Look at this man, crazy man. You know that how tea is discovered. There is a king from China, he has a habit of taking boiling water. So he is a crazy man, he went to the jungle and he put that plant, tea plant, into the boiling water, and that's how the discovery of, tea. So what happened, he used to take all the plant. Today, we talk about lot of innovation. You can look at Ayush product. Ayurveda, Unani, Siddha, now the Tibetan system have been included. So we need to generate the evidence. So what happened to this person? He had taken 365 medicinal plants, and after that he died, he turned into the blue, and that is before, 2008. But one thing is that leading discovery, if you look at that from China, if you see that all the malarial symptoms are being described, and that's how, people got the Nobel Prize, and handbook on prescription of emergencies have been published. So these are the contributions. So if I go on, the next one is, Egypt, one of the major contributor. If you look at all medical document, record, ancient Egyptian medicine, today when we talk about pharmacovigilance, the concept was start from Egypt. And that's how they published the document 110 or 200 long content, all the formula, and particularly the herbal formulation. Now, coming to India, we are very proud, of the India. So if you look at this, Susat, during the Gupta's, kingdom. So what he had described, if you go to ophthalmology, all the description of the disease or the surgery have been done. He actually counted 300 bones of the human, and he also discussed. So some of the basic concept, antiseptic, aseptic, this concept has been started by Susatra. So if you look at the next one, Hippocratic Oath, what he said that he described typically pulmonary edema, how it will have a clinical symptoms of clubbing of the finger. So another one is he promoted Susatra concept into irrigation for wound healing. So these are the new concepts. If you look at that, dissociated with medicine, with philosophy, establish the science of medicine. Then you look at the highest moral inspiration from the Then look at the Iranian civilization. So one of these person, Al-Rajvi, he discovered alcohol as an antiseptic. Then he recorded 184 books with the article. Now one more concept, if you look at that, currently he may be from Uzbekistan. And if you look at that, he wrote Canon on Medicine, European medicine textbook during that time. And if you look at the concept, he said drug must be pure. Today, as a professional, if I ask, how do you check the quality of drug? You know, we call it NSQ. If it is not at par with Indian pharmacopoeia, you call it spurious, or you call it, you know, counterfeit medicine. So during that time, he said drug must be pure, it must be used for one indication, and the strength of proportion severity of the disease, you know, we describe as CRC or DRC, drug dose response curve, and during that time, all this concept was there. So coming to discovery of microscope, you know, so glass invented by Roman, it was recognized when the middle and thin age yielded magnification. Then concept was coming as a eyeglasses. Then 1590, it was used for hand invented the cylinder, and 1600 it added the devices. So if you look at all this discovery, then definitely you can look at that how we started learning. Today we talk about recording of blood pressure. So if you go back, there is a scientist called Dale. He used to put the cannula into the artery. That you call it a direct recording of blood pressure. Now we have a indirect one, and from there we develop a telemetry. So this is how we actually, you know, even if you look at hematology, circulatory system, all the rare disease, and how Christopher had used the blood transfusion and the use of brain. But in case of a clinical trial also, whatever experimental data we have, let's go for a human studies. You can see 500 BC, 1025, 744, and today, after COVID, see the new concept. We have a decentralized clinical trial. Earlier it was not there. Adaptive design, basket trial, umbrella trial. So these are the new concept has started. So if you go back, you know, you must remember, you know, by the river of Babylon, the famous music. This king, he wanted to promote the non-vegetarian. Then some of the people, they objected to his concept. And this is considered to be a first clinical trial in the world. So he made two groups. One group, they were receiving vegetarian food. Another group, they were receiving non-vegetarian food with wine. And after 10 days, it was found that those who had taken vegetarian food, they do much better compared to non-vegetarian. So this is how history of, you know, clinical trial during that time was there. And obviously we understand, you know, every month, every year, 28th of May, we celebrate as clinical trial day because of discovery of ascorbic acid, you know, in scurvy. So you can see that how it was designed during that time. The group was given vinegar, diluted sulfuric acid, cedar, seawater, and it was a comparative study. Today we talk about RCTs, randomized controlled study. So if you plan for a psychiatric trial, if you do not have a control group, you might get efficacy of 80%. But moment you put a control group, efficacy come down to 25%. And that's the reason that how when you do clinical trial, in order to avoid the bias, you have a system of randomization, then stratification, and all this experimental design have been started during that time. So these are the group and how statistically they have calculated, and ultimately they come up with. Coming with the smallpox, today it has been eradicated. But if you take a story, you know, girl with smallpox, 1100th century, you know, putting the scrap from smallpox pustule into the nostril, you know, wearing the clothing someone who already developed, you know, smallpox, and that give the immunity, and that concept started. So if you look at that, you know, some of these, I'll just go back. So these are Benjamin Sesti, that 1720, 1721, London smallpox location was there. So this person, what he did is, he was a farmer, and he had contacted that small cowpox were protected, and he come up with a concept. And that's how, if you look at the cowpox inoculation resistant to subsequent inoculation of smallpox, and that give a protection in 1798. So that's how we come up with a concept that how can you eradicate smallpox. And last case, if you see 1707, who confident about smallpox, it's completely eradicated. Now coming to some of this, you know, concept, washing hand. You know that during COVID, we try with biosafety norms. We try with how important is the washing of the hand. So this started with Sushatra, then Hippocratic, they promoted for irrigation. This man, he was working in Austria, and he said, some of this maternal and mortality, it is because hygiene is not maintained. So he started with a device, and after that, he did an experimental study. He found statistically, if you apply this concept, mortality, it will be reduced from 18 to 1.3%, but his HOD did not agree to it, and he lost a job. Again, he came back, and this was the data where it was found drastically reduced, statistically reduced. He devised this instrument, and this is how history of clinical trial, it was started in one person during 6 tenure in the Prague and Vienna, and this is how they do it. So, coming to epidemiology, what we did is epidemiology. If we look at the British physician anesthesiologist, he actually put how you do that epidemiological study. Today, if you see that during the COVID, we talk about infection rate and density of the population. Okay, so these are things are applied, and birth of pharmaceutical industry, it is begin with glycogenic function of the liver, pancreas in digestion, query. So these are, we have developed this system of that you can develop a pharmacological pharmacy industry, and that's how you're going to manage in case of pulmonary embolism, thrombosis. So we have an anti-thrombotic drug, but if you look at Louis Pasteur, germ basis information of infectious disease. So this is how we go for a boring. They discovered antibody for a diphtheria antitoxin, and immunization has been begun, the process of immunization. Similarly, Paul Ehrlich had come up with a concept with magic bullet. And when 100 years was completed, I was also invited. So these are concept is started. But if you look at that antibiotic used during the syphilis, and these are the compound has been used, erubenzene, 32% arsenic, and it's toxic. It was used for treatment of syphilis. Now we understand after discovery of penicillin, that's the right choice for. Similarly, insulin also, it has been discovered. They got award of Nobel Prize, and this is how 1922 Banting and Best published paper of discovery. 1923, they were awarded joint Nobel Prize. Similarly, if you look at Scotland, Alexander Fleming, where today we talk about antimicrobial resistance. If you look at last 15 years, how many antibiotic has come to India? Only one antibiotic, that is naproxen. So he was awarded in 1945, all this Nobel Prize for Physiology of Medicine for this. Then American medical researcher, virologist, he had a successful inactivated polio vaccine. And associated in this, like they go for a manufacturing or this, and during that time also, people put the question of study design, how you're going to do it. Similarly, Sabine, vaccine tested, weekend, and today when you go for an application of vaccine, they will tell you that how much protection, because the regulatory acceptance, if it is beyond 50%, then it will be considered. So women in clinical research, one of the important thing is that Nightingale, Shri was a famous nurse working during the wartime, and they contributed to a Crimean war to sanitary condition of the army. Marie Curie, she worked on radioactive material. And that's how we have a concept of radiotherapy. All this has come. Similarly, Salmon Yellow, she worked on immunoassay. Now we use for diagnostic one. Then Davidson Jewelry, chromosomal translocation. Now, what are the concept of clinical evaluation? Even experimental evaluation, we have a design. You have a control, you have a fecal control, you have a treated, we have a positive and negative control. Similarly, when you do clinical study, the blinding, single blinding, double blinding, triple blinding, multiple blinding, and also use of placebo. So this all it came. So when you go back in 1784, Benjamin was appointed a Franklin US ambassador, and they wanted to do a animal magnetism for medical cure. So they planned for a single blind placebo-controlled trial. So this is how blinding was started. If you look at the older picture, blinding, we do not call it blinding now because ophthalmologists may not like it. We call it masking. So these are the new concepts. Even in statistics, you go for a randomization. You go for a stratified randomization. You look at the power of the study. All you take the concept since 1890, how introduce application of statistics for experimental design and also for randomization and analysis. So you can look at the first clinical trial with properly randomized control trial. It was published in British Medical Journal. And this is how we look at that history of clinical research and experimental research, how you're going to get two milestones. Today, after COVID, as I say, we learned a lot of new technique, decentralized clinical trial, adaptive design. These all have been included. So ethics, if you look at that, we talk about Hippocratic, principle. So there, if you look at that Nuremberg Code, what happened in Nuremberg Code? All this German army, they had argued in international court that in the world few must die to save many more. They say, it is anywhere, Hitler is going to kill them after the war. Then they said, we are from German army, so whatever order it comes, we cannot say no. And they also say that all unethical practice, not only in Germany, but it is also in US. But ultimately, what is the concept we came? We came with individual autonomy. Today, when we do clinical research, you give all information to participant, and then you take a consent. So similarly, if you look at all this milestone, Belham report, how much benefit, how much risks, can you justify if you're sitting in ethics committee or if you're sitting in any as an investigator? So this is how we look at all this milestone of. So when you go back, identify bacteria as a Mycobacterium leprae, and it was not claim was well received. Then he actually done inoculation of live leprosy into the nurses and patients without any consent. And this is how Osler, he come up with the concept of, informed consent during 1898. So if you look at that, we have to inform, they have to understand, and after understanding, they have to use their individual autonomy, say, yes, I wanted to participate. So similarly, if you look at Nuremberg Code, ultimately we come up with the concept of individual autonomy, and that's how, if you look at it, all the medical experiment, during, when you talk about ethics, you can just think it is a very thin line. You see a blind man on the road, and you help that person to cross the road. If I'm sitting in an ethics committee, I'll tell it is an unethical practice. You may be irritated why you are saying it is unethical practice. Because you did not take a consent, informed consent. If you would have said, went and say, I'm so and so, hopefully you are trying to cross the road, can I help you to cross the road? If the person say yes, then it become ethical. So that is why it is very important to look at, because we call good science is a good ethics. So if we look back in World War I and II, it was very good science, but it was very bad ethics. So that is why we have a concept, first do no harm, intentionally. You are going to get the benefit, and if there is no benefit, can you monitor? If there is an ADR or event take place, can you monitor? So we take an oath, do not do any harm as a pharmacist, as a nurse, or as a medical person. So this is how we go, informed consent in enhanced clinical trial, where it is said that the report submitted to medical board, clinical research committee, how to provide each patient the informed consent. And today, when you look at informed consent, we look at all 8 essential elements and 4 additional elements. Some of the elements, you say, what is the purpose of the study? Purpose is research. There should be transparency. You are not only single one. there are 200 patients. Out of 200, you are the patient. So this is how you can also see one step further. When you do clinical trial, how to evaluate efficacy and safety in male patient, then the female patient, and others. You understand others. So during this IUFR meeting, one of the ladies stopped me and she asked me, do you have a guideline how do you evaluate efficacy and safety for male, female, and others? And we conducted, one of these objective, and ultimately we publish. You can read this paper in pharmacology report. How do even preclinical study also we look at how efficacy of safety in male as well as female, and in clinical male, female, and others, or you can go for a stratified. Now coming to ethical justification for any study, we follow ICMR guideline. And this ICMR guideline initially prepared in 1980, 2000, 2006, and the latest guideline is released in 2017, 12 October. So when you read this guideline, you can look at, we follow 12 principles. Some of the principle has been incorporated. As an investigator, you are part of society. Anything you are going to do it should be benefit to the society. Then we have an one world health concept. Any study you do, how to, is it going to impact on environment? That you have a concept, product is safe for a human, product is safe for animal, and product is safe for environment. So this all concept has been started. You can read ICMR guideline. So there are several guidelines. If you go to ICMR Bioethics Unit, that is office is in Bangalore. So we have a guideline for palliative care, euthanasia, how to use for biomedical research, unuse of biomaterial. So all these guidelines are there, even publication policy, you can read that. So this was a paper was published about gender differences. How do you generate the data in case of a male or in case of a female? So obviously now we are into AI. Today we do any preclinical study. For example, a stroke, Alzheimer's, any neurodegenerative. So earlier, when you plan for any preclinical study, we are going to ask the question, a lot of people say curcumin has efficacy. But when you look at the data, curcumin do not cross the blood-brain barrier. Can we apply preclinical data, how much it mimic, and it will be useful in case of a clinical situation. And that's how all this development, if you look at that evaluation of drug development, that we screen, and we go for an in silico study. So there you can say that how much it mimic. But when you do in silico, when you take it as a level of evidence, it will be considered a zero level of evidence. So this is how we screen thousands of compound. It reduces the time, and that's how all this software it is available. And all scope, if you look at that in drug development process, we can just quickly go through it. We can just quickly go through it. So you have a target, you have a drug discovery, you can go for a preclinical research, then let's go to the clinical. And if the product is already approved, let's go for a repurpose or off-label use. So when you take an example of during COVID, we identify 4 targets, S1, S2, N-terminal proteases. Then we screen all gene database, 78,000. How many molecules will be suitable for S1, S2, N-terminal proteases. So you can do quickly and you can generate the data. So cost is very high. And as I say, if you wanted to go accelerate the process, so definitely you have an affinity, you have an older compound, look at all preclinical data, because this preclinical data will look at depending on clinical situation. You wanted to use for 10 days, 1 month, or more than 6 months. Accordingly, you need an acute toxicity, repeated dose, or long-term toxicity data. And that's how natural machine learning is very important. So these are some of the examples how stepwise you can go with. But one thing is that if you use, artificial intelligence, this is one example. They have used for breast cancer, but they excluded all the data of male breast cancer. So today you wanted to ask any question, what about breast cancer is male they have not used it. So you don't get an answer. So there are a couple of, but when you look at our industry, it's growing. It is growing at the rate of, 10 to 12%. So you can take an example that how it is growing, and you can take an example that when we decided to go for a hydroxychloroquine on 22nd March, we also asked that how much hydroxychloroquine we have. Because we have a 140 crore population, if one person also develop COVID, can we manage to give hydroxychloroquine? But after 20 days, we export to everybody, 200 countries. Even we got an appreciation from Brazil president, thank you Modiji, with Lord Krishna. Similarly for vaccine also, medical device also. Today we talk about medical device, we have 8,000 plus medical device. We have a regulation we started in 2017 and it is implemented from 2018. So there is a way to go because there are very few people expertise on medical device. Obviously cosmetic, Ayurveda, everything it is done. So this is how we go for it. But you know that when you talk about country-wise achievement, we need to put money on R&D. Otherwise, you do not grow. If you take the example of one watch, HMT, you don't see now. Only tractor is there. So these are some of the examples how we can invest. And if you look at that dependency, how much we import, how much we export, can you have a mechanism, we'll go for more export, then we can say that we are the world leaders. So this is R&D spending, how much we spend in Europe or US or Asian countries. That need to be looked at that, then only you can grow. So if you take an example of pharmaceutical industry, Sun Pharma, Reddy's, Lupin, they're growing. They're putting the money into R&D. So if you look at 1980s, we have 1 or 2 compounds for IND. Today, every month there are 5 applications. So this is how we look at all this, company and how it is growing pharma company over a period of time. But it is very important, unless you go for innovation, new technology, you're not going to grow. Some of the real fact, I will tell you that generic, we are called pharmacy of the world. We export all the generic market to all over world. So this is how we look at, but obviously we have a challenge. Every day morning, somebody will get up and say, I'm going to put 5%, 25%, 50%. That challenge we have, and definitely when we grow, it will be difficult to replace Indian company over a period of 10 years. So definitely we have a hole, and that's how we look at, but we have to look at the reality. How we stand on innovation, 81. How we stand on global innovation, then knowledge index. So this is how, even we had couple of lecture on publication. How much we contribute? Only 4%. But if you take an example of smaller country, Switzerland, they contribute 30 to 39%. And even if you take an example of other one, knowledge index, how much? Singapore is number 1. Even if you look at that other country like Europe, Switzerland is number 1. So definitely our next generation need to be trained. They should have a skilled manpower so that you can grow. And definitely not only publication, I'll put it a word, you should also look for an innovation or patent, and that's how. So this is one, I just wanted to give an example, how simple idea can be published and patented. This is by an undergraduate student. They come up with an idea, if you go for a chemotherapy, you're going to lose the hair. So they put the devices which will reduce the temperature. And this paper was published in Archive of Internal Medicine, 20 impact factor. So one of the important points is novelty. I remember one of the medical officer from Maharashtra, he worked on scopiobite. He sent a paper to one of the Indian journal, and within half an hour it was rejected. And this man was very crazy. He sent it to Lancet. Lancet only says, can you allow us to improve the English? He said yes. And same paper was published in, Lancet. So innovation is very important. We have to do it and looking for a new compound. And this is what it is going to allow us. All this company, they have an R&D. They're putting the money into R&D for innovation. But from academic institute, we need to look for, did you thought of any orphan disease? Did you look at an orphan drug? How many people you work on, snake bite, scorpion bite? So these are the area you can look at. So global impact will come with a collaboration. So I just give you one example. One of the BMG editor had to come to IIT Bombay. So one of the younger faculty asked, why can't you publish in Lancet, New England Journal of Medicine? His answer was simple. You don't have a collaboration. You don't collaborate from one department to another, one institute to another. But COVID taught us that anything you go for a pan-India, let's go for a multi-site study. So this is how we look at the collaboration, and definitely, it is not enough to do based. You must know what to do based, and then you do the best. So any clinical study we do as per GCP. So we take it an example that when you plan for any study, just go to equator. What is a national guideline? What is an international guideline? If you plan for in silico, in vitro, in vivo, clinical study, that will give a framework. So you should be familiar with OECD principle and ICH or Indian. So we have an academic clinical trial. I only started, and with the Gazette notification. So this is what we released the draft guideline under my chairmanship for Government of India. So you can follow that, but we should not forget our traditional system. We can do a lot, but when you look at a regulatory angle, you make an application as phytopharmaceutical. Now NDCT rule said, can you identify 4 active ingredients? Then only it will be accepted. If you go to US, they will say 2 active ingredient. So this is how we have to look at, and definitely skill development program. We have done more than 700 skill development programs so far, and definitely what we have to do, we should not forget patient safety. And during the COVID time, we also understand there is also healthcare worker safety. So if you go to Switzerland, this fountain symbolizes patient safety. So we had come up with a draft guideline for patient safety. I call a meeting of 350 patients, of chronic patients. I took an input, and that's how we submitted this patient safety guideline for India. And since I have taken over as IUPAR chairman for next 4 years, my office is in Paris. So this is how we go globally. Anywhere we go, you say India is fast. India will take lead. OECD, we are the chairman. Okay? So that gives, proud moment for India and for us. So one thing is there that everybody look in one direction. Can you look in other direction, what you can contribute? Okay? And that also requires that you have a friendly environment so that you can do the research. You can think of novelty or innovation. So this is how we go. So this is my website, and we do a lot of training program. All of you are, welcome to come. And you should not forget rural India. 80% of the population is in rural India. You might do all the work in metros. How about rural India? So we must include rural India, that you can come when all of us come together, and this is how we go for it. And that's how I'll just stop it here. So all of us, we have to get together for safety. So this is one project we are doing in Leh. Though this is a double hump camel. That day I was there, it was minus 26. And they can climb with 300 kg to the top hill in 13 minutes. So you can do a lot of, so we are doing a behavioral study along with that. These are some books, and these are my group. Thank you, Jai Hind.
Thank you, Professor Bhagavan Meghe. You have made the history of medicine so simple, and the history has been known to many of our delegates now. Any questions from the delegates, please?
Any question?
I doubt there should not be any question. It was so extensive and knowledgeable. Thank you very much.
Thank you. Thank you very much.
Hello. Yeah. Thank you, Dr. Vikas Mehendee, for a very informative talk regarding all the aspects of the Indian history of the medicine and how AI can be helpful in that. So thank you so much for this talk. As a token of thanks and appreciation, we would like to present you a memento. For that, I would like to invite Dr. Pushpa Sarkar to kindly come up and present the memento on the behalf of School of Health Sciences, Dayananda Sagar University, to the speaker as well as to the chairperson. Once again, thank you, Dr. Vikas Mehendee, for the talk. Please accept our appreciation and thanks. Thank you. Thanks are also due to Dr. Hanumat Prasad, Principal, Manya Institute of Medical Sciences. Thank you, sir, for coming and chairing the session for us. Thanks to all the dignitaries. Thank you. So continuing our session, next up we have a talk from Dr. Major Ameya Kagali. He is a consultant sport medicine Ramaiah Memorial Hospital and Karnataka State Cricket Association, Chief Medical Officer Paralympic Committee of India, Team Doctor of Rajasthan Royals IPL 2025 and co-founder of Krida Human Performance Center, Bengaluru. So we'll have the talk from Dr. Ameya Kagali. To chair the session, I would like to invite Dr. Prabhu Raja. Dr. Prabhu Raja, please come up on the dais and take the chair. Welcome, Dr. Prabhu Raja. Dr. Prabhu Raja is the Head Associate Professor, Department of Exercise and Sports Science, MCHP, Manipal Academy of Higher Education. We welcome you, sir, for the chairing of the session, and I would request you to introduce the speaker.
Thank you, ma'am. Thank you for the kind introduction. Good afternoon, everyone. So, Dr. Ameya Kagali. He's an Indian sports medicine physician with a unique blend of military precision and medical expertise. He served as a regimental medical officer, gaining early experience in leadership and high-pressure clinical care. He currently serves as a consultant at the Ramaiah Medical Hospital and Karnataka State Cricket Association, and he's a team doctor for Rajasthan Royals. He's a co-founder of Krida Human Performance Center, which focuses on advancing integrated athletic rehab and performance training. He dedicated advocate for holistic athletic welfare, focusing on physical, mental, and ethical dimension of care. So his work emphasis on performance optimization, holistic support, and advocacy, ensuring that para-athletes' medical, logistical, and dignity-related needs are met. Over to you, Dr. Ameya Kagali.
Cursor only.
Yeah. Because the brightness is too much, the pointer is light.
Good. No worries. Thanks. And can I change the slides from here? Can I change the slides from here? Change the slide?
Oh, yeah.
Can I change the slide from here? It's okay, I'll change it from here. Good afternoon, everyone. Thank you for the introduction. And it's a bit of an irony. I'm talking about tech in sport, and we are a bit technologically challenged right now. Nonetheless, so I'll be giving you, first of all, how many of this distance is a little worrying for me. There's too much distance between me and the audience. This is the first for me. Anyway, how many of you are interested in sport? Just to play, you know, be involved, watch sport. I mean, man, it's really disappointing. Not many, too many academicians and researchers, I guess, in the house. Anyway, but I deal with a lot of athletes, and I'm privileged. And more than athletes, I would say I deal with a lot of fit people around me, which encourage each other right from the background of the armed forces after I finished my MBBS training in Pune. And then working with elite teams right away, start my career with the Indian hockey team, then followed with para and so on and so forth. But throughout the journey, what has shaped my journey thus far with the medical expertise or the medical knowledge that we all gain in our undergrad and postgrad courses is the use of technology. There's no escaping technology from day-to-day lives to the professional lives. So I think the main aspect is the integration. It's basically to make not just our lives easier, but to make the lives of us and the clients that we work with a lot more objective, a lot more precise, right? So it's no more science is moving towards a field, especially in sport. I'll stick to sport, where it's not about what you feel anymore, unless, of course, it's a branch of psychology. I come with a physiological background, and so we want to measure up to the last decimal as to what is happening in high-performance sport. And that might be toned down a bit if I'm working with recreational athletes or in a population which is more generalized, that is working professionals in the IT sector or in the medical profession. So the objective is to obviously monitor, prevent, and then diagnose, not the conventional, what a conventional medical professional would do. Generally, you go and see a doctor or a physiotherapist if you're in pain, if you have a fall, you want to rehab. But what happens in sport is that it's like an annual health checkup, which you start maybe after 50 or 60, maybe a cancer screening or something like that. But in sport, we start this, even my youngest athlete is an 8-year-old swimmer. So she's absolutely fine, nothing wrong as such with her, but we want to track the athlete's progress from a very young age. That might include and not only restricted to certain blood work, see monitors like your HSCRP, serum cortisol levels, vitamin D, calcium, magnesium, zinc, potassium. And so I'm coming to the point is that we are not here to exclusively diagnose a condition, right? Sports tech, of course, it's just one of the aspect of sports tech. Then, of course, rehabilitate injuries efficiently is fine. Then I'll be talking about my experience across hockey, Paralympic, and cricket, of course. So the core objectives is, again, as I started, it is not to diagnose a condition, it is performance enhancement. So anybody who walks, in the clinic, or when I walk into a sporting setup, and by the way, that's one of the differences too, where in a conventional setup, again, you have the patient or the client coming to you. Here, we have to be on the field, and if some of you all would take up a career in sport as a sports physiotherapist, you all will have able to relate, where it's not always the athlete or the client will come to you, and you will be sitting in a nice, cozy chamber. It'll be hot, and kudos to the organizers for picking this place. It gives a very feel-like environment. So you'll have to running around a lot. There is no scope for hierarchy, unlike in a medical college, in a physiotherapy college. So everyone's in shorts, you're running around, and it's a much more collaborative approach. And of course, injury prevention, because once you start tracking, you will exactly know which side is weaker or stronger on a particular athlete, not just from a skill perspective, but also from a joint perspective. Giving an example, if there's a badminton player, we like to slot it as it's a non-contact, unilateral kind of a sport. because a player who's smashing with his right hand will not use his left hand suddenly in the middle of the game. As opposed to a 100-meter runner, you have all the 4 limbs working in sync with almost a similar amount of strength and power and force required, right? Then rehabilitation, optimization, and then finally the return to play, which is the most important aspect, be it for a coach or the team manager or the media, anyone. We just want to know, when will this ex-player be back on the field? So I'll dive straight into about 4 or 5 commonly used parameters. One is the easiest and the most portable, that is the handheld dynamometer. I'm sure you guys have heard about this equipment or even seen, or some of you might have even used the equipment. It's portable, reliable tool for quantifying isometric strength predominantly. And now I need to delve into what is isometric, eccentric, concentric, which I won't. So it's just that you make a fist and you try to clench as hard as possible, give it 3 readings, then you get a parameter. Now, where this is used is again in a post-injury assessment, where we see a lot of wrist injuries in, say, spinners, fast bowlers, or batsmen who like to use their wrist a lot, especially down south from Andhra, Telangana, Karnataka. We are known as very wristy players. And then, of course, the bilateral comparison, like what I told you about in swimmers, for example, in a butterfly stroke or in a freestyle, in backstroke. So when you're going there, what is the flexion of the right shoulder as compared to the left? Or external rotation or internal rotation, because that will ultimately define what muscle is firing and at what rate it will be firing. So and that will help judge at what force has been created and how good his performance is eventually. So I think this active force 2 is one of the equipment, and then of course we have this. We also have the muscle meter from a company in Australia which we use, and we have some very good results. So it's not a passive kind of a test. You need a good trainer for it who can match up to the strength of the particular athlete. So I prefer it to be done by somebody who's a little more physically stronger. And that's where our fitness also is equally important as compared to the athletes. You have an NBA player, 6'4", forget NBA, anyone who plays basketball, 6'4", to match up to his kind of push of the shoulder flexion or his kind of throwing, you need to be equally strong because you're giving the counter force to it, right? Then here we have, and we also modify the kind of testing that we do. This one is a 21-year-old swimmer that he comes to my center, and he's training for the Asian Games to be held in Japan next year. So any idea, like, these are not the actions that you will do in a day-to-day life, okay? But these are the key components when you break down a swimming mechanism. How will his arm come? So that will be the shoulder adduction in 90 degrees, and from there, maybe an external rotation, or getting it back to abduction from adduction, or adduction to abduction. So these are the fine sport-specific tests that we can use, and the gentleman is my staff there who's holding the muscle meter. You see how much his forearm muscles are also tensed and can be seen. That's the kind of pressure he's applying. That's how strong the athlete is. Because if you don't do that, you will get a reading which is far more abducted, more than 90 degrees. And it'll give you wrong readings. So you'll focus on other muscles while training the particular athlete, right? Now, similarly, when in swimming, everyone knows the kicks are so important. Now, I could have done the flexion of the knee joint or the extension of the knee joint in a seated position or in a prone position, in a supine position, right? But it has to be a prone position because, again, we have to, come out of the box and start making the test more sport specific. Now, the elder brother or the beast of the isometric testing is the isokinetic dynamometer. It's like, anybody has seen the IKD chair, as we call it? Yeah? Students, anybody? Excuse me. No? Any followers of Game of Thrones? Because it's just like a throne. All right? We'll see what it does. Now here, It's completely automatic. We enter the data of what we want from the athlete. I'll take an example of a javelin thrower who had a shoulder injury, and with 6 months of rehab, how did he face there? After 8 months, how much? After 9 months, how much? After a year, what was the data like? Which will help us plan his throwing much, much better, right? And here in an isometric, you're just applying force, there's a counter force, and it's right there. But in an isokinetic movement, you're doing the movement, or the leg extension, or the hip. Every muscle, every particular joint is put to test, and we also tell the athlete that it is like a workout session in itself. So the criteria for me would be a 24-hour rest before and after the test. It's quite high intensity, and the more the athlete puts effort, the counter force is even higher, right? And yeah, and then it evaluates the agonist and antagonist, so it's a good way to measure the HQ ratio, the hamstring to quad, which is very important for runners, football players, hockey players, squash, tennis. They have a lot of change of direction movement, so you want each and every fiber to fire at their optimal level, right? Thank you. And any kind of bilateral asymmetries, again, it's sport specific, less than 10% for any bilateral sport, and less than 15% for a unilateral sport. Now, what does that mean? So if I have a force generating by maybe my right shoulder flexion, if I'm a right arm fast bowler, it'll obviously be higher than my left. Similarly, all the righties in the house, when you write, your fingers are much bigger. One side has to be bigger than the other. No two sides are equal, right? But how much is unequal will eventually decide on how much load it's bearing. And that's where that data will help us in injury prevention. So it's not a direct approach. It's a very indirect, and the history that is monitored for a very, very long time. And what is RTP? Anyone? What is RTP readiness? RTP or RTS? Anyone have heard this term? I've purposely put some abbreviations to understand where it's come from. Anyway, RTP is a very common lingo used, that is return to play, or RTS is return to sport. So that's my lab here where I studied. I did my PG in Auckland University in New Zealand, and that's the isokinetic dynamometer, the chair what I was talking about. And this is where we are at Ramaiah Memorial Hospital. This is a javelin thrower that we are speaking, para javelin, Sandeep Kumar, and he's participated in a couple of Paralympics. So again, as I told you, we can actually design which joint that we want to test and which position, so that can become a completely supine table. It can become an inverted one where we want to test the hamstring ratio or the quad strength ratio, or when we're testing the shoulder, we can make the athlete sit or even lie down. So this is what a report looks like. I'm sorry it might not be very visible for you guys. But it is again Sandeep's report itself. So the total work done, concentric IR to ER ratio, that is the internal rotation to external ratio. So there we can see on the right hand side is 30%, while the internal rotation and external rotation is there. So we know that it gives us a kind of a pathway that are we on the right track? Are we on expected lines? And why is this important is because an athlete, when they come to us, they have only one question: when will I get back to playing? When will I get back to sport? They are not bothered about how good they are while they are at it. So even if they tell ACL fata, when will I be ready? Be it post-op, be it conservative, I don't care. But make me ready for the next game, which is a little different in our clinical setting. They ask little more questions that we are used to hearing. You know, kab chal paunga? Can I do the things I did before? So that's the difference between that 1% of high performance that we talk about and what the recreational or the general population requires. Now, just to show, this is the basic report. It has to be, we of course discuss it with the coach, with the athlete, and if need be the team manager too. And we tell them, we give them a plan to what can be done and what most importantly should not be done. in a case like that. The actual report generated is a 5-page PDF minimum. The remaining 3-4 are all the graphs and, you know, how much it's going. So it's quite visually appealing actually. But many of my athletes or the coaches, they don't understand it, but we don't expect them to understand. So it's just like, you know, this, and after that a summary of what needs to be done from here on. The next test is again from a strength perspective is going to the endurance athletes. We have our runners, and from the last 2 years we are also monitoring the fast bowlers of the Karnataka Ranji team and the fast bowlers of the Rajasthan Royals on the VO2 max setup, just for them to last. How much can they bowl in that much time? 5,000 meters runners, 3,000 meters steeplechase, 1,500. So any of the long distance runners or even the mid distance runners, because this directly impacts how good their lung capacity is. Some are skillful. It's not a parameter for how skillful they are. Okay, it's just one of the parameters that we can imbibe in a good athlete history. So, I mean, VO2 max is like the mileage of the athlete. How much consumption is there at the cellular level of oxygen? A good car is known by a good mileage, right? And a good mileage, what all to be done for getting that good mileage? So, I mean, we do it, like in India it's still not there, but in UK, Loughborough University has this test suited for a wheelchair-bound athlete too. So we have cycle races in para-sport, and that's purposely I've put that picture. If you can see, it's a para-athlete, and then what are the factors that ultimately define the VO2 max. So again, quantifies aerobic capacity, recovery efficiency, so you have a beautiful graph. We want that graph to be like a nice, slow coming steep, that is delaying fatigue. And then once you fatigue, it should come down rapidly, which will enhance recovery. So you can easily see the graph and tell if it's more like a parabola and then another delayed, like a big, nice, curvy mountain, it's not a good space to be in an elite space. But if it is a very nice, steep, slope rise, hit a nice peak, and then drops down immediately, tells that there's very gradual levels of fatigue, and there's instant level of recovery that defines a good athlete. And of course, in the clinical space, of course, I don't work in this space much, but since I'm associated with an institute that does, I have the opportunity to see what is PQLI, cardiopulmonary fitness. What is PQLI? Anybody? Physical Quality Life Index. So it's one of the, I won't say the single most factor, but at least definitely in the top 5, which will define. A higher VO2 max will obviously tell you how good your lung and your heart are working. And you guys should be lucky that you are in Bangalore and not Delhi. And again, the life expectancy post-chemo, after they take the particular medication, how good they are. Of course, the speeds, the protocol are very varied. It's much more subdued as compared to an elite athlete. And the prognosis of various pulmonary conditions, COPD, bronchial asthma. But of course, you need to have an extra intensivist and a team ready if things don't go as planned. So the test looks something like this. That's again, I've given comparisons, our lab in New Zealand, and that is our very own in Ramaya Memorial Hospital. So that's an elite runner. He was again training for the Commonwealth Games in 2022 in Birmingham, and next is in Glasgow, so he's gunning for that. Able-bodied athlete, wonderful results. We did his lactate threshold also to see how well he's fatiguing and when he's fatiguing. Again, the protocol is different. Some like to have a warm-up, a gradual increase. Some like to go on an incline. Some like no incline, but take the speed to even 20 kmph, 25 kmph. We've gone up to even 26 kmph. Just that the limit of this treadmill is not more than 24 kmph. And the limit of that treadmill is around 40 kmph. So you can imagine, like, you know, humans, the fastest human, Usain Bolt in a 100-meter race, you know what his top speed was? Any idea, anybody? Top speed of Usain Bolt is 44 kmph. You know, that's the time he hit in that world record-breaking 100 meters. Yeah, and out of all whatever little I have done with my athletes, this remains my proudest moment while testing this athlete. and this is Mr. Sharat Kumar. You see what happens in the VO2 max test, right? You're breathing in an airtight mask, so you're at a point, it's very claustrophobic, okay? Now I'll give you another stat. This is a blind athlete. So he has no stimuli coming in from the visual senses, only the auditory senses. It was a Herculean task dealing with this gentleman. He went on to win the silver medal at the Para-Asian Games in Hangzhou in China. And we did around 3 tests on him with 3-4 months apart. And that was phenomenal in his training. So I would stand on his left while running, and I would tell him that, you know, Sharat, this is the speed that we are hitting now at 5 kmph, 8 kmph, 10 kmph. So he could only answer by his hand. He can't talk, he can't see. Okay? He can't talk obviously because of the mask. So I mean, what I want to do is that let's not restrict it to just a certain aspect or a certain few individuals who can do the test. We need to work ways around, get technology to people who, even to this population of people who are training at a certain level. And of course, this was another VO2 max chamber. Now, any idea what is the difference between this and maybe these two photos? If you've seen that, here what we did was that I was interning with the New Zealand Olympic team. They would create the whole atmosphere in this chamber as to how it will be in Japan. That time the Olympics was in Japan in 2021. It was delayed by a year. So what they would do is that they would see what is the temperature if the schedule is out already a year in advance as to when is the particular event happening, what time of the day, what will be the conditions like. So they simulate the environment there. In Japan, if it's 35 degrees, humidity of 70%, at an altitude of so and so, what will it be like running in that environment? It's not like, you know, you run here, you practice out in the field now, and then you go to maybe Chennai or Delhi and run. There is a lot of external factors which define performance. And again, it's the 1% club that I'm talking about, right? So in this chamber, we created a whole environment. By environment, I mean the physical weather of Japan, where the athlete will eventually be running. And we don't suffer inside, so we come out and we try to monitor and track what is happening with the athlete inside that chamber. So this was the start of it. This is, I think, a pic taken in Netherlands in the early 1950s, 60s. So this is how it was. So from there, it is taken as a good around 70 odd years, 7 decades of research. And we even have portable masks right now where we make the athlete wear it like a haversack and make him run on the track. So this is how it started. You see where to incline, someone had to physically, manually do it, and then incline, and the whole machine was behind, a very cumbersome and a tedious process. Okay, the fourth rather, the force plates. Ever heard of what force plates are, or what do they do? Why is it there? Okay, so it's just the mechanical sensing system designed to measure the GRF and moments involved in human movement. So as I'm moving, as I'm standing, the body is designed in certain way because we are bipedal, that I put my weight equally on both my legs, the right and the left. But for whatever reason, the weight keeps shifting. Now, if I'm standing and speaking before you all, it's okay. But if I'm playing in sport, for example, imagine if there's a batsman waiting. He faces in one side, right? If a bowler is coming, and you might have heard commentators say that, you know, he's a lot more balanced approach. He knows whether he's going front or back. He knows whether he's playing on the front foot or back foot. Or if he edges, he was in no man's land. What does it all mean? The science behind this is the balance and how much of ground reaction force you're exerting. Okay? In philosophical ways, you get what you give back, right? So it's just that. So even when you're sitting right now, you're not sitting equally, although your body is designed to do that, right? Then the technique optimization, loading asymmetries and load distribution on either side, followed by load monitoring, so important. You know, there's something called, the trainers would know, the acute to chronic workload ratio. That is again directly impactful and directly indicative of the injury prevention protocol. We have the old time school of coaching was, you have to work hard, you have to do this. I saw, even so many of the people, they keep on hopping you, hard work, hard work. I mean, I honestly, like in sport, I don't believe much in hard work as much I do in smart work. So it's also important to know when to conserve your energy and when to go for the full throttle, right? Then, so load monitoring comes in effective there, and the use of force plate is quite magical in that space. And of course, for screening and for neuromuscular fatigue. Now, when I say neuromuscular fatigue, when a particular athlete is injured, you're also training the mind. They are hesitant, they are skeptical. If I've had an ankle surgery, they don't want to keep that foot forward. So we have to actually tell them that, you're bearing this load quite well. And if they show them numbers on a force plate that we're doing it, they get that much more confident. And when they come back on the field, it's quite magical. Again, what are the applications? The applications, again, as I told you, I started with an example of cricket when the batsman is taking guard, when he's standing the way it is. If he's facing a bowler 140 and above, he has to maintain a certain balance. Because if he's not maintaining the balance, the reflex goes for a toss. Some, you might see, they are born with it. Some need to work hard. So again, this is again my stuff. We have the force plates here. So that, I'm not sure which sport the boy plays, but looking like a mid-distance runner. Again, to see how much of pressure he's exerting on either stuff. And that is again an achievement that we do on my para-athletes. He's a double upper limb amputee. He's a swimmer in the S4 category. All the para-athletes have a category. So he has no upper limb, ladies and gentlemen. Okay? And he's in a category which uses only his limbs to kick. So it becomes very important for me. So even for a swimmer, you might think he's not talking or he's not running. He is swimming without hands. It's just his leg movements and his body, how well it rotates. So for the leg to kick and propel his body, he needs to have as close to possible equal strength on both his lower limbs. You can do a single leg stance, single leg jump, double leg jump, counter movement jump. I mean, there are multiple protocols. This is just how it's done, and that's the beauty of a force plate. Again, you might have seen this regularly. Anybody who this gentleman and who that gentleman are? No? Footballers in the house? Harry Kane? Yeah? Ex-former England captain. Is he still the captain? No? No, right? Yeah. And that's Mitchell Stark. So you might have seen this in their training sessions that they have these fancy vests that they roam around. Some like to wear it outside, some like to... What exactly is in that vest? Any idea why do they wear it? Or, it's just for fashion. It's like quite horrible fashion, to be honest. But what does it signify? What is it? Ever thought of it? It has a GPS tracker behind, okay? Which tells us at the beginning of the session and at the end of the session how much a particular athlete has covered a certain distance, right? So similarly, it's like, tracking acceleration, deceleration, sprint counts, change of direction. Change of direction, very important in a sport like this, which is hockey. That's our Indian team captain, Harmanpreet Singh. And it also helps in enables a comparison between training and match loads. So some athletes prefer to wear it even during the international match when it's going on. So then they compare and contrast as to, are we matching the same intensity in the practice session like how we have it at the match or the game time? Okay, if the answer is yes, that means again the training is going well. And if the answer is no, again, why is it no? Why isn't he matching up at the same speed? Or some athletes we have seen are going great guns in the training session, but on match day, they completely fall flat, right? Then prevents overtraining, assists in recovery planning. So again, we're taking baby steps. Now, I don't know whether you follow the IPL or no. I'm presuming you do. We had Sanju Samson had a side strain, against in one of the matches. So when we were getting him back ready for the 10th match or the 11th match, we had to track his movement. And we can't track his movement he might have faced 1,000 balls, or he might have run maybe 200 meters. It's not maybe anymore in that environment. Okay? Then again, real-time data and also tactical planning. So this also helps when our analyst is visualizing how our players are moving. So that's an infographic of a penalty stroke in hockey. It also sees how effective our boys are moving to plan and counter plan much better. Then of course, it's everybody's favorite, the wearables. I'm wearing one now. We have your watches, you have your phones connected to them, the rings and whatnot. This is again for a very lay population, or some of the athletes also wear it. Tracks sleep, hydration, which will later define the nutrition and how much you're consuming. It gives us a fantastic idea of how much to give to the athlete in terms of nutritional consumption and water intake. Key in lawn training camps, obviously, we can't have the big labs everywhere or the portable devices, or we want to irritate the athletes now and then. So just give them a fancy watch and tell them that it's sponsored. They're more than happy to wear it, and then we can track their movement on our devices and then see how it goes. Right? Then of course, in long camps, in the microcycles over a long time. So every 4 years, there's a macrocycle, then the meso, micro, nanocycle, and then it comes on to the each rep and each set of what the athlete is doing. And of course, for the female athletes, we have even menstrual trackers and how that impacts physical training. So everybody, if there's an important final jump in the Olympics, the third jump, you have to go for the world record or the medal jump. You need to have to know at what day it is of your follicular levels, your ovulatory cycle, or what phase of the menstrual cycle that you are in. The trackers are excellent in that way. Some of the examples: hoop strap, continuous glucose monitoring. Now also we have smart shoes. Nike is coming up with one of them. They have the smart insoles, which will kind of tell you at what level of the foot and at which space are you putting that much pressure while running, walking, jogging, or whatever. So this is what the watch will tell. I'm sure any one of you who's using an Apple, Samsung, or the Garmin watch will be familiar with these kind of readings. Resting heart rate. Is this good? A resting heart rate of 43 and a VO2 max of 49. Okay, not okay, pretty okay. I think it's pretty good. I mean, I wouldn't do much to this gentleman with this kind of readings. And then the other part, the most important part actually, is your body composition analysis. You know, I should have actually started my talk with this, because this is what we do when any athlete walks in to know. It's not just how much you weigh or mujhe weight loss kam karna hai or something like that. And we take calls like, I want to lose 2 kgs in the next 3 months. Those are yours and my goal. But at the elite level and even at the recreation level, I think of body composition analysis. What is your fat mass? What is your fat percentage? Skeletal mass distribution. Like, where is it? Is your visceral fat? And this new term come up with TOFI, TOFI. Have you heard of it? It's directly related to all the lifestyle diseases. TOFI is thin out, fat in. Okay, so you might appear to be a very lean person, but if you have fat in the wrong places, you will have poor prognosis and higher chance of comorbidities later on in life. So again, in the clinical environment, it's sarcopenia, very common that every year we are losing 1% of muscle mass after the age of 40. That takes it to almost 8 to 10% per decade after the age of 40. That's why strengthening is so important. And then of course, post-THR and TKR, a total hip replacement and TKR, it helps in how well you're recovering. So we have some interesting things that we do with, that's the DEXA scan. Very minimal radiation if people are worried about the radiation exposure. But again, it gives you very nice data about how the body composition is. And that is the in-body. Are we done? Oh, okay. I'll just wrap this up quick. So again, the decision making, why are we dealing with so many numbers, so many things? It's all on a platter. Integration of data for holistic athlete care. Then, you know, we sit down, we have our team meetings. The input is there, analysis, and then how to intervene, when to intervene. And the bigger question, do we really need to intervene sometimes? So the drawbacks, obviously, cost effectiveness. Everything I've spoken costs a bomb. Okay? The IKD chair goes to almost 75-80 lakhs. VO2 max, 25 lakhs. So it doesn't come at a cheap price. You have to justify why you're taking it. If you're having it in an institute, if you're having it in a certain place, you have to justify the cost. Then research, some people don't like research in that elite space because of the privacy of data, which is a big thing in elite sport. Then, of course, the practical implementation, everyone can't have access to all this, so we need to have other ways to go around it. Yeah, the key takeaway is just this: technology enhances clinical judgment. I have a lot of coaches getting scared to use technology. They tell, okay, will I be replaced by it? But so my answer is that you won't be replaced by it. You'll be replaced by another human who's learned how to use this technology. So again, objective data, collaboration between tech and all the medical staff, SNC coaches, sports science team, nutritional, psychologists. We come down, sit together, and then come to a final conclusion. That's it from me, ladies and gentlemen. Thank you so much. Jai Hind.
Thank you very much, Doctor, for the fantastic presentation. So I have, I want, what is your key take on this? So we do have a lot of external, internal load monitoring. Like we do a lot of trim calculations. We use a lot of rescue questionnaires, heart rate variability. As you said, acute to chronic workload ratio. A lot of internal, external monitoring we do. But still, if I see the incidence of new injuries, if you see the statistics, it keeps increasing as the year goes by. So in spite of so much advances,
increasing as
the number of injuries.
Okay.
So the statistics keeps increasing. So what is your take on this? In spite of so much advances in the data analysis, load monitoring, why we are not able to still, exactly can't prevent or can't bring down the number of injuries?
That's a good question. I have two answers for it. One is that maybe back in the day, we never measured so much to understand that there were so many injuries. So, so it's not that if we don't track it, that there were no injuries in the past. There were injuries, but just that they weren't reported. That's one thing. Secondly is that I see there's a huge divide between elite sport and the recreational athlete, where the previous slide where I told, no? This one. We've made such tremendous progress that we've started to label everyone as something or the other. Now, in a situation like the IPL, you're playing 14 matches over 2 months. The life of an IPL player and support staff is not as hunky. It's only 3 things: airport, ground, hotel. And there's a very high intensity game happening every 3rd day, if you notice. Extremely high intensity. Okay, so back in the day, maybe it was much more spaced out. I'm just talking about cricket. You talk about even the swimming federation, what is happening right now. There are nationals held almost every month. And even if there's no national held, there is an inter-school competition. It's very difficult for trainers to even plan the LTAD or the macro cycle. So how much are we overtraining the boys and the girls? Right? So back in the day when they say they didn't have opportunities, now we are facing a whole sea change where we have only opportunities everywhere. You have a doctors league coming up, you have, so many other leagues coming up here and then. So one is the quantity of matches, maybe affecting the quality of matches. And second is that so many over-testing has been done and over-diagnosis, as it in one of the slides, that, sometimes the practical implementation, sometimes the best implementation is to not implement anything, just to observe. I think that...
Thank you very much. Any questions from the audience?
Yes, sir. Good afternoon, Amay sir. It was a wonderful presentation with a lot of information. I had one question because it was in my mind when I attended one exercise physiology seminar and workshop. There was one foreigner presenter who was talking about, he said Indians can never win 100 meters race. And we just asked, why do you think so? So he was talking like, he was talking in terms of genetic ceiling or the influence of genetics on VO2 max. So of course our athletes have proven him wrong by like our javelin throwers and our shuttlers are proven wrong. But I would like you to enlighten us with this. What is genetic ceiling and genetic influence on VO2 max? Thank you, sir.
Thank you, sir, for the question. I mean, I would partially agree with the foreigner. And the reason is that, I'll give an example. You take hockey as a sport, right? We were world champions. 6, 7, I think, medals on a trot consecutively. in the 1950s, 60s, 70s. Okay? And then what happened? For 41 years, there was a medal drought. What happened in those 40 years? Did genetics change? What happened? What was there that transformed so much? Did we stop playing hockey? Did money didn't come? Money was not there that time also, it's not there now also. I mean, so that was not there. What happened was that in the 90s and the late 90s, in spite of having the great Dhanraj Pillai captaining our side, we won Azlan Shah and local matches, but never at the Olympic level, which is the epitome of success in hockey. One thing happened is that the field changed. From a grass, natural grass, it changed to a turf, right? So hockey, from a skill-based sport, became a hit-and-run sport. So it took us that much time. In Tokyo, when we won the bronze, it was after 41 years that we won the bronze. Excuse me, sir. Sir. Sir, I'm answering a question. Yeah. So after 40 years when we won the game, the turf had changed. So to plan for that, it took us 5 years. Skill was there. Hit, and when you run, that speed didn't match up with our European and the Australian and Kiwi counterparts. So to come till there, it takes decades of change. So I'm not saying there won't be any in the future, but it will take time for us to get there, depending on how we train. In fact, there is a boy in North Karnataka or in Telangana side who is creating ripples right now. He's around 20 or so. And also the culture, the running culture. Now it's always been there. Now I'll give another example of Mr. Avinash Sable, 3,000 meter steeplechaser. He won the silver in the Commonwealth Games after almost 27 years. And he's the only non-Kenyan to come on the podium in 27 years. So, but you can imagine since 1992 till 2022 in all the Commonwealth Games, Kenya had the top 3 finishes. For the first time ever, we had a non-Kenyan. So it's not going to happen in a day or even in a year or two. It will take a good 5 years to a decade to train in that particular way. And then hopefully we'll produce an athlete in track too, and not just in field.
Thank you, sir.
Anything else? No?
Thank you, Dr. Ramya Kagli, for this insight into how you train the athletes and what is the role of a physiotherapist. It was really interesting, especially for the people like us who are non-physiotherapy background. So looking at all those pictures.
He's not a physiotherapist.
But he was given...
He's a doctor.
Okay, but you are doing a physiotherapy.
No, he's not physiotherapy. He's sports medicine.
Sports medicine, okay. Okay, so but it was insightful how you train the sports people and how you tackle the different challenges of the para-Olympic people also. So thank you so much for the talk. I'd like to call upon Pushpa Sarkar ma'am to please come and felicitate the speaker.
Dr. Ameya is a doctor, basically. He's done his specialization in sports medicine, and he goes as a resource person across the globe. Thank you, Dr. Ameya, for being here.
So as a token of appreciation from our end, we would like to give a memento to Dr. Ramya Kagli and a certificate from School of Health Sciences, Dayananda Sagar University. Thank you so much, Dr. Kagli, for coming here. Thank you. We would like to thank Dr. Prabhu Raja for chairing the session. Thank you, Dr. Prabhu Raja, for coming here and chairing the session for us. Thank you. Up next, we have the last session before the lunch. The session is of Dr. Padmanabhan Shekharan. Dr. Padmanabhan Shekharan would be talking about zero gravity training, what is possible. The session would be chaired by Dr. Shri Raghunath. I would request Dr. Shri Raghunath to kindly come up and take the chair on the dais. Welcome you, sir. Dr. Shri Raghunath is a Dean S. Vyasa School of Physiotherapy, Bangalore. He is consented to be the chair for this session. I would request Dr. Shri Raghunath to kindly introduce the speaker.
Thank you, madam, for that nice introduction. It's indeed my proud privilege to introduce Dr. Padmanabhan Shekharan, the resource person of the day. Dr. Padmanabhan is a specialist physiotherapist with 25 years of tertiary care, orthopedic and sports rehab experience. He is a clinical and administrative leader with 10 years of leadership experience handling the rehab services vertical of major hospital group. He is a visited consultant for Emirates Healthcare Provinces UAE. He is an international educator with over 195 workshops and CPD programs delivered across multiple countries. Also, he is invited faculty for national and international orthopedic and sports medicine, orthoscopy and physiotherapy conferences across the globe. He has published, authored with 25 international peer-reviewed publications, which include Journal of Orthoscopy, Journal of Shoulder and Elbow Surgery, European Journal of Orthopedic Surgery, International Journal of Orthopedics and Cochrane Review Protocols. Med-ed entrepreneur and physiotherapy futurist for tech convergence in rehabilitation. As I said, it is my proud privilege to introduce Dr. Padmanabhan Shekharan. Sir, over to you.
Okay, guys, good afternoon, and thank you, the Dayananda Sagar team, for having me here, the Vinod and team. Yeah, you know, Bangalore traffic, it took some time, but I appreciate you have put together a beautiful conference with so many speakers, and I'm really happy to be among one. I'm going to talk about zero gravity training. Primarily, we use the only way by which you use the zero gravity now is by a zero gravity treadmill. We have one. We thought we will share the experience with you guys. So there are three parts to my talk. The first one, I'm going to talk about the technology. Obviously, this is a technology conference, so I'm going to talk to you about the technology, the zero gravity, and then how do we use it, the clinical applications in terms of what the technology kind of tells what is possible. And then we'll also share, we have been using it for some time, so we'll share what are we able to do with this. Hopefully, it will provide you some inspiration into taking nap. Okay. Okay, before we start, I'm sure everybody has heard about this. You know, Newton discovered gravity. Good news, gravity was always there. Yep. So he just found an interesting way of, you know, looking at an apple, that's all. What actually Newton did was this, okay? He defined the laws of gravity, okay? So he defined the laws of gravity, that's what he did. Okay. Of course, I'm in an engineering campus as well, so I won't pretend I know them. I actually don't know the laws of gravity. Okay, what I know is very, very simple, which is relevant to whatever we are doing. What we know is everybody here has got a mass, every object has got a mass. That means inherent to its material, it has got some mass. Okay, that's what it is called. And then when you actually measure the mass against the gravitational pull, it's called as your weight. Okay, and we are all obsessed with weight, is it not? Body weight, okay, weight and all that stuff. So that's the relevance of gravity. Okay, there is nothing as a human being in Earth we do without the reference to gravity. Just imagine this. Good. Physiotherapy, everything is about weight, is it not? Yeah. Just imagine this. We all have dumbbell, we have resistance, but then this is all about weight. I have an interesting question to ask you guys. Okay, if you are not very hungry and not busy talking to each other, probably you can think about this. If we take off the marker, okay, you can see that the dumbbells are of same shape. Okay, the dumbbells are of same shape, and then obviously there are of different weight, and for some reason, if we don't mark them, okay, and then put it in a physiotherapy department, would any physio or anybody for in a gym, wherever, would you be comfortable picking them up and then prescribing based on which one comes first, which one comes second? How good are we, okay, when it is not marked? You want to know the relevance of this question? Yes, no? Yes? No? Okay. Yeah. Because we made it easier for us to, okay, define and classify gravity, but the gravity is all around us. And if you have an ability to use that as a gravity, as a prescription, then you can redefine what we do. So that's essentially what I'm going to talk about. So when we talk about, clinical applications, we are talking about how do we use mass or how do we use weight, and then we call in the clinical terminology as load, okay? So of course there are various definitions to load, but here the load basically means the weight, which I showed you. It can also means resistance. It also means how do we use gravity, okay? This is something which I have added now, okay? Why do we have to use it? Because you want to make sure something adapts. That means you use weight to lift, and then your muscle become bigger, stronger, okay? You use your body weight, and then it becomes, you get good at some of the movements. Same way, if some structure is injured, okay, you use weight and resistance. We know the TheraBand, the blue TheraBand, which we tie to one end and then pull, okay? Yeah, that one. So you use weight to also give what we call as biological and mechanical cues. And then if you give biological and mechanical cues to a structure, the structure adapts to it, okay? This adaptation is what actually we use to basically address a dysfunction and also facilitate repair in tissue, okay? So that's why it is important for us to prescribe load. So we also gotten a little better at prescription of load, because we know that each structure can adapt a little different to different type of loading. For example, a muscle, tendon and cartilage. So you have the knee joint, okay? You have the patellar tendon, you have the patellofemoral joint, and then you have the patellofemoral cartilage, okay? And you know that a same exercise, if it is prescribed in a different level, it can be directed towards the cartilage or a tendon or a joint adaptation. I'm sure you guys are learning about it, okay? Because the diagnosis, what we treat knee pain, but if you are able to prescribe and then treat patellar tendon pain as opposed to just knee pain, your treatment is going to get better. So how do we use resistance or load as a prescription? If it is healthy, you want to improve performance. If it is injured, you want to get it back to performance, or you take care of pain. You want to adapt, so okay, you want the structure to adapt. Somebody who has a patellar tendon problem and then he wants to do something like, jumping and landing, which is part of basketball. Somebody has a patellar tendon, but he wants to actually kick a football, generate force, different adaptation. Somebody has a patellar tendon and then they want to drive in Bengaluru traffic. Somebody has patellar tendon and then they just want to sit. And then, these guys, physiotherapists. Here? Yeah? No? Okay. So what are the adaptations? This is defined by what are the functional demands. So the load has to be different. The prescription has to be different. The way we prescribe load is like this nowadays, okay? It is easy for us because you have different levels of resistance and they're all marked. I gave you have a barbell and you know how much is the weight of the barbell. And when you do a squat or when you do a deadlift, the aspiration is for you to do, say, for example, I want to do equivalent of my body weight. I'm a 60 kg man and I want to do a 60 kg barbell squat. Easy to measure, easy to progress. You also want to do it for different, resistance and all that stuff. But if you're having somebody who's actually running, okay, or somebody who's, in your biomechanics book, you would have read actually about prescribing load in terms of, say, climbing up and down the stairs. So it says about 8 times your body weight. It doesn't say how many stairs. If I do it for half an hour, it's different. If I squat, it's 4 times your body weight across your knee. So you can measure with gravity or the load by using the proportion of body weight or with the external resistance. Now, what I'm here to talk about is fundamentally change the way you define load prescription. Okay? So, the load prescription, if you have taken the gravity off, okay, then if you are prescribing it in zero gravity or a microgravity environment, then the prescription is completely different. Only if you understand the concept of load prescriptions using resistance, then you will understand the concept of how do you actually take the load off and then reintroduce for specific adaptation. That's what I'm here to speak about. Yeah, I hope. So this is what we use. We use a R-force, BDL R-force. Okay, this allows us to offload a 135 kg man to almost zero body weight. Okay, it literally lifts this guy 135 kg man, and you can do 100% body weight. There are very few in the country. There are only about 5 or 6. We have one of them. We are fortunate to have one, and then we're able to do some actions, meaning. So the action of mechanism of action of the zero gravity is very, very simple. It looks like an air-filled chamber. Okay, it fills the air, fills it very fast, and then lifts the man up. Now that is not where the technology is. You know, the technology is like this. When you're actually lifting somebody up, you can measure how much is his body weight. But when he is moving in air, that means the person is actually walking, squatting, jumping, landing. Okay, and then you are modifying your parameters in terms of I want 50%, I want 30%, I want 60% of body weight. For every change in the action and for every change in the parameter, the air pressure changes automatically. Okay, that's where the technology, that's why it is super expensive. Okay, it's a 1 crore piece of equipment. So you are able to, it's called as the differential air pressure system. So it is able to sense the change in the movement, it is able to sense the change in your action, and then you can also prescribe the zero gravity or the microgravity as a load. Now quickly about the technology, you can achieve unweighing, and then you can change the speed of walking. The machine that we have allows somebody to run at the sprinting speed. Okay, so you can run at a sprinting speed without load on your leg, and it has some applications. I will show you what they are. And obviously it has other applications in terms of you are able to have a real-time feedback on somebody who is actually having no feel of how to load the leg symmetrically. I'll give you case examples. Okay, you show them the feedback, you all know about the visual feedback, and then you keep the environment changing, and then what it does to the gait is phenomenal. Okay, and we have some case examples. And that's all about the technology. And of course, you will be able to get the gait symmetry. Okay, the treadmill platform has got a sensor which will actually measure accurately the step length, the speed. It also gives you how much load you're putting and then how much symmetry. As you can see, this is an example of, okay, it doesn't work. Yeah, okay. This is an example, you can say 48 centimeters of step length symmetry. And then it also gives you step width symmetry. Okay. And the best part is when it integrates both and then gives you something like that. Okay. The change in center of pressure when you take step and when you take multiple step over time. And if you are able to get that butterfly pattern perfectly, then your step length, step width, and your swing phase, everything is integrated perfectly. Okay. For someone who has had changes in load and deviations in gait, this is just a game changer. Okay. And then we are able to show them objectively how to achieve this over time, and then how we can tweak the gravitation, the unloading or unweighing, and then get them to gait symmetry first and then reintroduce the load, and it has done wonders for us. So there are preset protocols. Obviously, you can make somebody walk very acute. So we have made somebody after say orthopedic procedure like a high tibial osteotomy to walk as early as 4th week symmetrical gait with the offloading. So unweighing here, you can see the prescription will be about 65%, and then you can increase or decrease the loading. There are set protocols. There are set protocols for this. You also have return to play protocols. One of the best thing about the machine that we have is it allows you to run as a sprinting speed, as I said. So somebody who is recovering from a bone stress injury, we have managed to get them running at a marathon speed, okay, as they were recovering. Otherwise, it was rest, okay. And then here, we are actually keeping them running throughout. So that's the implication. So the progression for speed is different The progression for endurance is different. The progression for strength is different. These are preset protocols. But then when you put the load symmetry, and then you have too many options for you to actually prescribe and then progress these loads. Then comes the weight loss, which is not something which we use. But then in terms of clinical application, we found that this is something which is actually of a huge impact. You know the prescription for somebody who is with a ONE, okay, who is weighing heavy and ONE, not able to walk. You know what is the prescription? Okay, don't climb stairs, please walk and reduce weight. You understood? And how? Okay, and then we prescribe isometric quadriceps, resistance, and then diet. Nothing is going to work. So that is where this comes in. So you are able to take somebody who is overweight, and then you are able to make them walk at a normal or even an exercise walking speed, because you are taking the load off, and you are able to do it at least 3 times, 4 times in a week. Okay, and then you see their body weight changes, you see their strength adaptations happen, and then it completely redefines the way you are actually treating somebody with lower limb arthritis. Okay, and you will be so surprised how much it means to the patients. Okay, it's actually, that's why the 135 kg unweighing is very important. Okay, because you will be able to lift that heavy a man, and then 100 kgs and 90 is very easy. Then it does significant clinical, it adds significant clinical value. Okay, so this protocol especially. So there is research. There are research now. As you can see, the research is fairly recent, because not this technology has been around for some time. AlterG has been around for some time, but it has its own limitations and all that, and primarily nobody understood how much you can use it on the clinic, and it was restricted mostly for sports rehab of an elite athletes. But right now we can do much more than that. So there are papers, and you can see it is 2022. This is post-op patient, 1 year follow-up, and then it says about better gait and then muscle atrophy. Because you are engaging the muscle and then you are engaging them in functional activity, you are able to prevent your muscle wasting, because they are working through the function, and you are able to get this. And you also have studies which say about using it on total knee replacement, meaning we use it on TKR patients who come with a loading symmetry and then a gait deviations, and then they are really getting better. I told you about the step length and step width, and then the butterfly walking pattern with symmetries, integrating the stance and swing phase. It does wonders for these patients. Then comes, there is a comparative paper, again 2023. So they have used it on hip replacement patients. So we have used it on patients who have had avian surgeries. The avian surgeries, by the time the patient goes in for a surgery, already he is limping, okay, for 2-3 years. Okay, his gait pattern has changed. And then the surgery, you do whatever, if you do core decompression or you do replacement, whatever you do, you're going to take some time for you to restore that symmetry in gait, because you've forgotten. Okay, gait is more about your memory, is it not? You've forgotten. And irrespective of how much you train your hip abductors, how much you train your walking stance and balance, there is value. But then for it to integrate into function, it takes quite a bit of time. And then here we are able to do it pretty quick. Okay, we do use in a lot of avian patients, a lot of hip surgery patients. And yes, of course, post-operative injury patients. One thing that happens in post-operative cases is you have this deconditioning effect in your body, because you are walking with your walker, you are walking with your crutches. How much do you walk? Do you walk as an exercise? You don't walk as an exercise. You walk for your function, is it not? And that's about 6 weeks, that's about 8 weeks, sometimes it is 10 weeks. And if you're actually not having exercise for that period, then the deconditioning effect sets in, and then your complications sets in. So here, you're able to offset the deconditioning effect. So there are changes in your metabolic parameters as well. And this is something which we found. The question obviously remains that human beings are designed to walk, you are supposed to run, and then you are running over ground. And then here you say that you are able to lift up, offload the gravity, and then run. Does it have the same effect? Okay, there somebody has studied. And when you can, because that's the advantage of the new age treadmills, because they will be Okay, guys, I will appreciate if you can talk a little less among yourself. Okay? Okay, thank you. So, you will be able to improve the sports performance of somebody running at a sprinting speed and then keep the performance. I have a couple of case examples of this. We are learning this because there are no textbooks which are saying this. We are learning this. And then it has done wonders for our patients. I'll tell you the examples. So it is possible for you to run in a microgravity or a zero gravity environment and then enhance your sports performance. This is actually a game changer. This is actually a game changer. So those are my case examples. Okay. So this is a patient who came to us with post-op TKR, and because it is unilateral, she had difficulty getting gait symmetry, walking, and then she had something very, very specific. She came to us 6 months post-op. Whenever she has to walk on uneven surface or climb down, she wants to trek, okay, climb up on an uneven surface, she has difficulty, and then she's just not getting the symmetry. So we put her on the protocol for gait symmetry. You can see that she still has a varus on the left knee, and then we were able to get her gait symmetry, walking uphill, and then improved walking endurance, ability to do exercise, walking as an exercise for a longer time. Okay, those are the things that we were able to do. This is an example of post-op. You know what happens in a tibial condyle fracture, is it not? 3 months to 6 months, you are actually not able to load the limb, and then by the time you are able to load the limb, okay, you realize that you are actually not symmetrical, and then it takes about 1 year for you to recover. Here, we are able to get this guy to do this, okay. See what he's able to do? He's able to run after a tibial condyle fracture. 6 months post-op. You know why this is important to him? Can you see him? He's a little obese, okay. And then you keep him grounded because of the knee fracture for some time. The guy is going to get more weight. And you all know that when there is an articular fracture, tibial condyle, you are going to also develop early onset of osteoarthritis, and then you're going to add weight to it, and it's going to be detrimental, one fracture. So that's advantage. We are able to give him a healing stimulus, get a loading symmetry, and then able to make him run faster and then lose weight. This is somebody who had a patellar fracture, and he came to us 9 months after patellar fracture. You know what patellar fracture does, is it not? He also developed chondromalacia and absolutely zero ability to climb up and down the stairs. Okay, and then here we are able to prescribe him a single leg squat. Okay, and then we are able to offload and then progressively induce the load, and the guy is able to climb up and down the stairs normally. A lot of time it is mostly the inhibition and then the lack of movement and the inability to load that causes this, and we are able to restore this. This is a phenomenal story. And this is something which is emotional and close. The man is very big, okay, and as a cervical myelopathy, with him walking for the 2 years, he wrote a very emotional LinkedIn post, okay, and his walking, if you see over ground, I don't have a picture, he needs support of 2 people to walk, and then takes a very small step, okay. We were able to put him on this and then give him that butterfly pattern, okay, step length, step width, and loading symmetry. He was literally in tears after this. And this is an endurance runner. The guy finishes, if you Google him, you will see almost in every marathon in the country, this is the guy who finishes first on the podium. He is a 10K, every TCS 10K, he is on podium for the last 3 years. He tried to transition from the 10K into half marathon at the same speed, okay. At the same speed, guess his speed of half marathon. His half marathon is 1 hour 13 minutes, okay. That's fast. Most people run a 10K around that time, okay. And then he developed a stress fracture of the fibula, okay. And he has, when these guys run, they run multiple events in the same year, every city, and these are all brand ambassadors. So we were able to keep him his running stride and his running speed throughout the recovery of the fracture, okay. He doesn't feel the pain of the fracture, and then we obviously did something for the fracture as well. We are equipped to deal with it, bone stress injury, and then we kept him striding. The guy finished on the podium. He in fact got his best timing okay, recovering from this. Took us 10 weeks from a stress fracture of the fibula. The guy was on the podium, okay, and he wrote a beautiful Instagram story on it. And this is the latest we have seen. So, young 14-year-old female, okay, sprinter, national level sprinter, overtraining, came to us with a navicular bone stress fracture, navicular, okay, and career done, okay, immobilized and all that. She had a national, she has been traveling, meaning she has been training for this national event, Junior National Athletic Championship, which happened last month, for her lifetime. And then they put so much, and then you see the MRI, and then people think that, okay, you give up your running career forever, okay. And then we took her, I think the coach has written a post, okay, it took 40 days, that's what he says, okay. We took about 7 weeks, and then that's what she was able to do, okay. Can you see that? So the treadmill allows you to run at that speed with an offloading. And then she won a silver, okay, and she won a silver and she won a gold, 2 medals after recovering from a navicular fracture. So it is possible, okay. We also have grade 3 avians where we are able to increase their walking distance. We have fracture femur neck. This patient was very interesting. You know, when you see patients with femur neck fractures, which is fixed, and then you see them walking with a 10 lumbar gait, and then you are trying to, you know, improve their hip abductor strength, but because there is a screw, there is only so much that can be done. And then this guy also had a delayed union. That means 6 months he came, the fracture line is still not united. And you all know when we load a joint, when we load the bone, you can unite, okay? We didn't actually start with the goal of, you know, fracture healing. We only wanted to normalize his gait, because when you are walking with the 10 lumbar, when you have pain, there is only so much you walk. You walk about, say, 500 meters, okay, or about 1,000, 2,000 steps in a day. And then here you put them on a loading cycle, and then you make them walk at least half an hour to 40 minutes, okay, and then do it repeatedly, at least 2 to 3 times in a week. And we were surprised, the surgeon was surprised, that the fracture actually united, okay, in 4 weeks' time, okay. So the healing stimulus can really make a difference. Ideally, I should have gotten the X-ray. We also have an international tennis player who cannot be grounded. She plays at a very high level. Tibialis posterior tendonitis, we are able to keep her load. The load management is completely redefined. We were able to keep her running throughout her rehab process, okay, while she was hardly able to do a single leg heel lift. We also have a patient with a calcific tendinopathy of an Achilles tendon, senior runner. He runs a running group. He is very highly respected. He runs a running group he trains most of the marathon runners who finish on podium. He himself finished on the podium in every race. People are looking up to him. Calcific tendinopathy, bilateral. His goal was very, very simple. I don't just want to imagine somebody is limping, and then he says, I don't want to just run. I also want to keep my time. Okay, we were able to do this. Okay, we also treat quite a bit of ankle injuries with osteochondral defects of the talus. We have a case series of 12 patients actually on just this one. So that's essentially what was my topic. So zero gravity training, what is possible? Actually quite a lot. And that is what we use, the R-Force. It's a cutting edge rehab technology, and the future health is already here. Thank you. Yeah, 8 minutes. Okay, thank you.
Thank you, Dr. Padmanabhan, for its insightful information on zero gravity training. I just have one question here with regard to how soon an athlete can get back to this zero gravity training.
Day one.
Day one?
Yeah,
wow.
yeah.
Okay, right.
It's possible.
Excellent. Any questions from the audience?
Yes, sir.
Good afternoon, sir. Thank you for being with us and giving this wonderful talk. Of course,
my pleasure.
as you said, it's a new field where not only sports, even other rehabilitation centers are exploring these possibilities. Of course, you said these instruments can give a lot of objective values.
Yep.
Yeah, but one thing which probably I don't know whether the studies are there or not, we say that our muscle actions are largely influenced by the gravitational force, right?
That's what we believe.
Yeah.
Okay. It's not zero gravity, it's a microgravity.
Yes.
That's what it is. The
So,
prescription is microgravity.
I would like to know whether, how could be an muscle recruitment happening inside this controlled environment, sir? Thank you.
Good question. Thank you. Okay. The answer is very, very simple. Okay. When you have injury to any part of your body, what does the muscle do? What does the muscle do? It works or it inhibits. What does it do? It inhibits. Okay. How do you facilitate the muscle? What is the best form of facilitation for the muscle? Okay. You can stimulate, obviously. Okay. It is physiological, but it's not functional. Okay. My quadriceps is adapted to walk and climbing up and down the stairs, and it can recruit the best when I recreate the function. So whenever there is injury or pain or surgery, okay, the muscle recruitment is the one which goes off. That's why the muscle recruitment goes off, your gait pattern changes, your function gets affected, and then you develop long-term physiological changes, including muscle wasting. How do we offset it? By reintroducing the function faster, okay? And that's what it does. In fact, it actually recruits the muscle faster. That's what we are learning, and that's what the research supports in terms of muscle recruitment, metabolic, and then movement memory. In terms of running, the running form is actually better because when you reintroduce the load. So that's what we are learning. It's going to change the way we actually prescribe. 26 years, I thought I knew things, okay? And then technology came and did something else, okay? And then we are very fascinated that we did something like this. And then every day is a learning, okay? That's what I'm here to share. Yes, ma'am.
Hello. Yeah. Thank you, Dr. Padmanabhan, for a very interesting talk. This is something which we had not heard about.
Yep.
So you're telling that zero gravity, microgravity thing. Will it not, like, you're telling from the day one you can put the person onto this microtherapy or this zero gravity training. So the healing or something is not at all affected by
no, that's what I'm saying. Load is a healing stimulus. That's what I changed. I started my slide with it, okay? So load is a biological and mechanical cue for healing. There is a very famous dialogue. The guy who actually, how many of you know who is Philip Glasgow? Do you know Philip Glasgow? Okay, how many of you know the peace and love protocol? Okay, heard of the terminology called optimal loading? Okay, so the optimal loading basically means that you don't immobilize the structure, you start loading it so that it recovers faster, and there is enough science with this, okay, in this field, and there is a 2015 paper which is explaining, and his dialogue is very, very simple. When you ask this question, when do you want to load, okay, he says day zero, moment zero. Day zero, moment zero. That's essentially what is the prescription for load. Obviously not for fractures and not for unstable injuries and all that stuff. But then there are ways by which, for example, you can immobilize the knee and then still do what we call as axial load. So there are ways for you to start loading for a healing stimulus. Okay, it does heal. Please. Okay, my pleasure. We done?
Yeah.
Okay.
Any more questions? Thank you. Thank you so much. Thank you so much, Dr. Padmanabhan, for this wonderful presentation.
Yeah.
Thank you.
Thank you. Yeah.
Excuse me, sir. One more question.
Yeah.
Sir, when you are the patient is taken in the anti-gravity or microgravity environment, I wanted to ask about what happens to the circulation.
What happens to the?
Blood circulation.
Yeah.
In normal gravity, what happens is when we are running, our calf muscles just pump and the venous return happens. But what happens in the zero gravity? Is there not blood pooling or is there pressure variance?
No, nothing happens. Okay, it stays exactly normal. That is the best part of the technology. I told you about the differential air pressure system. I told you about the differential air pressure. As your body moves, the air basically changes so that it really does not really apply a lot of compressive pressure and lift somebody up. That's not what it does. Okay, so it actually changes every time you move, and that's essentially what is the ingenuity of this technology. So the circulation, we also had these reservations. For example, you put somebody with, say, hypotension. So you put somebody and then you lift them up, whether there is pulling of the circulation or where there is more blood flow to the upper body. Nothing like that. Physiologically, they have measured all of them. It is possible for you to keep the physiological adaptation completely normal by using or changing the air pressure according to the movement. That's essentially what is the technology. You should experience. Okay.
Yes, sir. Thank you, sir.
Yeah, thank you.
Thank you, Dr. Padmanabhan. Thank you so much for your talk. I would request Dr. Pushpa Sarkar to please come up on the dais. So please be in the center stage. We would like to present you with a memento.
Okay. Thank you. Good.
I request ma'am to present a memento and a certificate from our side to Dr. Padmanabhan Shekaran for his contribution to this scientific sessions.
Thank you for
Thank you, Dr. Shekaran, for being a part of this scientific deliberations. We would also like to extend our thanks to Dr. Shri for chairing the session. Thanks, sir, for coming here and chairing the session for us. Thank you, everyone. Now we are going to break for lunch. So we'll have a half an hour break. It's 1:45 right now. It would be nice to have you all back by 2:15 so that we can start with the afternoon sessions. We have 2 more sessions in this arena and others will be in the gallery hall. So please pick and choose your topic of interest and be seated there by 2:15. See you in half an hour. Thank you. Nice to have you. Thank you, sir. It was a very interesting talk.
closely, really closely. We measure small things, really small things. Because when you understand small things, you make big things happen. Let's look closer. We help the world's leading companies, universities, and researchers to work on everything from the medicines that cure us. The foods and drinks we enjoy. The materials we build with, and the energies that power us. There is potential everywhere to make a healthier, cleaner, better world together. Because we know that when we make the invisible visible, we make the impossible possible. How do you see the world? We look closely, really closely. We measure small things, really small things. Because when you understand small things, you make big things happen. Let's look closer. We help the world's leading companies, universities, and researchers to work on everything from the medicines that cure us. The foods and drinks we enjoy. The materials we build with, and the energies that power us. There is potential everywhere to make a healthier, cleaner, better world together. Because we know that when we make the invisible visible, we make the impossible possible.
proceed the next scientific session, for which I'm happy to invite Dr. Gajendra Singh, Principal RV College of Nursing, Bengaluru. I request her kindly occupy the chairs. I request her to kindly invite Dr. Lata T. Madam for her deliberations.
Hello. Good afternoon, one and all, esteemed colleagues, delegates, and my dear professional friends from the nursing fraternity in India and abroad. First and foremost, I would like to express my heartfelt thanks to the organizers of Ictahs 2025 for inviting me here. It is a great honor to serve as the chair for this scientific session on recent nursing innovations in translational One Health by our esteemed speaker, Dr. Lata T. Madam. Dr. Lata T. is currently serving as a professor cum principal at the College of Nursing, All India Institute of Medical Sciences, BB Nagar, Hyderabad, Telangana. She is a distinguished academician and a leader in the field of nursing education and research. Dr. Lata brings a wealth of experience and expertise to her role. Her career is marked by a strong commitment to advancing nursing practice through evidence-based education, leadership, and innovation. Throughout her professional journey, Dr. Lata has held various academic and administrative positions, contributing significantly to the curriculum development, faculty development programs, and quality assurance in nursing education. She has also been actively involved in research and has several scholarly publications to her credit, reflecting a deep interest in improving health outcomes throughout the nursing science. Dr. Lata is known for dynamic leadership, mentorship, and dedication into student success. Under her guidance, the College of Nursing at AIIMS, BB Nagar, Telangana had made notable progress in the academic excellence and research. Initiatives, her vision and contributions continue to shape the future of nursing education in India. Welcome to the ICTHS 2025, Madam. Kindly proceed, Madam. All the best.
Thank you, sir. Thanks for that elaborate introduction. And good afternoon to all. I know all are with heavy lunch, very tasty lunch. Probably hyperglycemic minds are going for sleep now. I will try my best to keep you all awake. And at the outset, I would like to thank the organizers for giving me this opportunity. And I'm here for the second time in Dayananda Sagar campus. So I feel like very homely now. So the opinion expressed here are my own, and then based on the evidences and the resources. Though I am involved in some of the funded project, this session has nothing to do with that, and I have no conflict of interest. And I'll take you through few aspects of One Health approach in nursing, of course, introduction, and then what is the One Health approach in zoonotic diseases, and One Health and nursing profession. And these days, you know, AI talks a lot, and what AI does in nursing and One Health, with few of the examples. So as all of us know that human cannot separate from the animal and the environment. Okay? We live with the animal in this beautiful environment. But we have to keep this environment not only beautiful, even healthy. Then only we can live as healthy people. And we also should leave animal to live healthy. So it becomes very difficult for us to take care of the entire animal kingdom as healthy, and then maybe we have to move out from the hospital and then work for the animal. But we should remember that we are with them, we are living with them. Definitely we have to take care of their health, thereby improving our health. So we are dependent with animals in different aspects, maybe sometimes for the food, sometimes for the activities. Directly or indirectly we are related to them. Now vegetarians may claim that I don't need an animal because I don't eat animal, I am a vegetarian, but definitely we are need not only for food, there are many other things we come in contact with the animals as well. So the zoonotic diseases, if you see, it is not something new. Though the One Health concept is slightly a newer concept, but zoonotic disease is not a new concept. So here I have a data which starts from almost 1 century, from 1918 till our COVID, it is given. We had a variety of zoonotic diseases, pandemicity, and we human being exposure to these diseases, and we have lost many of the very beautiful souls with this disease. But later we learned how to cope up with this situation. How can we treat these conditions? How can we prevent it? And the very recent, the huge pandemicity what we had with the COVID-19, it has taught us many things, right? So if you see the list of diseases which we had, it's a huge list. Okay? These are some of the notable ones. This is across the world. If you see what happened in India, this is the data which I got from Ministry of Health and Family Welfare. From 2019 to 2023, if you see, there are a lot of zoonotic diseases again. Though this pie chart gives you that around half of the zoonotic diseases belong to scrub typhus. So you may think that what was happening, all of a sudden why this scrub typhus has increased. There are two hypotheses for this. One is scrub typhus was there, but the detection was not happening so closely. And along with the COVID, and you know that many of the laboratories have improved a lot in India, of course in other countries as well. So since the laboratories have improved, the detection rate also started increasing. That's how we know that scrub typhus is taking 50% of the zoonotic diseases, but nevertheless we have many other conditions also, starting from brucellosis, Japanese encephalitis, leptospirosis, there are many more. So this was already there, and this is the data for last 5 years. Okay? Now, if you see where these zoonotic diseases are common, this is the map. If you see, we have variety of diseases in different places. If you consider like towards the south, we have some pockets like KFD, Kasnur forest disease, which is seen mainly in Karnataka, in some pockets of Karnataka, not in the entire Karnataka also. And I was fortunate to see many of the KFD cases and even have taken care of the KFD cases. So likewise, there are many data you can see in almost all the places. Though we don't see anything in Jammu and Kashmir, don't assume that there are no zoonotic diseases. The data is not available due to various reasons. The data is not available for Jammu and Kashmir, the complete areas, but otherwise you can see a lot of diseases happen. Again, this data is from Ministry of Health and Family Welfare. Now, the emergence, re-emergence of the pathogens. The same examples of COVID, if you take, so we know that this is one of the re-emerging with a different variant. Earlier also we had SARS-CoV, but now it is SARS-CoV-2, so it is we called it as COVID-19. And these diseases are re-emerging. Why it is re-emerging? Maybe viral diseases are coming with a different variants, or it could be because of our lifestyle and we are failing to manage certain things in certain areas. That could be one of the reasons again. And how can we prevent them? And the happy news is that most of them can be preventable. Okay? So how do we prevent? What we should do? So all together those things are included in One Health. So what should we do to prevent? We should have the harmonious relationship with the healthy animals, healthy human, and healthy environment. That's what I said earlier also. So how can we make the animal kingdom healthy? Because we are not coming in contact only with the animals which are near to us. Even for that reason, wild animals are also part of our life, right? So we have wild animals whom we cannot directly take care, of course, and also the environment. How can we take care of the environment which gives me a good health, or a place to have a good health and live in this world? So this, if we are able to manage that with the animals, human and environment, probably 3/4 of our work is done. 3/4 of One Health is already taken care. But how do we do it? Let us see. For this, we should go with the One Health approach. So what should we do? What is the approach we must? It is not specific to any one discipline. We should have multiple disciplines involved here, right? So one is, of course, human health for us. Sometimes I feel that, we are a little selfish because we consider mostly for ourselves, and we called human as having the highest intelligence and so many other things. But did we ever compete with the animals? And who was the umpire who gave us that we are having highest IQs and we are so good, right? We ourselves are telling that. We are the umpires, we are telling ourselves. No animal would have competed with us, of course, for a lighter version of that. But now if you see, along with us, we have to take care of the human health. Probably many of you also have read in the newspapers or would have seen in the television or even mass media, they say what kind of drugs are given to the food which we eat. Like maybe best example is your chicken. I know many of you like chicken. So what and all is added in the chicken? What kind of medicines, antibiotics, the steroids? So we eat it, right? We like different varieties of chicken preparations. Along with that, we are also slowly consuming those drugs, the steroids, and there are many other things. So even if you consider the antibiotic stewardship, antimicrobial stewardship, AMR, that also talks about this animal poultry and then what antibiotics are being used for these different animals, right? So all those, this when we eat, so that covers the animal health and environmental science. So one good thing probably we have observed during the COVID lockdown was that though we all have suffered a lot, probably environment has cherished at that time, right? Our air quality has improved. In many places, air quality was very low earlier. Because of the lockdown, the air quality has improved. And the same way, many things have, some rivers have become very clean, okay? Because we human beings keep, maybe spoiling the rivers, spoiling the landscape, and so many things we did. So during COVID, we gave a time for everybody to recover, right? I'm not telling that we are purposefully doing it. Maybe that's the way we live. And that is necessary for our daily living, so we are doing it. So environmental science is important, public health. So whatever we talk these days, everything is focusing towards the public health. And if public health is taken care, probably the hospitals will have less work to do. And I always say this, we are one of the professionals who earn our daily bread with somebody's suffering. You agree with me? If there are no one to suffer, then we have no earnings. We suffer on somebody's earnings. Somebody's sufferings we are earning. So when we do so, many of us, we consider that is health professionals are angels and we are noble professions. Of course, everything is true. But majority of us are work for the salary, right? We gain our salary or we earn our salary with that. So when we do so, we have to have reduced patient load in the hospital. All of us want reduced patient load, isn't it? That will, of course, reduce our workload. Besides, it will also improve the productivity of the human being. For that, public health is very, very important. So we have to take care of the public and then ecology. So when we consider all these disciplines together, then we are able to control or we are able to have a better approach for One Health. So whether India has taken any initiative, yes, of course, India has taken a lot of initiative in last 15 years. If you see, probably the slide is not visible at the back. If you see in 2009, CDC has established One Health office in India. That is the beginning of One Health we started in India. And from then onwards, we have moved progressively. Though in between COVID was there, but it also helped in establishing India strengthens commitment amid COVID-19 in 2020, and we were so self-sufficient that even we could export vaccine to many other countries, right? We also helped other country people to have the better life or to prevent the COVID to some extent, okay? So India has taken a lot of initiative, our Indian government has taken a lot of initiative to curb lot of zoonotic diseases and improve the One Health concept and One Health as well. So it has three interfaces mainly. One is human and animal interface. How do we interact with human and the animal, and then human and environment, and of course environment and animal. So these three interfaces are important when we talk about One Health. So then what should we do, and what are the few of the examples where we have frequent contact with the animals, or how animal and environment is in contact? If you see, the first one is human and animal interface. We have direct contact with the livestock such as goats, cattle, pigs, and so many animals, and handling pets and dogs at home. We have, I know some of us have pets as even birds, right? And there are many animals also we have, not only the dog and cats, these are very common ones. And then many a time when we play with these pets, not only we, our children, when they play, it's very obvious that we might get some scratches, some bites, and many a time we consider that kuch nahi hoga, ghar ka hi hai. So, but every time it may not be, right? And some of us might immunize these pets, some of us may not. And the very sad part of it these days, we see the stray dogs or street dogs attacking on the children, even up to the death, right? So this is another part where we are encroaching the animals' place and the animals are coming back to us, okay? And then exposure to rodents while cleaning storage rooms or drain cleans or different areas what we do. Not only that, think of our own Bangalore. I know majority of you would from Bangalore only. If there is one heavy rain in Bangalore, what will happen? Half of the Bangalore will stop functioning. And we can see in the mass media's television everywhere, take a bucket and push the water out. So this is the status when we have. Obviously, we come in contact with all these animal wastages also, right? So that is how we would contract the diseases from the animal, and sometimes even we give it to the animal also. The next is human and environment. So living near the stagnant water or mosquito breeding zones, this is very common. We know that, the dengue, malaria, there are many more conditions which actually we are inviting them. If you are able to take care of the mosquito breeding, many of this can be prevented. But sometimes we feel that, yeah, somebody is doing, government is doing, panchayat is doing, municipality is doing, ye mera kaam nahi hai. So when we consider that, or sometimes we think that, okay, I will keep my home or my compound clean and I will not bother what is happening in next to my compound. Sometimes that attitude also some of us would have. So all this will give rise to the breeding of the diseases. Practicing open defecation near riverbanks or fields, but I think these days this has come down drastically. And then exposure to animal waste in wet and during monsoon farming work need not be only during the monsoon farming work, even otherwise also. Take a simple example of your gardening. There is a possibility, if you are not taking care properly, then there is a high possibility that we could get exposed to these muds. And these days, for gardening, we also have indoor gardens. I'm sure many of you would have indoor gardens, and we get everything, ready-made from either from nursery or from gardener, and he will come and give you. You don't know what is the kind of manure he is using, and we use it right on your dining table. You keep 1 or 2 pots, right? And sometimes we keep it in the living hall, we keep it in the bedrooms. So that means slowly we are getting exposed to it. I'm not telling we should not keep it, but we should make sure that it is a healthy condition and we can survive with them. And then we have animal and environment. Yes, they also have close contact like how we have. And there can be different areas where the animal purposefully may not be doing it. We are making the animal wastage getting mixed with the environment, and we come across with that. Maybe a few examples like poory, piggery waste disposal into the open drainage. You would have seen many a time, very unhygienic slaughterhouses. There will be a lot of mosquitoes, and the waste and the blood is flowing just next to the where they're slaughtering areas, and the weak veterinary public health reporting. Sometimes we get to know that, yeah, there is Nipah cases reported, bird flu something, and then many the birds are killed, things like that. But there are many things which are not directly reported actually. Whatever is reported, it is taken care, but how many are actually reporting every time? That is also a matter. Okay? So what is the One Health approach in zoonotic diseases? One is integrated surveillance. We should have a surveillance system, not just a surveillance system for health, but it should be an integrated surveillance system. I'll tell you what is that. And also we should have data sharing, and then joint risk assessment, sustained partnership. So these are important to curb the zoonotic diseases. Yeah, this is one of the surveillance network. This I have taken directly from Sharan et al. It's published in 2023. He also says the same thing. You can see here human, environment and animal. So the ecosystem is between these three. And in between we have the interface, human environment interface, animal environment and the human animal interface. So what are these surveillance? We have to have it. We need data. At the end of the day, we need data for everything, because data helps us to develop the evidence, and the evidence helps us to provide the best care to the public, or to us, or even to the entire population. So the type of infectious pathogen spillover events, it may not be same everywhere. Though there were so many sayings when the COVID started, some people said that it started from China, and then some said it is purposefully given virus, and so many things were there. But then how this has started from spreading from a lab, if it is true, from a lab to the entire world, not only to one particular area, to the entire world, how did it get spread? That was from animal to human, then human to human, then of course environment is also important there. And we have water, soil, climate, and those difficulties also. So when we can take care of these things, excuse me, when we are able to take care of this interface, human, animal, animal and environment and human. If you can take care of this, probably we have answered One Health very well. So when we are trying to answer this One Health, there are few of the examples which I would like to give you along with integration of the AI in it. When I said we need to have the data, data is important. So this AI is helping us even in starting from collection of data to the giving the decision. So I will show you some of the examples. There are a lot of studies going on. I don't know how many of you have taken part or doing the studies or read the studies. There are different studies going on about integration of AI in One Health. I'm very happy to share that our microbiologist in AIIMS Bibinagar has a huge grant, received a huge grant for One Health. It's more than almost 2 crores of grant. And we are also starting a fellowship program in One Health very soon now, along with infectious disease. One is infectious disease and also the fellowship in One Health. So these are some of the initiatives which have been taken by the government. Of course, ours is a government institute. And also I know some of the private institutes also have taken very important role in dealing with One Health and having the better healthy system. Welcome. Yeah, here are some of the examples. I have taken this few of the studies which are done in India and published. So here one, if you see, identifying the high-risk villages in post-monsoon. I am quoting the study as it is because of the space. I haven't given the reference here, but at the end I will show you all the references. Those who are interested can take the picture of that reference and read the entire article. So they have used the component as micro-risk zoning, and the AI technique used is Bayesian network and random forest models. So here what they did, what is the AI enabled innovation is like offline computable mobile risk map using GPS. That means we know that we can collect lot of data when we have the online. It is possible. You feed the data into the app and then somebody sitting at the back end is getting the data and they are able to do the analysis. But here it was done in offline mode. So because you know that when we go to the villages, getting internet is not easy. Sometimes even in our hospital, inside the hospital, we don't get proper internet. How can you expect that to happen in the villages, remote villages, right? So in such cases, it is possible to take it in our offline computable mobile risk using the GPS, and we can see even rainfalls, livestock density, and what are the usual common diseases, etc. So who will collect the data here? Ashas. Ashas will report that, yeah, something is happening in these areas, and the data can be validated by the ANMs who are posted there. Then we have the PHN, public health nurse or CHOs. Of course, there are many other health disciplines involved in it, but for the sake of this presentation, I am limiting myself only to the nursing professions, where nursing profession with the help of AI, how can we tackle the One Health? That is what I wanted to focus. Other professionals, please don't take it in other way that why only nurses are doing, others are not doing it. Yes, all are doing it, but my focus for this next few minutes is only for nursing. Okay? Yeah. So the CHOs, when they get the data, they use the map to prioritize the IECs because they will help in telling that, yeah, this area, this is the education we must give, and this area may be something else, because here one size may not fit everybody. We cannot say that, yeah, this is the IEC material we have prepared and that has to be distributed to the entire India. No, that may not work. Only when there is a necessity, we should do it. The best example I can give you, all of you had a nice lavish lunch now, and if somebody comes and gives you masala dosa, whether you will be able to eat now? No, no, you want masala dosa but not right now. You might say that, yeah, give me after an hour also I can try, or you give me a small piece I can try. So that should not be an case here. Okay? So we should be able to give them what is important in that area and what prophylaxis to be given, what is the outreach efforts to be given. So these aspects can be seen by the CHOs or PHNs. And then next we have identifying the high risk village, I'm sorry with the technical what is happening? Yeah, educate communities and the workers. So we know that whenever we talk about public health, the management or the prevention should start from the grassroots level. Somebody sitting in a higher level in a, complete in a AC room tell that this has to be done, it will not work. Of course, they might guide us, but the work has to happen at the grassroots level. So here they have used the e-lepto modules and where the simulation and e-learning was available and the gamified short videos were given. This was done in Tamil Nadu, so they have done it in Tamil, having the, the very well-known local stories they have utilized, and they found that ASHAs are helping in screen the videos during the self-help group meets. There are a lot of self-help groups like Stri Shakti groups and some other maybe different areas, it will be different names it will be called. So when they have their visits, local visits, though these videos were screened. So based on that, these ANMs will facilitate the group learning during the health days. We observe a lot of health days, so during those days. And then PHN or CHOs will track the uptake, adjust the content as per the outbreak trend and feedback. So sometimes we may have to change the topic, sometimes we have to see what is very prevalent in that area, our focus has to be in that particular aspect. So that is taken care at the higher level. So this is how AI is utilized here. And next, outbreak clusters for combined actions. So here also they have used different AI modules. So the AI modules used were fuzzy clustering and decision tree. You know that decision tree is used in many other cases as well. So here also ASHAs and ANM helps in identifying the families and collecting the data. CHOs or PHNs will help in further processing of that. Okay. So and then tracing the infection source and block the transmission. This is very, very important. Even if there is certain communicable diseases or the zoonotic diseases, that has to be stopped in that particular area and it should not spread beyond that area. So there comes this AI utilization. We can use the logistic trees and source mapping AI. So AI maps animals, contacts and human mobility from patient data. So we were able to get the data and then feed it into the system, and there we will be able to get the analysis and take the decision based on that. Okay, this is another example, seasonal outbreak anticipation. So before something could happen, you can anticipate that what is going to happen. So how can we prevent this? How can we take care of this? So that was also possible with the help of the epidemic forest forecast interface, and then they have used ANN, artificial natural random forest and Bayesian ensemble, and they have taken the data here and finally they executed early warning triggers. They said that this is the area probably this kind of diseases would be seen, so that the preventive action can be taken well ahead of time. Okay. The take home message here is from a distance, the cluster of trees looks like a forest, but when we go, we can see each forest, but forests together make a dense, the trees together make a dense forest. But we should remember that we, being the healthcare professionals, nurses or other healthcare professionals, when we talk about translational of health research, specifically focusing on one health, it must be collecting the data. Without data, nothing works further. So once we collect the data, we have to upload it in different AI tools. There could be different tools. So what is best? Sometimes we may have to develop our own, and then AI will help us in analyzing, and also sometimes it will recommend what to be done. But that has to be reviewed, justified, and if we see that, that is good, once the generation of alerts comes from the AI, then we will be able to verify it, and that helps in guiding the action. So with this, These are the references. If somebody is interested, you can take. These are specifically where nursing professionals are included in One Health with the AI. These 6 studies, what the examples I have given there. Okay? All these articles are freely accessible in India. So with this, I thank my university, my institute giving me permission to be with you, and Dayananda Sagar University, especially Madam Sarkar, for giving me this opportunity, calling me again here and being with you, beautiful audience. Thank you very much.
Here I have some queries, madam, in relevance to One Health.
Yes, sir.
It is a global perspective in health preservation, especially relevance to human environment and animals. But even if there is a disease for an animal in the community, there will be an outbreak of disease. Very recently what has happened, COVID-19 is the best example, and we have a stern warning. So here, nurses in their curriculum, in their practice, at the level of diploma, at the level of BSc nursing, at the level of postgraduate nursing, relevance to epidemic, endemic and pandemic. Shall we have to strengthen the concept of One Health in nursing curriculum? Because your kind self has mentioned ASHA workers and ANMs. ANM program is wiping off in majority of the states. However, ASHA workers are still existing. In future, these responsibilities need to manage by the RNRMs. So what is your opinion, madam?
Yeah, definitely, sir. What is necessity for that particular time, like if you consider for us, our education for India, what is very essential that has to be included in the curriculum. At the same time, we also should remember that the curriculum should not have the elephantiasis. Many a time we keep adding many things and then we don't delete what is obsolete. So that is why we periodically do the curriculum revision. Curriculum revision is very, very essential. When we do the curriculum revision, what is essential for us to include that has to be included, what is not essential that sometimes we may have to delete it. And it is not only everything should be in curriculum. We being seniors are being the teachers, after knowing that this is the present trend, we need not to wait for somebody to include in the curriculum. We can take 1 or 2 hours extra and give the exposure to our students. We will also learn. Of course, Corona, none of us have studied in the syllabus, but we all learnt it. And we have given the education to our children, I mean our students. So it is possible. One is adding in the curriculum, but again, our curriculum revision may not happen very frequently. Actually speaking, the curriculum revision can happen once in 4 years or 5 years, but sometimes you need not to wait till 4 or 5 years. Something which is very much interested, we can include. And some aspects, see Kala Azar, when I was in my previous institute, I was thinking, why should I study this Kala Azar? I haven't seen even a single case in 25 years of my experience. But when I moved to West Bengal, I could see the Kala Azar cases. That's the first time I have seen, though I was in nursing for 25 years, not even a single case, but I have seen it. So that area that may becomes very prevalent. There we have to teach it elaboratively. It's not only the theory class. I used to take the students to clinical and tell them that, yeah, this is the case what is given in your textbook, Park and Park, right? Park and Park is our Bible for community health nursing. So I used to tell them, yeah, see in the actual real life situation. We can include in curriculum, sir. Without curriculum also we can teach it. That's what I wanted to say.
Thank you, madam. The session is open for delegates.
Yes.
If you have any queries, questions, you can put forth to the speaker. Any doubts, any questions, any queries? No one?
No problem. I will be available even downstage. We can have the one-to-one dialogues. I'm available. Thank you.
Really, Madam has enriched our knowledge in what way we have to live in this globe, in this planet, having a concept of One Health. On behalf of everyone, thank you for expertly leading this scientific session to successful end, and special thanks to our speaker Dr. Lata T. Venkatesan for her insightful talk on recent nursing innovations in translational One Health. Her presentation was really enlightening and mindful. She clearly showed how nurses are central to connecting health for people, animal, and our environment. This session did a great job for linking theory with real-world innovative practices. The idea we heard today will definitely influence our work and research moving forward, especially for postgraduate, PhD, and fellowship nurses. This session at ICTAS 25 has left us not just better informed, but truly motivated. Thank you all for a very productive and valuable discussion. Thank you, one and all.
Thank you, madam, for the scientific inputs. I kindly request Dr. Pushpa Sarkar, madam, to hand over the memento and certificate of appreciation to Dr. Lata, madam. Can we have a huge round of applause? Thank you, madam. I also request madam to hand over certificate and memento to Dr. Gajendra Singh, sir. Thank you, madam. Now I request Dr. Komla HK, Principal, BGS Institute of Nursing Sciences, Bengaluru, to kindly occupy the chair and proceed further lecture session. Thank you, madam. I request you to kindly invite Dr. Uma Rani for her deliberation.
Good afternoon to one and all. In today's rapidly evolving healthcare technological and research and technology advancement are growing very fast. Yet, the real problems where we face is the not in generating the knowledge, but in bridging that knowledge to the bedside is very important. So as a nurses, we often encounter with many of the barriers where to integrate the research findings and technologies into practice.
It won't fall.
To give us a thought-provoking session, today we have honored to have with us Dr. Umarani J, Dean, Principal, D.Y. Patil College of Nursing, Kolhapur. Dr. Uma Devi is a distinguished nursing academician and the administrator, having 20 years of experience in nursing education, research and clinical leadership. She had made significant contributions to academic governance, curriculum development and faculty capacity building programs, and also had led numerous research projects on enhancing patients' care quality, caregiver support and community health outcomes. Madam has publications in reputed national and international journals, presentations at academic forums and authorship of educational resources. Madam has received awards for her excellence, leadership and service to the profession. So Madam, we are honored to have you on this session. The platform is open for you, ma'am.
Thank you, ma'am, for the elaborate introduction. Good evening, all of you. So today we are going to see about the overcoming barriers to translating research and technology into nursing. So today's objectives will be elaborating on the common barriers which is hindering the research and technology adoption, and analyzing the organizational, professional and cultural factors which is influencing the uptake, and also I am going to deal about what are the strategies to overcome these barriers. We know the translation of research into nursing practice is very much essential. Why it is essential? Because research and technology enhances the nursing practice. Even though it is enhancing the nursing practice, some of the hindrances are there which is really limiting the integration of research and technology into practice. Hence, we must understand what are all the barriers and we should learn how to overcome all these barriers. So why always we talk about translation? Why the translation is very much essential into the nursing? Because we are all living in the rapid era of technological advancement. We know the nursing stands for its forefront of patient care, that is quality patient care, and we are going into the acquiring of new knowledge, and also we need to implement the research and technology into practice. Hence, the translation is very much important. So how to enhance this translation? What is the need for it? It enhances the patient outcome. How it is enhancing? Whenever any institution which is implementing any intervention to its organization, always when it is backed up with some research evidence, it will give a very fruitful result. Similarly, which increases the efficiency. So how the efficiencies are increasing? Once the nurses are able to implement the research evidence into the practice, which reduces the errors in the care, and also many of the time the nurses are having more free time, they will be able to incorporate and communicate with the directly patient to improve the quality. And also it enhances the professional growth of themselves. whenever they go for innovations, somehow they will be able to have the continuing nursing education where they will be able to update their knowledge and skills. So these are all the key barriers which is existing and which hampers the implementation of the research into practice. So there is a significant gap existing between the knowledge and its application into the practice. Multiple factors are hindering the practice. Why? Because many of the time the organization culture which will not be allowing you to implement, and some of the resource constraints are there in the institution which may also hinder, and over to that the lack of knowledge and skills among the nursing fraternity matters a lot. Coming to the organization culture and resistant to change. In our day-to-day life, whenever we are going to have any change, ultimately our mind will not be accepting for a change. For example, today we are planning to go for a movie as a weekend. So suddenly if any work comes with the spouse or with the children's regular routine, if anything is going to get changed, our mind will not accept. Similarly, whatever is the change, we are going to have it. This is a natural mindset of the people. We will not accept for a change very immediately. Even though the individual and resource limitations are there, because as individuals, they will not have the mindset to adopt the change, and also certain resource limitation. Resource may not be available for us to implement. In spite of that, the culture of the organization, what is existing in the present, we don't want to change, because we are all in the comfort zone. We don't want to come out of the comfort zone, so our mind will not accept for a change. So lack of buy-in. Always, most of the time, the leaders are very much resistant to have a change, because there is a false assumption. They may be thinking these changes, the technological adaptation into practice may increase the workload. This is what they don't want to have a change. And also siloed departments. In terms of the departments, who is isolated or separated, not at all collaborating with any of the other departments. There is no interdisciplinary collaboration happening in the hospitals or any educational institution or any research institution with the IT department, research or clinical departments. That will hamper the integration into practice. And similarly, inadequate support system from the organization in terms of acquiring the resources and facilitating for the training, that also will be the hindrance for the implementation. The next is the resource and infrastructure constraints. Sometimes our young budding nurses may be techno-savvy and they wanted to have so much interest to implement the research into practice and also the technology information into practice. But even though they are very much enthusiastic, sometimes it will be hampered by the practical constraints, especially when the adequate resources are not available, the institution is not supporting with adequate resources and infrastructure, they will not be able to make it. And similarly, what are all the examples of those resources? Financial constraints, because most of the newer equipments are having high cost equipments. So probably the leaders may not be supporting to acquire those, and also shortage of staff. So the nurse-patient ratio in majority of the hospitals are not properly maintained, and having a very little time, the nurses are not able to spend time for learning for the new protocols and integrating the knowledge and research and technology into practice. And most of the time, the outdated infrastructure. You all very well aware, we are all every now and then we are updating our gadgets, like say from mobile phone, laptop or whatever is the any technological instruments, equipments we use to update in our day-to-day life. Similarly, the organization, when they have the existing old IT system, that will not be supporting for the innovative areas. And the next is the limited research awareness. Most of the time, the nurses are busy with their workload and they are not aware about the latest research findings or technological advancement. So without knowing this, they are not able to implement into the practice. And also the insufficient trainings are provided by the institution. Every time all the institutions are not giving adequate training for the nurses to enhance their newer technology. Even with the trainings, adequate trainings are given also, sometimes the nurses may not be having the full confidence to carry out the research findings into the practice. So the evidence-based practice is not happening due to the lack of confidence. So the next area is workload and time limitation. As we all know, most of the institutions are not maintaining the adequate manpower related to patient care. So the nurses are not having interest to spend time for understanding the research. Unless they understand the research, they are not able to implement it. And due to the patient load, the workload is increased, and which also reduces the time for them to go for review of literatures. And due to the administrative task, they are not able to develop their professional standards. And most of the time, the shortage of staff nurses, at last it will end up with the burnout, and also it limits the innovation efforts. Then they are not able to adopt the technology. Why they are not able to adopt the technology? Because they are not having adequate information. The limited digital literacy is there among the nursing fraternity. So it is our duty to make use of all the literature support and increase the digital awareness. And resistant to new electronic system. In the latest HIMS and how to maintain the hospital information, patient information data, they should be given adequate training. And they will assume that may increase the workload of the nurses, so they are not able to show interest. Always they used to resist for the newer technology system. Then over to that, financial constraints for updating the technology. So these are all the key barriers to translate the knowledge and research into practice. Why these barriers should be overcome? Because once we overcome these barriers, we will be having a fruitful, healthier patients, efficient workflow, and more empowered nursing workforce. Unless the barriers are not understandable and not taken any step to overcome these barriers, it will result in poor quality care. So some of the strategies to overcome the barriers. So we need to promote the research culture in the nursing profession, because this research culture will give a deep insight in terms of preventing the disease and promoting the treatment. And we know during the recent technological development, some of the tools which is very much supporting for the translation of technology into practice. So these tools are very much useful in monitoring as well as the procedural accuracy. And what are all the role of our nurse leaders? So as nurse leaders, all should be empowering the nursing practice by promoting the evidence-based culture in the hospitals. So usually in the day-to-day life, when they are going and meeting the people, they have to ask some questions and they should know how this can be implemented, the evidence-based practice, and what are all the behaviors related to EBP practice to be well aware for the leaders, and they have to implement into the unit. And capacity building is another area where they will be able to provide adequate continuing nursing education where it can be promoted to the staffs and which will improve the competency of the staff nurses and develop the competent nurse in the unit. And every time the nurse leader should see whether there are access for the resources for the unit nurses, and also they will be given adequate training to know about the current evidence. And remove all the barriers which is hindering the translation into practice in terms of any policies, guidelines which is not very clear that need to be taken care, and it has to be removed. And sustain the momentum. Why? Because we have to integrate the evidence-based practice so that we will be able to get the adequate quality care. And how to integrate the research and technology. Wherever the institutions which are all integrating the research and technology, they have a very good evidence of improvement in their patient care, and also it shows the nurses are experiencing the high job satisfaction where the technological integration is happening. And some of the areas, example, telehealth integration. The institutions where the telehealth platform is there, through that they are improving the access to the patient care even in the remote setting. And also some of the AI-powered diagnostic tools which enhances the early detection of the condition and which quickens the treatment process so that the patient will be saved and secured. And the other one is evidence-based protocol. As per the EBP practice, some of the protocols like infection control policies and also biomedical waste management all are already existing into practice. So some of the newer evidence-based protocols should be implemented through integrating the research and technology. And next is the improvement of digital competencies among the nurses. So we all know when we are introducing the AI into healthcare setting, most of the time the appropriate information are not reached to all the nursing professions. So we need to give adequate digital literacy to the nursing profession. It should be given with the training how to search the database and how to evaluate the research studies and how to access the evidence-based protocols and practice. And even the information about the clinical technology, especially the HIMS of the hospital, as well as some of the telehealth care platforms and some of the equipments, how to use the smart pumps and etc. And data management, it is very important to improve the competency to how to handle the patient's data. Every nurse should know how to handle the data with the privacy, and they should know how to secure the patient data and when they communicate and how to analyze the patient data, because the patient data, the confidentiality should be maintained. And even whenever they are going for digital communication, they must be given a proper training for how to secure the messages, especially with the virtual teams and also patient engagement tools, how to use those tools during the digital communication. Interdisciplinary collaborations, some of the strategies for the nurses for interdisciplinary collaboration. Whenever there is an opportunity, the nurses should come up and speak up. The clinical observations and evidence-based practice, when they conduct their daily rounds and when they conduct some of the meetings, they should have developed the confidence and they have to give up the clarity and take appropriate decisions. And they must have the professional relationship maintaining power. So they should identify across the department, they must have the working relationship so that they will be able to collaborate with some of the research study, or if they want to conduct any research related or EBP practice related workshop and conferences. So the building relationship, interdisciplinary relationship is very much essential to remove those barriers. And whatever it is, every nursing profession should have the updated knowledge to implement all this technology and research into the practice. Regularly, they should be given access for the reviewing of journals, and they should be given training for attending some of the continuing nursing education program so that they are able to maintain their knowledge updated and be a change event. So champion of change, the nurse should act as a champion of change because the lead or participate in the quality improvement, it will have initiativeness to require across the cross-cultural collaboration. Wherever the collaboration is happening, there the quality of patient care is improved. So research studies shows the collaboration impact where there is evidence 47% of the departments where they have collaborated, they have a reduction in the patient's readmission, as well as where the collaborative departments have quickly adopted the EBP when compared to the departments which is not collaborated with the other department. Similarly, 62% of the nurses, they had high level of job satisfaction when they worked and started the EBP, whereas when compared to the other departments where there is no collaboration happening. And at the same time, 28% of the interdisciplinary collaboration have a highly significant improvement in the patient's safety. So ultimately, the collaboration is very much essential to implement the translation. Promote the robust training, because once the technology is coming into practice, rigorous training is required for the nurses. The hands-on training, especially through the simulation center or any other online modules, the training can be given to equip them with the adequate knowledge and skills. And invest the infrastructure and the resources, because the infrastructure and resources plays a major role. Unless this is invested, we are not able to succeed. So more budget should be allocated for the infrastructure and the resources so that it will facilitate the integration of knowledge, technology and practice, and foster a culture of innovation. So culture of innovation should be implemented within the nursing area, because promoting research culture always value with the continuous learning. So unless the nurses are given a chance for continuous knowledge enhancement and to involve in the innovations, implementation will be a big question mark. And at last, monitoring and evaluation. So monitoring and evaluation also plays a major role. Whatever we want to implement, if we are implementing just like that, we are not monitoring what is the changes happening, what is the output of the change, so it is of no use. So regular monitoring and evaluation is very much essential so that we will be able to measure how the objectives are achieved or not. So this can be achieved through the clinical audits. So clinical audits regularly should be conducted to assess the adherence to the EBB, and also outcome tracking. So we should know how much the intervention is given and what is the outcome of the particular intervention. So longitudinal monitoring of the patient outcome to evaluate what is the impact of that evidence-based intervention in the particular unit. So outcome tracking is the must area. And at last, the feedback from the staff. Even though we are implementing certain things and there may be challenges, so unless we get the feedback from the stakeholders, we will not be able to analyze what are all the changes which is undergone by all the stakeholders to implement. So feedback is very much essential. So regular survey can be conducted among the stakeholders to get the feedback. And some of the area of monitoring and evaluation, what as nurse they have to see. In case of monitoring, we need to know, are we doing what we planned? And also, are the resources are being effectively used or not? Because sometimes we will be getting the new equipments and newer protocols, everything it is in place, but it is not properly utilized. So, regular monitoring is necessary to know whether the particular resource is being used effectively and what are all the adjustments are needed for proper implementation. At the same time, at the end when we evaluate, periodic assessment of the outcome need to be evaluated. So whether we achieved the objectives or not. So what went good and what went wrong need to be assessed. And what are all the things changed as a result of our integration, and was this integration is effective or not. So these are all the areas we need to evaluate to measure the outcome. So both evaluation and monitoring work together to bridge the gap between the knowledge, research and integration into the practice. So to conclude, overcoming these barriers can improve the patient outcome, and also it will enhance the professional and decision making. It strengthens the quality and safety of nursing care. I'm sure by fostering the continuous learning, encouraging the EBP and supporting the adoption of digital innovations, nursing can provide a high quality patient care in today's evolving healthier environment. So the take home message is, from evidence to impact, together we can advance, translate research, elevate the practice and improve the lives of the patient. Thank you. Any questions?
Thank you, ma'am. Now the platform is open for the discussion. Any questions from the delegates? Please, you can put forward. If there are no questions, thank you, ma'am, for the wonderful session. And your session today, it has closely highlighted that it's a challenge as well as it's our responsibility. By addressing these barriers, nurses can empower and nurses can deliver a safer, smarter and better care to the patient. I thank DSU for the opportunity, and also I thank Madam for the wonderful session. Thank you, ma'am.
Thank you, madam, for such informative scientific session. I kindly request Dr. Pushpa Sarkar, madam, to hand over the memento and certificate of appreciation to Dr. Umarani, madam. Thank you, madam. I also request madam to hand over memento and certificate to Dr. Komla.
Dear delegates, we'll have a quick panel discussion and don't get bored and really you'll enjoy it. So please wait for 5 minutes. We'll have just 15 to 20 minutes quick panel discussion which is power packed. So believe me, it's my promise. So after that, quickly we'll finish off the inauguration. After this 15 to 20 minutes of quick panel discussions, right? Bear with me. Good evening. So we came to an end. Before you leave this hall, as I told you, we will feed you with high energy dose of panel discussion. So the topic for the panel discussion is AI-driven translational and technological advances in health sciences. Before that, we have one announcement regarding certificates. We will be sending you the feedback link, thereby QR code is generated. And after completing your feedback, then you can download the attendance certificate from that link. Presentation certificates has been given, participation certificate also given. Only participation of attendance you can download on your own, no need to ask. You are the king of your certificate, so you just submit your feedback. We are seeking the feedback. Just donate feedback for us, earn your certificate. Thank you very much, and be ready for panel discussion. On this case, I invite Dr. Major Guru Prasad sir, moderator for this panel discussion, to please come on to the dais. Dr. Manish Pal, CEO, Microbioma, as one panelist. Professor Sylvian Lehman, Director of the Institute of Neuroscience, Multiply, to the dais. Professor Michael Katz, Clinical Professor from University of Arizona. Once again, the topic is AI-driven translation and technological advances in health sciences, moderated by Dr. Major Guru Prasad Timmaya. Over to you, sir.
Ladies and gentlemen, I think you would have really enjoyed the last 2 days of this scientific, collaborative, translational, transformative, technological extravaganza that we have had.
We have one more panelist, Dr. Lata T. Please come on to the dais.
Wonderful.
Madam, sorry, we couldn't incorporate your photo, but it's okay. Just now you completed a talk. Please. Dr. Lata T. After this, immediately valedictory. So we have a lot of prizes. So please stay back. Don't be in hurry. You have spent 2 days. So we are asking to stay back for 30 minutes. Your valuable 30 minutes. And know whether your presentation could grab the prize or not. Thank you.
So Dr. Lata, very, very warm welcome to you. So we are going to have a very interesting panel discussion which we just put together. And it's all about the buzzword which is AI, artificial intelligence. So I would like to pose one question to all our panelists here. So in your own respective domains, what would be that one translational or technological roadblock which the artificial intelligence, AI, has helped overcome? What would be those roadblocks in your own domains? If you can explain, please. I would request Dr. Sylvian to start off. I want to switch it on.
Very interesting question, in fact. So I'm working in a university hospital, and we are using ER already to collect information from the medical record, and also to help when we have a meeting and interview even with patients, the ER help us to do the record and also the reporting of that. But we don't use ER for prescription or for diagnosis yet. We'll see in the future. And for the research, in research we use a lot ER for big data handling and also to help us to, for reports. But when I ask, for example, ER to write a research project, the structure is good, but what is inside is not good because it's based on all the information. And when you do a research project, you want to focus on a small thing. So it cannot do everything, but definitely it helps us to be more efficient. But to be more efficient, you need to have the knowledge before. And the risk is that, especially for the students, if you rely on the ER to do your job, then we will have a problem, I think.
Thank you. Professor Mike,
thank you.
Your views.
It is a very interesting question, and I'm going to answer it in I guess, two parts, and that's based on different roles that I have as a pharmacy educator and as a pharmacy clinician. So I think as an educator, there's a lot of potential benefits for AI, both from our standpoint as educators, but also from the student standpoint. I have to admit I've used artificial intelligence platforms to help prepare presentations and lectures, and I may be accused of being lazy by doing that, but it is very, very helpful to at least get some basic information. The potential concern, and certainly we tell our students that AI platforms can be great tools to help them in their studies, but they cannot replace what they're doing. So there is that concern, and maybe this is a barrier from the student side or educational side that AI could be used as a way to cheat or to sacrifice academic integrity. So there's that concern. Now, in the healthcare side, there's certainly many potential benefits, and I think using artificial intelligence to gather information, whether it's gathering research evidence or publications regarding some clinical question or analyzing large amounts of data can be very, very helpful. But one of my concerns is that the AI technology today, and I don't think will ever fully replace the human brain, and certainly those of us who work with patients know that patients are very complicated. There's a lot of nuances to patient care, and while AI can be a great tool for us to help make decisions, I think it's we humans, whether it's physicians, nurses, pharmacists, whoever the clinicians are, it's we humans that have to be making those decisions for our patients.
Dr. Paul?
Yeah, thank you, Major Guru. Yeah, I work in anti-infective space, so I can look at the role of AI in three parts, and all of them are a win-win situation. I say win-win because first is when you're inventing a molecule, the journey is anywhere between 10 to 15 years. So you don't have to go for 15 years anymore. So you can do virtual screening of the compounds. You can design the compounds virtually and look at its binding to the target. Everything, maybe we'll reduce it to 4 years. So you're saving 6 years. And second thing is, you don't have to do so many animal experiments and try out everything by yourself in the wet lab. But before you go to these animal experiments, you can always go to AI-based tools and you simulate it. And the PK, PD, everything we can do by simulation and identify the potential properties, and then you verify them. And the third benefit of that I see is sustainability. So in the ecosystem, I think it's less taxing to the entire universe per se when you fast track it, and at the same time, microbes which would take very less time to develop resistance, right? So we don't expose too long to them before we come to that stage. So all these three benefits I see. But the caveat here, there is a danger as well. The danger is our human brains. We may become dumb very soon if we depend too much on that to decide for us. We reduce our thinking. Now what happens when you see an experiment and you look at an outcome, you think, what happened, why it happened? And now that thinking ability will start reducing in us because the machine is giving me ready-made answers. So that's one major caveat I see, otherwise mostly benefits. Thank you.
Wonderful. So AI can really accelerate our natural stupidity, isn't it? So wonderful. Dr. Lata, your views, please.
Yes. An hour ago, I was explaining like how AI can be integrated with the One Health, and that helps in from the grassroots level. Probably I would share one more, our own project. What currently we are doing with AI is that, you know, when we do the patient handover, the shift handover, basically I'm a nurse. So when we do the shift handover from one shift to another, so we are developing an AI-enabled handoff using the S-bar technique. S-bar is like situation, background, assessment, and recommendation. And we know that until and unless we hand over the patient properly to the next, the nurse in charge of that particular patient, some of the information would miss, though everything will be written in the case sheet, but sometimes, you know, in the busy schedule, many a time we have the staff shortages and nurse-patient ratio is not maintained, and there are so many issues why the proper handover is not happening. So we are developing an AI-enabled tool which takes up the S-bar, situation, background, assessment, and recommendation, that helps in, the handoff will become easy, it saves lot of time, and that is how we improve the patient care. So this is what we are currently doing, and in nursing we have wonderful areas where we can include AI and develop many aspects which improves the quality care of the patients. Thank you.
I'll come a little closer to you for the next question. So given that, Dr. Lata, you just highlighted how time-saving artificial intelligence can be. We'll come on to the next question with the AI modules that are getting trained in multimodalities of, let's say, hospital management. It could be nursing management, it could be lab management, it could be radiology. So many aspects of managing a hospital. What could be those ethical considerations that we should be looking at? How careful should we be when we are adapting and adopting AI? Your views on that, please.
Yes. This is one of the worry we have. Even when we started doing a project, the major question raised by the IEC, Institutional Ethics Committee, was that what is the data security? How do you do it? Yes, data security is one of the thing, like, the threat we consider it, but there is, I think today also there is a release of an article which says that how can we have the secure data. I could not read the whole thing, this afternoon only I got it. So it is possible, and we have, CDAC system which is there with the government, the Ministry of Health and Family Welfare has adopted it. So when we include, like we have HMIS, HMIS is taken into this app, and then AI is trained with the dummy data initially, and then we see how it goes. So data security is definitely taken care. That is the major threat. Other than this, I don't see any other major threat until and unless the proper training is given for this AI tool.
Perfect. Perfect. Dr. Paul, your domain, any views on ethical aspects of adapting artificial intelligence?
In my domain, you mean?
Yeah.
I see positive benefits of ethics here because machine does not think beyond what we have fed in. If the information and the guidelines what we give to the machine is the right direction, it will make a decision based on that. At the same time, for AI, to be beneficial to us, it is not the answer that it gives. It's the question, the way we ask it. Otherwise, you know, if it tells you, okay, you cannot dissect this mice, for example. And if I repose the question, I need the mice to be dissected for this result. It says, excellent point. It is better you dissect it and it is going to play with us.
Yeah.
So when it comes to ethics from using AI, you have to be very cautious that you do not make the machine to respond to the way you want to listen to. So I always tell in research, never look for answers. You ask the right questions and look for data. When you look for answers, you're always manipulating because you want what you want to see. When you look at data per se, that is the truth. So seeking the truth when it becomes the driver, I think ethics gets balanced out with your non-interference in AI.
Beautiful. Absolutely.
Thanks.
Dr. Mike.
I'm happy you mentioned that issue of how to ask appropriate questions. I don't know about your social media feeds, but every day I'm seeing on my social media, come sign up for this course on how to ask ChatGPT questions. So, you know, obviously it's an important thing to make sure we're asking the appropriate questions. But I think from an ethical standpoint, I mean, there's all kinds of issues to talk about. Certainly in a patient care setting, patient privacy and privacy of their information is really, really important. And we really have no idea with the AI platforms, you know, how such protected information might be utilized or how whether it would be continued to be protected. So we have to be very, very careful to make sure we're not putting any private protected patient information into an AI platform. But you know, the other issue, of course, is where the AI platforms are getting their information. And I know there's, at least in the United States, there's lawsuits from publishers and others against AI platforms because, in essence, the AI platforms are stealing information, intellectual property from these publications. And I imagine that'll be sorted out in the court, but that's certainly an ethical problem as well.
Professor Lehman?
In addition, one thing that maybe we don't think of is the data that have been used to generate the models. And that's a real issue because depending the data, then you may end up with very ethical problems. Let's say you generate the data on skin cancer on white skin, it will not do the same. And so if you use the AI with not the same context, then you have a problem. And we see that all the time now. I mean, the data that are used to generate the AI model, that's really issue, and then the use of the AI is an issue.
Dr. Mike, how clinically trustworthy is AI? You have been practicing medicine, so your views, please.
Well, my views is sometimes when I have symptoms, I look at, you know, to see. And then you have a list that is often very good because it gives you, by rank, the most likely origin of a disease, of a symptoms. But probably that is not enough. That helps a practitioner, but at the end, the practitioner alone is scoring less than ER, and the practitioner with the ER is scoring good, and the ER alone is practicing better if you consider several thousand people. But on the individual point of view, it's a little bit different.
Thank you.
Yeah, I think it's very clear that it's not completely trustworthy. And you know, the information that you're obtaining, you know, certainly it's related in part to how the question is asked, but you know, the information is not completely trustworthy, and we still need to be a little bit skeptical and make sure we're evaluating that information. And again, certainly if we're using such information to make patient care decisions, we need to be very, very careful. One publication that actually came out of our college very recently, we basically had a contest between our pharmacy students and ChatGPT on how accurately they could answer a series of fairly standard drug information questions. I'm very happy to say that my students won the contest, and we actually published that very, very recently. So at least there was a previous version of ChatGPT that was being assessed, but again, even basic drug information questions, it's not there yet.
I would say there has to be balance, because we have got only X amount of recall power. Just before examinations, we study, revise so that we can recall properly just for the sake of exams. But if I have to recall a clinical case, how do I make a diagnosis? I will be able to recall only based on my experience and what I could, which I'm currently involved in. So adopting AI to do that background work, and the way, again, it comes back to asking the question. I would always add a line there stating that from a peer-reviewed resource. If you add that, then it goes to those database and pulls up the information from the literature. So you get to see if some similar case was handled elsewhere, how did they treat the patient? That information is going to pull out and give an interpretation to you. Then you look at your clinical diagnosis. What does the clinical picture look like to you? Is the clinical picture matching with what it is showing? If it is not, then you got to stop it and then go and do your own research. If there is a match, then bingo, you're in the game. You know how to take the case forward. So that's the way I would incorporate clinical utilization.
I'll ask you one more follow-up question. You have been the person behind India's first drug discovery, which has gone global.
Yes.
I'm pretty sure it has been a very painstaking journey, bringing a molecule right from the drug discovery stage, preclinical stages, and finally moving it into the market has its own time frame. You have touched upon that. It almost sometimes takes up to 20 years.
18 years.
18 years, there you go. So, given now the propulsion of AI, which aspects of these trials or drug discovery, from discovery to go to market, where exactly do you think AI can come in and help us give a trustworthy, safe and efficacious drug?
I think I partially answered this question when you asked me the first time. So first is target identification. So you could see when we do not have AI, what happens is we go and search through PubMed or one of those databases and try to find information and make our own interpretation. So the way we assimilate the information is directly proportional to my analytical ability rather than the actual deep analytical power. My analytical power may be very different than yours, and yours or yours. So that limitation is excluded here. So the machine does that analysis, so it's much deeper. And based on that information, I can take the next step. So the drug discovery, the first phase is immediately shrunk. And then clinical trials, safety, we do a lot of off-target testing to see whether it is hitting any other target other than where I'm aiming it at, right? In spite of that, have I missed something? I may not know. So if I deploy AI and ask the right question, okay, the target is penicillin binding protein 2 in the bacteria, which is gram-negatively stained, and which other targets can it hit in the human cell? Or which other target cells, which are the microbiota in my body, it can hit? So it can do that. None of us look for microbiota impact. So it can do that analysis and tell me, okay, if you do this, maybe your Akkermansia will come down or Lactobacillus reuteri may come down. So that will help me to see, okay, I got to again optimize the drug. Normally in drug discovery, once you have a molecule, we optimize the lead and then bring in the drug-like characteristics. Now in drug-like characteristics, we never look at what impact it has on the largest invisible organ of the body, which is your microbiome. So that information it can do much better and show us. So it will help in every stage to shrink the time and have a better, more efficacious and more safer drug for human use. That would be my utilization.
Wonderful, wonderful. Thank you. Ma'am, clinical trustworthiness of artificial intelligence. Your quick views on that. Any views? Are we really ready to adapt AI?
Yes. When I have a expert, AI stalwart sitting next to me and giving a promising result, definitely I can't say no to it. Of course, we are taking an infancy step, and I feel a ray of hope. And ultimately, I feel that, to improve the quality of the patient care, whether it is AI, technology, until and unless we are not harming the patient community, I'm okay with it, and we welcome those AI-enabled patient care devices and the tools, decision makings, improvised care, definitely yes.
Wonderful. What could be those safeguard mechanisms that one should look at while embracing AI? We did touch upon the ethical aspects, but we do also know that there are several AI models that are available in the market which do hallucinate, which give out things that which are not well researched. It's all about prompt engineering. So when it comes to either the predictive nature of AI or when it comes to adapting it to a prescriptive pattern, what are the safeguards that we should generally look at?
Yeah, I feel we should not be like completely dependent on it, and still they are in the, at least in my field, it is still in the testing stage. And we have all the possibilities of improvising it and not becoming dependency, and multiple areas tested and given a certification that yes, we can go ahead, then it is fine. Till then we should, though everybody says it is good, as a nursing expert, I feel yes, we need to test it and then approve it, then embrace it. Till then it is still in a stage of testing. Yeah, thank you.
Dr. Mike, your views on some of the safeguards as clinicians when we are really moving ahead in terms of adopting AI, please.
Yeah, and I'll answer that again from the point of view of patient care. And as you were answering your question, I was thinking back to when I was training 100 and something years ago. And this is when calculators were first starting to become used. And everybody was in a panic that, well, we can't use calculators because we won't know if the answer is right. And if we're applying that to, say, some patient care decision, then we can't trust it. So interesting that question about safety of technology is not a new question, and I think the safeguards, number one, has to be a human has to be involved, and while hope it's still science fiction that we don't want to have computers making the ultimate decisions for our patients, and again use them as a tool. And we need to make sure we train our students and all the students out there today and all of you who are educators so that they know what's reasonable for a patient. So if we're asking an AI platform some question, is the response within the realm of reasonableness? If it's not, then perhaps it can't be trusted, and have those safeguards, just like in the hospital with things like smart pumps that we use to infuse medications, we build in the safeguards so that we can't exceed doses, so that we can protect the patient's safety. So I think it's sort of the same attitude.
Professor Lemon, your views?
I think we need to know the limit of the system and how to use it. It's like a tool, like a hammer. It's maybe dangerous. So, but what is a little strange is that when you ask a question, you realize that when you ask twice the question, the answer is not the same quite often because the way it's constructed. And that's an issue for us for certification.
Thank you. Do we have any questions from the audience, please? Any questions? Yes, please come to the mic.
A very good evening, sir. Actually, my question is related to, for example,
please introduce yourself.
I'm Dr. Vidya Nair. I'm a PhD scholar. I'm from JSS College of Pharmacy, Mysuru. So my question to you is, sir, that whatever information where we give to AI, though that information comes from us, humans. It's not coming from somewhere outer space. It's what we give. So now when we make a mistake or we make an error in the system while giving the information to AI, it might give results which might not be true. So how do you expect to, how do you overcome such things? Like what are your strategies that you hold on to overcome this sort of loss of data integrity?
Who would like to take that? So predominantly, I think she's asking about the prompts, the prompt engineering and the safeguards thereof.
That's a very good question, and that's a very genuine doubt anybody should have. So if you recall the question he asked about how do I use it clinically, right? I said, it'll give the information based on what you have fed in. But it can give you information from a broader network of resources than you could reach yourself in that given short period of time. See, if you have to go through like a million publications and come to a conclusion, it will take a month or two for you. But AI would do it in maybe 5 minutes, right? So it synthesizes the information, but then you have to do your own self-interpretation. And to answer the question on the genuinity of the data, now you have to give the right question to it. I told you already, get from a peer-reviewed sources. When I say peer-reviewed, it's though you have published, submit a paper, there are at least 3 to 4 scientists who have evaluated and said, okay, this data looks good. There is nothing called perfection in this. You can never be perfect. Because data is also, by nature of data, it evolves itself also. What you see today, tomorrow if I find some newer information, I am going to change the information as well. But AI will look at both the information and give an interpretation. That is where your personal discretion comes into play, which is based on the situation, customized situation. So that balance 15%, we always say standard error of 15% is allowed. You must play your mind in the 15% to solve that doubt what you may get every time you see that.
I think it's even our responsibility as healthcare professionals or people in healthcare field that we make sure that we give a very right information that is accurate. Maybe later that could be used. So I guess it's responsibility of all of us. The very reason for asking this is currently in pharmacovigilance, if you see, we are taking the data only when the reaction occurs. We're not taking the data of the people who might have taken the same drug but did not get the reaction. So in that matter, like, of course there is loss of data integrity, and because of which later AI might not be able to give the exact information, will not have a perfect comparator to state whether why the reaction has happened. Okay, thank you, sir.
Good one.
Okay. Do we have any other questions? Okay. All right. So thank you very much. I would really express my heartfelt gratitude and thanks to all our panelists today for coming here and enlightening us on the importance and the way we are going to adopt AI into the future. So thank you very much. Thank you very much for your kind participation. Thank you.
Before moving forward for valedictory, let's watch the journey of ICTHS 2025. It may not be a refined video, but we just captured the small moments, how we started, how we traveled, and how we are today. Yes, can we play the journey of ICTHS 2025? Yeah, please. Good to go? Play.
A very good evening, one and all. I am Ms. Shalini from College of Nursing Sciences.
And I am Dr. Faber Roy from College of Physiotherapy.
It is our privilege to welcome you all for the valedictory ceremony of ICTHS 2025. Over the past 2 days, ICTHS has truly stood out as confluence of innovation, skill development, and interdisciplinary learning. We witnessed 8 cutting-edge workshops spanning various disciplines of health sciences, offering hands-on learning and enriching practical exposure. Our scientific sessions were equally inspiring, bringing together eminent speakers, researchers, and delegates who shared groundbreaking ideas and perspectives, pushing forward the frontiers of healthcare and technology.
Indeed, Ms. Shalini, these 2 days have been a remarkable journey filled with knowledge exchange, collaboration, and scientific enthusiasm. We extend our heartfelt appreciation to all the participants, organizers, speakers, and guests who made ICTAHS a resounding success. Before we proceed further, let us begin this ceremony while seeking the blessings of the Almighty.
I now invite Ms. Samiksha and Ms. Maulya from Department of Physiotherapy to lead us in a soulful invocation song.
ಶರಣು ನಿನಗೆ ಶರಣು ವಿನಾಯಕ ಶರಣು ನಿನಗೆ ಶರಣು ವಿನಾಯಕ ವಿನಾಯಕ ವಿದ್ಯಾದಾಯಕ ದೇವ ವಿನಾಯಕ ವಿದ್ಯಾದಾಯಕ ದೇವ ಶರಣು ನಿನಗೆ ಶರಣು ವಿನಾಯಕ ಶರಣು ನಿನಗೆ ಶರಣು ಪಾಶಾಂಕುಶಧರ ಮೂಷಿಕ ವಾಹನ ಸರ್ಪಾಲಂಕೃತನೇ ಗಜಾನನ ಪಾಶಾಂಕುಶಧರ ಮೂಷಿಕ ವಾಹನ ಸರ್ಪಾಲಂಕೃತನೇ ಗಜಾನನ ಆದಿಪೂಜಿತ ನೀನು ವೇದವತಿತ ನೀನು ಆದಿಪೂಜಿತ ನೀನು ವೇದವತಿತ ನೀನು ಮೋದಕ ಪ್ರಿಯ ನೀನು ಗಣನಾಯಕ ಶರಣು ನಿನಗೆ ಶರಣು ವಿನಾಯಕ ಶರಣು ನಿನಗೆ ಶರಣು ವಿನಾಯಕ ವಿನಾಯಕ ವಿದ್ಯಾದಾಯಕ ದೇವ ವಿನಾಯಕ ವಿದ್ಯಾದಾಯಕ ದೇವ ಶರಣು ನಿನಗೆ ಶರಣು ವಿನಾಯಕ ಶರಣು ನಿನಗೆ ಶರಣು
Thank you, Ms. Samiksha and Ms. Maulya, for that beautiful and uplifting rendition. With that divine beginning, we shall officially commence the program.
Now, I would like to request our honorable dignitaries to take on the dais. I would like to invite Dr. Lingegowda, Dr. Manish Paul, Dr. Pushpa Sarkar, Dr. Guru Prasad, and Dr. Vijay Kumar.
It is now my privilege to invite Dr. Mayur Vaisi, Principal, College of Pharmacy, Dayananda Sagar University, to deliver the welcome address.
Good evening. So, on this auspicious occasion of the ICTHS conference, which has come to an end, and on this occasion, I want to invite the dignitaries on the dais and of the dais. Our Honorable Chief Guest, Dr. K.B. Lingegowda, Honorable Vice Chancellor, Shri Siddharth Medical College, Tumkur. Sir, I welcome you. Another guest of, I request our chair and convener of the conference to welcome the chief guest. Our guest of honor, Dr. Manish Paul, CEO of Microbiome Private Limited. Sir, I welcome you. The chair and convener of the ICTHS conference, Dr. Pushpa Sarkar, Dean, School of Health Sciences, I welcome. Dr. Guru Prasad, Deputy Medical Superintendent of CD Saima, I welcome you, sir. And Dr. Vijay Kumar, the Honorable, who was the Secretary of the ICTHS conference, I welcome you all. So, I also welcome all the co-conveners, conference delegates, researchers, faculty members, students who have made this conference a great success. So, as we gather to celebrate this conclusion of the ICTHS Conference 2025, I'm honored to address this esteemed assembly. We have witnessed and engaged in vibrant, intelligent, and deeply meaningful exchanges of ideas, innovations, research findings in the health sector. This conference not only brought together scientific minds across the globe, but also inspired renewed purpose and collaboration as I centered the bridge between industry and academia, fostering partnerships, and will drive future innovations. And I once again welcome you all, and I hope you had a great stay here. Thank you.
Thank you, sir, for your warm and encouraging words. To present a brief overview of the workshops, sessions, participation, and the scientific highlights of ICTHS 2025, may I now invite our convener, Dr. Vijay Kumar, to deliver the event report. I welcome you, sir.
Honorable Chief Guest of the Day, Dr. Lingegowda, sir. Guest of honor, Dr. Manish Paul, sir. Conference Chair, Dr. Pushpa Sarkar, ma'am. And our own Deputy Superintendent of our hospital and today's moderator for the panelist, Guru Prasad, sir. Students, faculty, delegates, exhibitors, press and media. At the outset, I would like to place on the conference report of 3 days International Conference on Translational and Technological Advances in Health Sciences. Before reading out the report, this 3 days conference has a 3-fold months of preparation. We have started the preparation for this conference on January 21st. January 21st was our first meeting to conduct this conference. With that, 2 months pre-production things we did, and from April we started our website, and we started the registration by April 15th. Initially, there was a lot of assumptions, presumptions, and we scared of to put 2,600. We started with 3,000, came down to 2,000, but I have marked at 2,600. So all these lot of debates, whether the registration fees will be suitable or not, people will come or not. We are away from the city, what to do? With all these misconfusions or doubts, etc. and etc., there was only one pillar and one force which driven us to witness such an international conference which has a global perspective and pulled out the registration across the country. The force is one and only Dr. Pushpa Sarkar, the conference chair. Because she is the facilitator for us from the management. We are very grateful to Dayananda Sagar University management, Chancellor, Pro-Chancellor, Registrar, because our idea is big, thought is big. We are thinking extraordinary. So I always believe extraordinary work or extraordinary results definitely seeks extraordinary efforts, extraordinary execution. I believe that's what we did. So with this conference has got 1,430 registrations across the globe, right? We started aiming 1,000, but we have ended up with 1,430 registrations and abstracts. So we have received 500 abstracts. Among that, 465 abstracts are selected for poster and oral presentations. Among that, poster presentations are 377 and oral presentation 288. This is one of the record in India. No conference in southern part of India has crossed 250 abstracts. So I congratulate and thank all the participants who have submitted your abstract and who presented your papers at this conference. We had 30 plus lectures. Among that, 12 international talks are there. And the conference was started with the keynote address by Dr. Vedprakash Mishra, a renowned medical person who worked in MCI, and there is no person who doesn't know Vedprakash Mishra. Then this platform and this conference is fortunate enough to have such an eminent person as our keynote speaker. And in the inauguration, we had Health Minister of Karnataka, Shri Dinesh Gundu sir, and the presence was there with all the different vice chancellors from the various universities, former vice chancellors from the various universities, and the inaugural gallery was very grand, and we have ended up with very good inauguration. And we had heard to the words of wisdom from Dinesh Gundu ji, Dr. Bhagavan sir from Vice Chancellor Rajiv University Health Sciences, M.A. Shekhar sir, former Vice Chancellor Aditya University, and Sachidanand sir, former Vice Chancellor Rajiv Gandhi University of Health Sciences. And we have started with the sessions. So we had main hall and 4 parallel halls. So we have divided all the 30 talks in the main hall and 4 parallel halls. And the whole program was live streaming on YouTube. And this particular conference is funded with a grant of 5 lakhs from Department of Biotechnology, Government of India. I am proud to say this, and congratulations to Dr. Prashant Tiwari, so who earned this. Congratulations, and thank you very much, sir, for your support towards this conference. And we had the participants from 14 different states of India and speaker from 6 different countries other than India. And we had first day pre-conference workshop, 8 pre-conference workshop we had conducted with 14 resource persons and 400 plus participants. And this is again a record. Any other international or national conference doesn't conduct 8 international workshops, that too with the 400 plus participants. We achieved it, sir. So I am proud as a convener to tell you that we had achieved a figure of 400 where the other conferences are difficult to reach 400. We reached it only in the pre-conference. So we are proud, and I am proud of my team. And other than this, we have different plenaries, scientific lectures we have, and poster presentation, oral presentations. And we have a list of sponsors, right? I'll come to that again. But I would like to mention the fuel, means the energy we got from few sponsors. First and foremost, we have Vantage Properties, Shri Raghavendra ji. Thank you very much for your support in the initial levels. Vantage Properties, our platinum sponsors for the day, for this conference. And Malvan and Emil is one of the silver sponsors. And our own Sagar Hospitals is one of the silver sponsors. And down the lines, you have a big list of sponsors who are behind this conference. So with this, I conclude the conference report, and we would like to come again and again for now and for 3 days for 2025. This report is by Dr. V.K., convener of ICTHS 2025, signing off.
Thank you, Dr. Vijay Kumar, for the wonderful summary. It's now an honor to invite the chief guest for today's valedictory function, Dr. K.B. Lingegowda, Honorable Vice Chancellor of Shri Siddhartha Academy of Higher Education. Dr. Lingegowda is an eminent clinician with expertise in oncology and palliative medicine, and a respected academic leader known for his contribution to healthcare and education. Sir, we request you to kindly address the gathering. Thank you.
Good evening, everybody. Namaste. Namaste. Your Dean Madam told me that you are tired of listening to any lectures. I'll just speak for next 30 minutes. You guys have become silent, don't worry. I'll just take 4.5 minutes. I know several faces here, and myself and Madam Pushpa Sarkar, when we were working in Rajiv Gandhi Health University, in fact, probably Lakshmanavari Gottirbeku, that was the first time we encouraged all the disciplines like nursing, AHS, physiotherapy, pharmacy, Ayush. In fact, right now I am the national president of NAPCAM, National Association of Palliative Care for Ayush and Integrative Medicine. The problem with you guys, you always think that you are second-rate citizens other than doctors. Though I am from medical doctor, we should feel that in giving health care, everybody is important. My friends from France and USA, they're laughing because there nobody will address either say madam or sir. And there is so much scope for you people, especially from AHS. And now Dr. Pushpa Sarkar was telling that the best paper goes to Allied Health Sciences person and first year MBBS student. Scope is too much, I'll tell you. And especially you aim right now start getting involved in the research work. Whether you score 95% or 80%, gold medal, nothing matters. Ultimately, it is your paperwork, publications, research matters when you want to enter to any of the best institutions. My daughter, who is pursuing a master's in public health in Johns Hopkins University in USA, she says, in fact, she was our student in Siddhartha institutions, how much important it is for any paper publications. I'll tell you, majority of you who are pursuing your either nursing or AHS or pharmacy or physiotherapy, you're all from either middle or lower socio-economical background. Never feel that you are from low background. In fact, I have traveled from much lower background than you guys from a village. I have reached this stage because of hard work. And people will help you. You collect the email IDs of our friends from USA, pursue with them, just be in touch with them. They will help you to get posted in their university to pursue your PhD. Madam, I am happy that at least PhD work is being encouraged to the maximum extent here in Dayananda Sagar. In fact, our Honorable Chancellor, the present Home Minister, he was prizing this particular campus so much. And Vijay Kumar, your madam is telling that in another 10 years, this Dayananda Sagar will become the best campus in the entire country, she is telling. That is the confidence we have. Madam, we will always there be with you.
And I'm happy that I have joined for this program. And I'm already dreaming that we should conduct similar kind of program by asking Dr. Pushpa Sarkar to be the advisor. Ultimately, I'm happy that at least for this valedictory program, so many of you are here. Usually, not many people will be there for the valedictory program inauguration. It's a different issue, unlike your people from France or USA. But here, we have got a lot of people. And when you achieve something, when you go and pursue your PhD, in fact, we are encouraging PhD work in my university. A lot of people with allied health sciences, they have registered to do their PhD. In one of the meetings in University Grants Commission last month, they were telling that in USA, there are about 2% of the total populations have done PhD. But here, unfortunately, in a country like India, only 0.2%, which is very less. So all of you aim to pursue your higher studies, whether it is master's or PhD or going abroad or going placed in the better universities, you will definitely have a big scope. And especially when you attend this kind of programs, and it is amazing for me to know that there are 1,400 registrations. And this kind of interaction with other specialties will definitely take you to the newer heights. I wish you all the best. And I will take Madam as our advisor for the next conference in 2026 in my university. And if anybody happens to pass Tumkur, please visit. In fact, you were telling that he is from Tumkur, my colleague. I wish you all the best. Jai Dayananda Sagar. Thank you.
Thank you, sir. It is now our privilege to invite the guest of honor for today's valedictory function, Dr. Manish Paul, CEO, Vicrovima Private Limited, to address the gathering.
Ellarigu namaskara. Namaskara. Okay, there is still energy. That's nice to hear that. Respected dignitaries on the dais and off the dais. I think this has been an amazing conference for the last 3 days. I was here for the first day, of course, at the pre-conference workshop. When I look at the kind of topics you guys have all participated in, is amazing. What I would like to leave with you as we come to the conclusion of this is, though the valedictory of the conference, it is the beginning of the collaborations. I saw the last presentation, which was made here, and it was talking a lot on collaborations. I think what we have to do going forward after this conference is take one line of learning and reach out to one person whom you did not know before and start networking. Networking within the campus of your own campuses, outside the campuses, and outside the institutions or around the world. Because when you start collaborating, your ideas multiply. This is a translational, in the sense what you have learned, you have to translate, right? So now, as is the theme, I would encourage each and every one of us who are gathered here and who have already left and who would probably get an opportunity to see it on the recordings which the conference would do, to see how each and every one of us can take this collaboration forward. So when the next conference happens, I'm sure Dr. Pushpa would arrange the next conference maybe next year or so. If you guys come back, you should be proud to say that in the previous conference, we made this collaboration and we did this project and we have done this. You can come and present a poster. Are we with this? Anybody willing to collaborate and bring back next year? Yeah, there are a few hands at least. That's good. And those who haven't heard, please make sure you all come back with more collaborations. Wishing you all the very best. Thank you very much.
Thank you so much, sir, for your inspiring and insightful address. We shall now proceed to the prize distribution ceremony. I invite Dr. Vanaja, Professor and HOD of Pharmacy Practice, Department of Pharmacy, College of Pharmacy, to take over this segment and honor the outstanding achievers of ICTHS 2025.
Good evening, one and all. Before I go to announce the prize winners, firstly, I would like to invite all my team members to stand along with me because they have worked with me untiringly for last 2 months. Please join. So, our team comprised of members from CD Cymer, the medical faculty, from the College of Physiotherapy, College of Nursing, College of Pharmacy, and Allied Health Sciences. So, as our convener already said, we had received overall 500 abstracts, which underwent a scrutiny among the internal faculty and some experts from outside DSU also. So we selected 465 abstracts. Among them, 377 were poster presentations and 88 were oral presentations. So we had 16 tracks from different disciplines of medicine, physiotherapy, pharmacy, nursing, and allied health sciences. So we have prizes distributing to all the faculty, from all the discipline. But the appreciation here is, we have the prize winners from a faculty of medicine or a faculty of allied sciences receiving in the discipline of medicine. So the participants have truly achieved a translational approach in receiving the prize. So I now call upon the first segment, that is the poster presentations. So under the medical faculty, we had 4 tracks. And the first prize goes to Harshita Bai from the College of Nursing, Devraj Aris College of Nursing. Harshita, I kindly request the chief guest and the dignitaries on the dais to join for the prize distribution. All of you please give a big round of applause and please keep cheering our achievers. The second prize goes to Dr. Vaibhav Sabu from Mandya Institute of Medical Sciences. Anybody else from Mandya Institute of Medical Sciences could come and collect the prize. Okay, so we move on to the next track, which was from the Faculty of Pharmacy. So the second prize goes to Dr. Gopinath from Vivipuram Institute of Pharmaceutical Sciences, Bangalore. The first prize goes to Mr. Kirtiraj from JSS College of Pharmacy, Mysore. I kindly request the audience to keep cheering our achievers again. second prize from the discipline of physiotherapy goes to Mr. Subhash from Dayananda Sagar University. Any other student from College of Physiotherapy could come and collect the prize? In physiotherapy goes to Dr. Manish Nayak from KMC Manipal. Next, we move on to the Faculty of Nursing. So the second prize goes to Mrs. Sarita from Devraj Aras College of Nursing, Kolar. Anybody from Devraj Aras College of Nursing? So the first prize goes to Dr. Cyrus Paul Isaac from Atal Bihari Vajpayee Medical College and Research. So actually the first prize in medical faculty went to a nursing student, and the first prize under the nursing faculty went to a medicine student. So congratulations. Anybody from Atal Bihari Vajpayee Medical College and Research? Okay, so next we come to the oral presentations. So among the 88 oral presenters in the track 1 to 4 under the medical faculty, the second prize goes to Dr. Peru Rupesh from the School of Physiotherapy, a PhD scholar. Vistas. And the first prize goes to Dr. Geeta Anjali from Mandya Medical College, Mandya. Okay. Next we move on to the pharmacy. So we have Dr. Aruna from JSS Dental College. So we can just see here that it's completely translational. We are having different participants from different colleges. The first prize in oral goes to Mr. Timmaya, PhD scholar, Adi Chunchaniri College of Pharmacy. Moving on to the physiotherapy, the second prize goes to Mrs. Subra Basu from the College of Physiotherapy, Pharmacopoeia University. Goes to Dr. Nice Mathur from College of Physiotherapy, MS Ramaiah University. Dr. Nice Mathur is from Acharya College, not from MS Ramaiah. Next, moving on to the nursing faculty, the second prize goes to Ms. Komakula Santoshi from AIMS Mangalagiri. And the first prize goes to Dr. Shalini Ganesh from Manipal College of Nursing. Okay, so with this, we finish the prize distribution of the oral and poster presenters. Next, since we had a great number of abstracts, we appreciate all the participants who came and presented here. So we decided to have a memorial award. Actually, it is in my father's name, Shri Kenchappa Memorial Award. So we have constituted 2 prizes for the overall best oral presentation of ICTHS 2025, which goes to Ms. Ananya Shri from Allied Health Sciences, JSS Academy of Higher Education, Mysore. Yeah, Ananya Shri is from the poster section.
The award is in the commemoration of Mr. Kenchappa, Professor Vanija Madam's father's. Thank you, Dr. Vanija.
See, just look at this. Out of 465, 88 were oral presentations. The rest were poster presentations, including all the health sciences. medical, pharmacy, physiotherapy, among all the posters, this is the best poster award won by an allied health science student of JSS. Right? Among 300 plus posters, she's got this. Please give a big round of applause for her, please. And this award is sponsored by Dr. Vanaja in commemoration of her father, Mr. Kenchappa.
Next, the best overall oral presentation goes to Mr. Kushal Nagesh Gowda, Medicine, first year from CD Saimar.
We would like to add few sentences for how we chose this award because it was a little challenging for us. This award goes to Mr. Kushal Nagesh. He is the first year MBBS student from CD Saima. So we had to do a lot of scrutiny to evaluate the prize selection. So we did, after having the evaluation from the judges, we did a plagiarism check, we did a AI check. After that, we sent it to our always supportive Dr. Manish Paul sir to select the overall oral presentation. So among all these scrutiny, Mr. Kushal from first year MBBS, we were very impressed because he has done a lot of work, maybe practically 122 skulls he has used to do his study, and he is just passed out from first year MBBS. So we are very proud and we appreciate his efforts and hope he continues this success in his life. So I kindly request somebody from CD Saima, else we have sir here to collect. Okay. His mentor is Dr. Shauri from CD Saima. Thank you one and all, and I really thank all the participants for their cooperation in coming here and presenting the posters and the oral presentations, and hope we have many more during the next conference at DSU.
Thank you, Dr. Vanaja, and congratulations to all the awardees.
Now, we would like to call upon the sponsors who have been a great part of our conference and felicitate them. The gold sponsor for our conference is Vintage. Platinum sponsor is Vintage. Vintage Properties. Shri Raghavendra sir.
Thank you so much, sir.
The silver sponsor goes to Ayman. Thank you, sir. Now we have our silver sponsor, Malvern. The first silver sponsor, Malvern. Thank you, sir. Now we have our second silver sponsor, Sagar Hospitals.
Now I request the other sponsors to collect the certificates from the dignitaries. If you are there, please be fast. First, Avenida. Avenida. Medilab India. If representatives also, you can come. Shri Book World. Shri Book World. Platinum Biomedics and Surgicals. Platinum Biomedics and Surgicals. R2 Global Healthcare. R2 Global Healthcare. Nursing Next Live. If anyone from Nursing Next Live. Loban Meditech. Anyone from Loban Meditech? Midovation INC. Scientific Enterprises. Yashaswini Surgicals. CBS Publishers. Yes. So all these sponsors will get the certificates by post since they are not there today. Thank you very much.
Thank you, sir. Now we move to the felicitation of our chief guest, Dr. K.B. Lingagowda. Now I request Dr. Pushpa Sarkar, Dean of School Health Sciences, to felicitate Dr. Linge Gowda. Dr. Linge Gowda currently serves as the Vice Chancellor at Shri Siddhartha Academy of Higher Education. He has previously served as the Director of Kidwai Memorial Institute of Oncology and a Registrar at RGUHS. We are deeply honored to have you, sir.
We are also immensely privileged to felicitate our guest of honor. Now I request Dr. Pushpa Sarkar, Dean, School of Health Sciences, to felicitate Dr. Manish Paul as CEO, Microbioma Private Limited. Dr. Manish Paul is globally respected scientist, entrepreneur and techno-commercial expert with over 3 decades of experience in anti-infectives, microbiology, R&D and One Health. We are honored to felicitate him today. Thank you, sir.
As we approach the end of this wonderful event, it is time to acknowledge the efforts behind its success. May I now invite Dr. Guru Prasad, Deputy Medical Superintendent, CD Saimer, to deliver the vote of thanks.
Ladies and gentlemen, every great conference ends with 2 things. One is the clarity of thought, and then the clarity of purpose. And ICTHS 2025 Sorry about that. So I would request A1 Shads, A1 Logics. Anybody from A1 Logics? I think they have contributed immensely to this conference. Do we have anybody from A1 Logics here? Is there? Please come. Please come. Collect your memento. Thank you very much for your contribution. Round of applause for Even Logics, please. Can I call upon somebody from SHADS? SHADS. Thank you. Thank you so much. All right. Welcome. Okay, so I was just mentioning to you that any conference ends with two good things. One is the clarity of thought and the continuity of purpose, and ICTHS 2025 has gifted us both of these things in large abundance. So for the past 3 days, what I have witnessed is that this campus has not just been a venue, it's been transformed into a laboratory of ideas, a marketplace of knowledge, and a meeting ground for innovation. And see, this has shown us when science speaks, progress listens. And when collaboration happens, transformation begins. So, respected dignitaries, esteemed speakers, distinguished delegates, my dear staff, faculty, students, namaskaram. It gives me great joy, and it's a very distinguished honor for me to deliver this valedictory note, this vote of thanks, on behalf of the Dayananda Sagar University and the team ICTHS 2025. This conference is absolutely special, and I would like to first pay a very special tribute to our chief guest, Dr. Linge Gowda, who is the Honorable Vice Chancellor of Siddhartha Academy of Higher Education. Sir, your presence today has added immense depth to this valedictory function. Your distinguished career, your contributions in the field of academics, in the field of research are absolutely noteworthy. It speaks volumes about your leadership. So thank you so much. So your address was not just a speech, it was like a spark for all of us. We are truly honored to have you with us today. Thank you so much for your time. He has come all the way from Tumkur, beating a lot of traffic. Incredible. Thank you so much. Thank you so much, sir. And of course, our guest of honor today, Dr. Manish Paul. I mean, I was so overjoyed to meet him today and have that conversation. He has done so much. He has walked many walks of life. He has had such a wonderful journey. His contribution to this country is immeasurable. He has let go, he has sacrificed some of the best of careers, right from FDAs, and sacrificing all of that and coming here to India to innovate our first molecule, which has gone global today. That is Dr. Manish Paul. Simplicity, humility personified. Thank you so much. Thank you so much for your presence here today. I would like to salute the architects of this international conference, which speaks about technology, which speaks about translation in health sciences, the architects. Pushpa madam. Ma'am, this is your brainchild. It's your vision, your energy, it's your leadership that has ensured that this conference just didn't happen. It happened with excellence. You dreamed big and you executed it bigger. So, in fact, setting forth many, many records in the way, as our dear organizing secretary Vijay Kumar was just mentioning. It's truly incredible. This deserves a huge round of applause. There is a saying, and it's my favorite. It's a hitopadesha. Udyame naiva siddhyanti karyani na manorathe nahi suptasya singhasya pravishyanti mukhe mrugaha. Udyama, industriousness, karya, effort. Nahi suptasya singhasya. You wouldn't have ever seen or heard of a deer walking into a lion's mouth, a lazy lion's mouth, just to satiate its hunger. A lion has to be on top of his game, has to be on the hunt, has to have that winning ability all the time, not just to survive, but to succeed. And that is the winning combination that we see here. So it's always about efforts. The aspirations of the mind can never be fulfilled without commensurate efforts. And we see that happening here in front of all of us. So thank you, Pushpa madam. And I would like to congratulate our secretary, organizing secretary, Dr. Vijay Kumar. What he has done is absolutely, it's called execution excellence. You know, something which is there in the visionary's mind, you put it across with absolute excellence. That is Vijay Kumar. We didn't even hear, it was like a well-oiled engine which ran so smoothly over the last 3 days and brought it to fruition. Dr. Vijay Kumar, thank you, thank you, thank you. And to the entire organizing committee, you have done a brilliant, brilliant job. And this is what happens when dedication meets teamwork. Excellence becomes inevitable. So I also extend my profound gratitude to our leadership and the Governing Council of Dayananda Sagar University, our Honorable Pro-Chancellor, Dr. Premchandra Sagar, our Honorable Chancellor, Dr. Hemachandra Sagar, our Honorable Vice Chancellor, Dr. Satyanarayana, our Honorable Registrar, Dr. Puttamadappa, Mr. Galiswamy, our Secretary of the MGVP Trust, and the entire leadership. I think it's absolutely their unwavering support which is the backbone of anything that we do here. We are very, very grateful to the leadership who dreams big, and that is what makes our institutions grow higher, and this conference is an epitome of that. Thank you very much for that. Thank you. My sincere appreciation to all our invited experts and speakers from across the globe. You have come all the way to be here with us, taken so much of pains. Humble, humble gratitude to each one of you. Thank you so much for that. All your scholarly presentations, your thought-provoking lectures, it has kindled a lot of hope in all of us and made this conference truly international. So thank you very much for this. And I would also like to thank our session chairs, our moderators, our paper presenters, our poster presenters, in such thick competition that happened today. So you all kept that academic flame alive. Thank you very much for that. And very, very grateful to each one of you delegates and participants. You have been here all through these 3 days, and I'm pretty sure you would have picked up so many wonderful transformational things that you would take it forward all through your life. Thank you for your participation. Special acknowledgement to all our sponsors and funding agencies. Firstly, the Department of Biotech, Government of India, our platinum sponsor, Vantage Point Property, silver sponsors, Sagar Hospitals, Malvern Panalytical, RTWO Global Healthcare, Platinum Biomedics and Surgicals, Medovation, Shri Book World, CPSPD, NNL1, Vijay Instruments, Avenida, Medilab India, and Loban Meditech. We are very, very grateful to each one of you for supporting innovation in health sciences and this conference. A huge shout out to all our unsung heroes. You made this entire conference run so smoothly. To all our administrative staff, our tech staff, our IT staff, our facilities, security, food and beverages, and of course, our very energetic student volunteers. I mean, you kept smiling through this conference, you kept the energy alive. Kudos to each one of you. Kudos to each one of you. You made this happen. We are very, very grateful to all of you. Very grateful. And any person whom I might have missed acknowledging, please pardon us. We are very grateful to all of you. So with that, I think we'll come to the end of this wonderful congregation of professionals. This, I think, it's more like a spirit of unity that we saw in this congregation, this academic excellence, all the researchers coming together, each one of you coming together with this spirit for this maiden conference. So it's not just the closing. I believe it's going to be the beginning of another transformation which is going to happen from our campus. So thank you so much. Thank you all. Travel safe, stay safe, all the very best. Jai Hind.
Before leaving the hall, I think, Guru, it's ready? So we'll display a QR. I just wanted to show how to download the certificates before going. So display. So you can scan, from there also you can scan and you can download the certificate. Since it is live, so the participants who attended this conference can scan this and the link is shared in the group also. So by scanning, you can submit the feedback. Once you submit the feedback, only your certificate will be downloaded. Please note this, right? Once you submit your feedback button, then only you can generate the certificate. So please scan this and generate the certificate. Thank you very much. Good day once again. Bye-bye.
Thank you, sir, for your heartfelt words of appreciation. Ladies and gentlemen, we now request everyone to kindly rise for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
We call all the organizing committee members to come on the stage for a photograph. The organizers of the conference, I request you all to please come on the stage for a photograph. All the committee members, the stage committee, discipline committee, hospitality. We request all the committees to come on the stage for a photo session.
With this, we formally conclude the valedictory ceremony of Ictahs 2025.
Thank you all for your participation, enthusiasm and support.
We wish you continued growth, inspiration and success. Have a wonderful evening. Thank you all.
I should mention few names. For everyone, it is a special thanks. But few names I have to mention who worked a lot. From sponsorships part, Dr. Rajiv and Dr. Prashant Tiwari have supported. Transport and accommodation has did a wonderful job, Dr. Vinod and team. And after you, sir, so Dr. Pramod, he did a relentless job. Dr. Vanaja and team, exceptional contribution. Thank you, ma'am. And the stage committee, food committee, and the rest, all the committees, you have given wonderful support for this conference. Thank you very much. I request our speakers also to join us, please. Please, sir.